Okay,
अभी
okay.
थिएटर में भी आना है.
Let us start your marathon, yaar.
So, Dinesh ji,
Dinesh,
1 second, I will tell you. 1 second.
you give me the countdown, please.
Dinesh, this exercise you should have done earlier. This is not done. Already it is 4:10.
4:10 now.
Yes, sir. You are live. You can start.
Yeah. Good evening, all. Good evening once again. My heartiest welcome from Sun Pharma on behalf of Sun Pharma Pharmacare Division to this webinar. This is our 14th series in our series in live surgical demonstration in the series of Explore the ENTs, Explore the Legends of ENT. So once again, my heartiest welcome to all of you. And today we have again galaxy of stars from different fields as well. We have Dr. Philip Panikar from Cochin. Heartiest welcome to you, sir. Dr. Pankaj Gupta from Jaipur, neurosurgeon. Heartiest welcome to you, sir. Again, we have our own close friends, Dr. Bumkar from Mumbai, Dr. Aparao from Vizag. And this is going to be the very live and very interesting session. Who will make this as a very, very prominent and significant for all of us. It is none other than Dr. Satish Jain, our legend. Welcome, sir. Welcome to you, sir. And the man who made this series of webinar, which is 14th one, which has become possible for Sun Pharma in exploring the ENTs and webinars as well from our side. So it is Dr. Rajiv Pachori. Thanks to you, sir, and welcome to you. And our moderator, Dr. Parmita Saha. So once again, my heartiest welcome to all of you on behalf of Sun Pharma Pharmacare Division. This is Mahendra Varman from Pharmacare Division, GM Pharmacare, who is dealing with Cipodem, Recipar, and Montec FX. Thank you once again, and without taking much time, then I will hand over the session to Dr. Rajiv Pachori. Thank you.
Good evening, all my friends. Again, thanks to Sun Pharma and team for doing making this event a great going event of this lockdown period, or in fact, I would say this 2020 time. So again, today this is 14th webinar on the live surgical, and today we have come with the acoustic neuroma, glomus, jugular, and lots of discussion. It is dream of every ENT surgeon to at least come near to this step of the surgery, like going in the skull base, going in the lateral skull base, going into the intracranial part, and the one of this is acoustic neuroma, this transverse approach. So I think all the ENTs who are seeing it and all the neurosurgeons who are seeing it, for the ENTs, it is just because this doing acoustic neuroma today is not because everybody can go for this thing. You have to learn from basics to advanced one, and that is we have come across in last 13 episodes that from basics we have started now up to the acoustic neuroma. So just try it and see it, and in the future you all can do this surgery with support of neurosurgeon, and with them making a team of neurosurgeon, yourself and all the friends. So, and glomus jugular we already seen, but today we have different case. So I will welcome Dr. Philip Panikar, Dr. Pankaj Gupta, Dr. Aparao, Dr. Bumkar, Dr. Paramita is also there, and again Sun Pharma for making this event a very successful. So over to Dr. Satish, something, and thank you for all.
Good evening, everyone. Welcome once again to our webinar. Today we have interesting cases lined up by Dr. Satish Jain, sir. Acoustic neuroma and glomus jugulare, and as Rajiv Pachori sir said that it's a dream of every ENT surgeon to know these steps, know the surgery at least close to it. So I think sir is known to make the most difficult surgery easy by step-by-step approach for all of us. And to all the viewers who are watching, you can ask as many questions as you want, and we can put forth these questions, and we can have a good discussion today on these topics. So I'll come to Satish Jain, sir. Good evening, sir.
Good evening, Paramita. Thank you, Rajiv boss, and thanks Sun Pharma for again making this happen. So today, good afternoon everyone, is a big day for us on this advances in lateral skull base surgery, and we are pleased to have some important guests with us who are going to enlighten us with their experience today. So first of all, I welcome Dr. Dilip Panikar from Cochin. For everyone, he is a very senior neurosurgeon attached to the Esther Medicity Hospital in Cochin, and he had been earlier the professor and head of the prestigious Amrita Institute of Medical Sciences in Cochin. He has been the past president of Skull-Based Surgery Society of India. His experience is amazing, particularly in the field of the surgery of vestibular schwannoma. And today he is going to be with us to enlighten us with his comments, his expertise, and we have a lot of people here online and we can ask questions as well. Thank you, sir, for being with us. Then we have our own Professor Pankaj Gupta. To me, he is like elder brother, you know. He is one of the men who is instrumental in my, my growth in skull-based surgery. I remember my times. He has been senior to me during my college days. Then he joined neurosurgery. He became, when he left SMS, he was professor of neurosurgery at SMS Medical College. Then finally he joined the Mahatma Gandhi Medical College and heading the unit there. We have worked together, done hundreds of cases together, and the way he has, given me confidence is something I can never forget in my life. When you work at the skull base, you are always surrounded by fear of complications, particularly intracranial complications, and we all know it's a teamwork. And when you have a person like neurosurgeon, like your friend, who can teach you each and everything with his hands, that this is what something, how to be managed in case go wrong, anything goes wrong, how you can manage those things. So that kind of confidence has been given to me by him, and I am always indebted to him. Thank you, boss, and thank you once again for coming to this webinar today, and I am sure he is going to join us in theatre as well later on. Thank you. So we have, I can see on screen, Dr. Apparao.
Hey.
Hi, man. Young man. Again, he is 63-year-old young man. He is a committed lateral skull-based surgeon, and we have been together in many of the, it was 20 years back when we used to go together for many of the workshops. Appa, thank you. And I came to know recently you have come back from US. You were stuck there 3 months during lockdown.
4 months. 4 months.
Oh my God. Welcome back. Thank you, and many more guests are going to join us, and you can see Ashish Bhumkar, our Master Blaster, the microtia surgeon, is a complete otologist, I call him, from external to inner ear, and thank you Ashish for again being with us. I can see Movani sir online. Sir, hello, good afternoon.
Good afternoon.
Oh, nice to hear from you. Last time you had some technical issues.
There is a light on his head, emitting from his head. See that?
Get the light off.
Sun is rising from there.
Okay, sun is rising.
I will take you to one of the slides. Can you connect? Can you connect, please? When we talk of lateral skull-based surgery, do you see slides on the screen?
Yes, sir. Yes, we can.
This lateral skull-based surgery, these are the people who have done phenomenal work in this field. I have gone through many of their publications, the kind of work they have done, the way they have devoted their life to this field of lateral skull-based surgery. We all know them, Professor William House, Hugo Fish, Brackman, and this, I call him as a father of modern lateral skull-based surgery, Professor Mario Sana, whom I call nothing less than phenomenal, who has devoted more than 40 years of his life to develop this science of lateral skull-based surgery, and we have got opportunity to learn from him very closely many times in India and PHNJ as well. So we are indebted to Professor Mario Sana, and I dedicate this day to Professor Mario Sana for his teachings, what he has taught all over in the world. Many of the, probably if I am not wrong, majority of the lateral skull-based surgeons, dedicated lateral skull-based surgeons, are his students who have learned from Mario Sana and spreading this science everywhere in the world. Thank you, Professor Mario Sana, for doing all this for everyone, for this mankind. And then Professor Morwani, we all know in our country the way he is spreaded and done this phenomenal work in lateral skull base surgery in our country, and we have always learned from him, and everybody and many of people are opted their career in lateral skull base surgery because of sir. Thank you, sir, for being with us today, and I'm sure today again will be a lot of learning from you. Thank you.
Satish, Dr. Paramita has also been to Mario Sana, no?
Yeah. Paramita has done fellowship at Mario's place, and Mario had a great praise for her. It is rare to see some Indian on the Otolaryngology website on the front page with Paramita. We are proud of her, and she is dedicated to lateral skull base surgery. I have, these days a lot of interaction with her, and she has sound knowledge in lateral skull base surgery and reading more and more about it. Thank you, Paramita, and I am sure Paramita will come up with good questions today and good discussion.
We will have a good discussion today, yes.
Yes, can you connect this? So, today's, when you come to the today's session, Panikar sir, please feel free to interrupt me anytime. Pankaj boss, everybody, so that we can ensure more and more interaction. Please. So, about today's case is a 30-year-old male who presented with a hearing loss 6 months back, and that was, according to him, was all of a sudden. Though sudden sensory neural hearing loss definition and the happening in the vestibular schwannomas is more with the small tumors. So this man realized hearing loss 6 months back, no history of tinnitus, no facial palsy, no other symptom at all. And when he got scan done is what in front of you. So we all know when it comes to cerebellopontine angle, CP angle, the majority of the lesions are vestibular schwannomas. We call acoustic neuroma more commonly, is a more popular name, but vestibular schwannoma is more appropriate name as it arises from the Schwann cells of the nerve sheath of the vestibular nerve. So the appropriate term is vestibular schwannoma. So once it is diagnosed, we are going to discuss today a lot of intricacies about decision making and need of surgery, observation and other things in detail. Before that, I will take you through certain radiological features of this patient and what all need to be seen in radiology and what radiology is required for that matter. So this patient has a CP angle lesion as diagnosed on the contrast MRI. He was, yes, please.
Had this patient presented to you 6 months back?
Not really.
No. Had he presented, would you have done this imaging?
Yes, 100%. So that's what, once you suspect, if you go to the guideline by the Congress of Neurological Surgeons, that evidence-based guidelines, according to them, any patient who has an interoral difference of more than 15 dB on two frequencies is an indication of MRI. And that is how you can pick up small lesions, and nowadays more and more small lesions are being picked up. A lot of people tell that our country has very less vestibular schwannoma. It's not less. It's not matter of less. We are not getting imaging done so often for many of the unilateral, pathologies of the ear, like unilateral tinnitus, sensory neural hearing loss, vertigo. All those need to be imaged with MRI overall. So, according to that guidelines, anybody having more than 15 dB interoral difference should be imaged with MRI to rule out such lesions. So that's how this contrast MRI is the primary investigation to pick up this small lesion. Even we can pick up to 3 mm acoustic neuroma with a good gadolinium enhanced MRI. So the first investigation of choice is the MRI, and that is gadolinium enhanced MRI, and that is what I am putting forward to you. So what all MRI sequence is important? Number one, this is a very important sequence known as 3D CIS, constructive interference in steady state image. 3D CIS image, there is three-dimensional image which I am going to reconstruct, and this is a dynamic. I always mention, once you come to the scan, you must have a dynamic imaging, and that's how we see through this software on DICOM on our computer. So what you need to see in vestibular schwannomas on MRI, we want lot of information. First of all, we want to have information about the size of the tumor. We want to see whether there are cystic component. You see in this tumor, there are two big cysts. Can you see?
Yes, sir.
The cystic component is considered to be unfavorable as far as the surgical management of vestibular schwannoma is concerned, particularly if the cysts are in the periphery, as proposed by Professor Mario Sana in his classification. If the cysts are peripheral, yes.
See, this patient had a sudden sensitivity loss because suddenly he had a cystic degeneration.
Yes, yes, enlarge in size. Yes, that's how.
That's how he got a sudden loss.
Yeah.
Otherwise, he wouldn't have sudden loss.
Yes.
Sometimes you can get a hemorrhage inside, but cystic degeneration is much more common than the bleeding inside the acoustic neuron.
Yes, that is how he presented with sudden enlargement in size because of the cystic degeneration.
Second point, Satish.
Yes.
If the cyst is intratumoral loaded over your part, when the cyst is a margin, then it's more difficult to
That's what I am coming to, sir. Your point is valid. The problem is once you are dealing with the surgical part and cyst is in the periphery, where it may be in interface with the facial nerve or the brain stem anywhere, with a thin wall cyst, sometimes it is difficult to separate, or if you try to, you may end up injuring the facial nerve, some vessel or brain stem or whatever it is in contact with. So you have to be very careful, and it is always wise in those difficult situations to leave a part of tumor attached to it. Leave a part of tumor attached to it, capsule attached to it.
Yes.
So what we need to know from imaging, we need to know what kind of tumor it is. We need to know the consistency of the tumor, and here this is a two big cysts in the tumor and rest of the tumor is firm. Why am I saying firm? This is heavily T2 weighted image with a hyperdensity showing the firmness of the tumor. This tumor is firm. Now what else you need to see out of it? Now if I keep the contrast image together, you will have a very good idea how these tumors take contrast enhancement. See, there are many tumors in the CT angle. You need to differentiate pre-operatively whether it is vestibular schwannoma or something else, because there are many tumors which look unlike vestibular schwannoma and we never take a biopsy. We have to plan our final approach only on the basis of radiological features. Maybe we are operating, we have to operate on the basis of the radiology rather than taking a pre-operative biopsy. So there could be many tumors like meningioma, could be lipoma, could be epidermoid. There are many common lesions in the CP angle. Out of them 80% are vestibular schwannomas, and they have certain radiological features which are characteristic of vestibular schwannoma. So like these tumor, if you see, I will show the T1 image, they are mostly hypodense. On T2, they are generally hyperintense. There could be cystic generation, here predominantly cystic generation, but the most important feature is they enhance on contrast administration, gadolinium administration, and that is classical of these tumors, and they have a component going into the intra-aortic meatus. See this tumor passing to the intra-aortic meatus? Can you see?
I think that would be the most important criteria of diagnosis that you will
Yes. Yes, intracanaliculaar component, because they have a tendency to arise from the junction of Schwann cell, peripheral Schwann cell to central oligodendrocyte. That's how these tumors arise. Mostly they arise in the either in the intra-aortic meatus or sometime at the level of the porus. So this is a classical feature. You need to confirm whether it is going inside the canalicular or no, and once it goes, it is quite diagnostic of vestibular schwannoma. If compared to the other lesions in the CP angle, why it is not meningioma? The simple is meningioma are never like this. They are eccentric to the intra-aortic meatus. They are more broad based. They generally do not enter the intra-aortic meatus, and they have calcification, enhancement and other features, and dural tail, the enhancement of the adjoining dura, which is classical of meningioma. Then somebody may ask why it is not epidermoid. Epidermoids do not enhance on contrast. They are simple cholesteatomas. So that's how you can differentially diagnose on the basis of MRI that what exactly it is. Now once it is a vestibular schwannoma in your mind, what all you need to see on MRI? I have lot of things which I can pick up from MRI, and those are surgically relevant. Like for example, I want to see the exact size of the tumor, which has lot of prognostic implication. Bigger the size of the tumor, difficult is to protect the function like hearing or facial nerve. That is most important. Like for this tumor, if I want to measure in the highest dimension, greatest dimension, see this tumor, this is roughly 3 centimeter by 3 centimeter in dimension. I will show in the other dimension, superior, inferior as well. By and large, less than 3 centimeter in one dimension. So this is a tumor. Will show the classification system, lot of classification system existing, but this is moderately advanced tumor with roughly close to 3 centimeter in dimension, in all dimension. Number one, that is what we want to see on MRI. Other thing what we want to see on MRI is the extension of the lesion. See how it is compressing the brain stem. Can you see the normal brain, the bones here, the brain stem? Can you see the compression of the brain stem by the medial part of the tumor? This tumor has not only gone in the CP angle. Yeah, it is this, it is, obliterating the fourth ventricle lateral part as well. It is, displacing this, what is this? This is the middle cerebellar peduncle. It is displacing, compressing this. To me, it is a little advanced tumor, 3B. I will show the classification system we follow. So that is what we want to know, whether it is compressing on the brainstem, number one. Number two, and the most important feature as far as the planning the approach and hearing preservation is concerned, how much it is extending into the intra-auditory meatus. See this on the 3D CIS image. See this tumor which is hypodense on T2 weighted, and how laterally it is extending into the intra-auditory meatus till here. Can you see? Lateral to this is the CSF. That means this tumor is not reaching to the fundus of the intra-auditory meatus, and that is a, yes, not only facial now, this tumor is big. Had this been a small tumor, we would try even for the hearing preservation had the hearing been good. So, yes, because those tumors which extend far laterally to the fundus are difficult to be tackled by the hearing preservation approaches with this much of, the metal, this cysternal component. With this 3 centimeter cysternal component going by the retrosigmoid and going far laterally, the tumor going far laterally to the fundus, it is difficult to remove completely, and if you try to, you can end up very closely damaging the hearing system. Yes, sir.
On what you are looking for. Now, what you say is absolutely true. The retrosigmoid approach works very, very well when you have a more medially located tumor, or a tumor that does not reach the internal acoustic canal. The more laterally the tumor goes, removal by retrosigmoid route is perfectly feasible, but then you will have to drill the posterior lip more extensively. So that is the one thing that has to be kept in mind. The drilling of the posterior lip of the canal is what gives you the access to the internal acoustic meatus, and if that is done well, that is theoretically possible to reach the lateral end. The other way to do it, as some surgeons have described, is to drill part of it, but not go all the way to the very end, but also to use an endoscope.
That's right. Now, endoscope has become a very good tool for every skull-based surgery. And
Sir, can I make a point, sir, here?
Every surgery, practically, endoscope is the biggest tool now.
Sir, can I make a point here?
Please.
Like Panikkar has said, it is very right that you can drill the part of the posterior canal wall medially to reach the tumor laterally. But there are a lot of studies done, there are a lot of calculations. If you try to more laterally, you may endanger the hearing by means of damaging the hearing system. That the most medial part is the endolymphatic system. So it is difficult to predict that how close you are to the endolymphatic system. By and large, in the studies done, by and large, up to 5 millimeter you can open the canal medial. Beyond that, if you try to go, you may be very close to. Now, like you said, the endoscope. If the tumor is not reaching to the fundus, right to the fundus, still you can remove with the endoscope with your instrument. But if it goes right to the fundus, that is a very, very narrow area, and if we try to remove the tumor from there, we can end up, damaging the nerve, which is our goal. So it is, that's why this approach is amazing. Retrosigmoid is the best and the fastest of approach and most commonly used by the neurosurgeon. There are certain limitations where particularly tumor goes far laterally into the canal. We'll discuss all these approaches in detail. Yes, sir. Yes.
Let me point it out.
Yes.
Let me point out one thing. Panikar, when you drill more of the posterior canal, these are the people you are going to expose more cells of the mastoidal system. And these people have more chance of CSF leak in the mastoid. Do you agree with me?
Yeah, I think, see, the one thing is whatever approach you do, whether you're doing a retrosigmoid, I mean, one has to be very, very familiar with the anatomy in that particular patient. So proper reading of the scan is absolutely essential, because the more you read the scan, the more you know your anatomy and the more you begin to anticipate what you
Yes, exactly. Yes, sir.
So encountering mastoid air cells is not a problem at all, as long as you know that you are going to encounter mastoid air cells. You can always seal them. The problem
Yes.
is when you encounter them and
I want to emphasize on the seating. I want to emphasize on the seating.
Sir, we'll come to that part later. Let us finish the imaging first.
Yeah, okay, fair enough.
Okay, so what all we need to see on MRI? Like I said, the cystic part in the tumor. This is very important, like you mentioned in the beginning. If cysts are in the periphery, then preservation of the critical structure becomes difficult. So what you can see here, now see this tumor. Let me start from above downwards. See the tumor, there is a tumor periphery all the way around the cyst. Can you see?
Yes, sir.
Thick tumor around the cyst. So these are thick walled cysts, you can say. They are two cysts but thick walled all the way from above downwards. See this. That is what you need to see. Number 3. Now what else you need to see here? The relationship with the surrounding cranial nerves. Let me show you from top to bottom for everyone. That is why this dynamic imaging is so important. Now I am coming from above downwards. See this. Now the first structure you can see now. Can you see here this now? That is the 5th cranial nerve. The thickest of all cranial nerve. Can you see all?
Yes, yes.
This is 5th cranial nerve on the top. Now as I go down, can you see this thin cranial nerve which is coming?
Yes, yes.
This is the 6th cranial nerve abducent. What we saw here about that 5th cranial nerve, it is in contact with the tumor, the superior part of the tumor. I am going from above downward. This is the vital information. Why I am saying vital? See, this superior part of the tumor is in contact with the trigeminal nerve, but the important thing is no cyst wall is in contact. It is the solid portion of the tumor which is in contact, which will help us separating in the arachnoid plane this part of the tumor from the nerves. Number 1. Then the 6th cranial nerve we have seen. This is the 6th cranial nerve, and as we go down, see, this is the 9th cranial nerve. That is in contact. Now, if you really want to see these nerves better in the upside down position, I can reconstruct it to a 3D image. 3D image will tell you exactly which part of the nerve is in contact with the tumor. This information is so vital surgically when you are operating on this tumor. See this. This is the 5th cranial nerve. I will take my cursor on the 5th to show you how the 5th cranial nerve is. This is the 5th cranial nerve going. This is the 5th cranial nerve coming, and here is the beginning of the tumor. This cranial nerve is right on the top of the tumor. This is in complete contact with the tumor. Number 1. Similarly, the 9th which is below, but the most important nerve we need to know about is the facial. How the facial is in relation with the tumor, and it is very difficult to know from a regular MRI. Nowadays, the sequence, the MRI imaging which gives you exact information of the tumor, the facial nerve relationship, is the diffusion tensor imaging. It's not available everywhere. Diffusion tensor imaging can give you exact idea how the nerve is in relation to the tumor. You know, out of the 4 cranial nerves in the intra-aortic meatus, the facial is anterosuperiorly. This tumor is arising from the nerves behind, those are vestibular nerves. So what generally happens to occur? When the tumor grows, it pushes the facial nerve anteriorly. If it is arising from the inferior vestibular, the facial will be pushed anterosuperiorly. If it is arising from the superior vestibular, then the facial nerve will be pushed anteriorly. How you can get to know? What I mean to say, like if I draw a line to show you how the facial nerve is going to go. You know, see this, the facial nerve coming from here, it is tilted by the tumor like this going to the brainstem. See what I am trying to say? Facial nerve which generally comes like this to the brainstem, it is pushed anteriorly by the tumor, and that is how the facial nerve is stretched. That is how it has become, sometimes become so thin ribbon like fibers. In larger tumors, difficult to say the facial nerve. So here, what we want to know radiologically, that what is the anterior extension of the tumor from the intra-aortic meatus. And there are lots of studies done. I tell you, if the tumor, this is the line of the intra-aortic meatus. More the tumor. See now how much the facial nerve is stretched. If I measure how much of the facial nerve is stretched, see this. This is important to know, because surgically you need to have a full three-dimensional idea that where exactly you are working. So my facial nerve is roughly more than a centimeter here, pushed anteriorly by the tumor, anterior bulge of the facial nerve because of the tumor. That is what we want to know. Now exactly how the facial nerve is, again I want to know whether my facial nerve is in contact with the cyst wall or not. How do we get to know? In 3D imaging. Let me show you very clear. See this. In 3D imaging, these are the nerves. See, I take on axial on my nerves and I'll pick up the sagittal. It's simple. See now. Now these are the nerves in the intra-aortic meatus. Can you see now? In the sagittal plane. This is cochlea, where the cochlear nerve is going. See this? And if I am going, see, these are the nerves going to the cerebellum. These are the now how they are arising and coming here. We can get to know exactly. See, this is the facial nerve. This is the dot of the facial nerve I can see here, and this is the tumor. And what part of the tumor it is? The solid part of the tumor. So my facial nerve here is in contact with the solid part of the tumor. This is facial nerve and it is in contact with the solid part, not the cystic part of the tumor. Otherwise the facial nerve preservation would have been very, very difficult, or you rather leave up a small part of the tumor along with the nerve to save the nerve. That is one of the strategy you can make. So this is all need to be seen on MRI again. Imaging is so important. Now to see the enhancement pattern of the tumor. Some tumors are very hypervascular, and those are more difficult tumors in terms of preservation of the function. That you can get to know on the gadolinium enhanced imaging. Now another thing to predict, there are many sequences on MRI. We should take the full advantage of MRI in this era of technology. MRI can give you a lot of information. You know, prognostically, this is a very special image. This is 3D flare image. For this tumor it is not so important. Why? In a small tumor, when you plan your hearing preservation surgery, you know, sometimes it is not possible. Many times it is possible. You can prognosticate to certain extent, and this is how MRI works here. See, this is 3D flare image. Look at the cochlea and vestibule on the other side, they are not visible. See, on normal 3D flare, they are not visible, the fluid is not visible. But here on this side, this is markedly prominent. In a small tumor, if this is small intracanalicular tumor, and if you find such changes in the cochlear fluid on 3D flare, that is highly predictive of non-preservation of the hearing. That means the cochlear fluid has already got proteinaceous material because of the compression of the cochlear nerve, and if you try to preserve the hearing, it is unlikely, very unlikely that you are able to preserve the hearing overall. So there are certain things you can predict.
You will be, it is difficult to preserve the serviceable hearing.
Yes, hearing, yes sir. Yes. Yeah, so whenever we talk about the hearing, this is something very important point sir has raised. We'll discuss this a little later. What exactly the meaning of hearing we are talking about. It's not a pure tone audiometry we are talking about. We are talking about the serviceable hearing. That is demonstrated by different parameter. We'll come to it. Now coming to the other parts of the radiology. We have seen MRI, it has immense value, we need to see all the nerves. Yes?
No, sir, continue.
We need to see all the nerves on dynamic MRI, the extent of the tumor, lateral extent. Yes, yes.
Ask Deepak if he has any more information to give us on MRI.
Whom?
Ask Deepak Panikar.
Yes, sir. Yes, sir. Anything you want to see more?
There's one thing that's very important with regard to the tumor is also to look at the tumor-brain interface. And for that, you look at the T2 image.
Yes.
Now, just pull up the T2 image,
Yes. Yes, sir.
the T2 axial. So one thing you look at is the tumor-brain interface.
Yes.
Now, you see the small CSF cleft
Yes.
periphery of the tumor.
Yes.
And also the fact that the surrounding brain that is compressed does not have any hyperintense signal there. The moment you have absence of that CSF cleft, it can be very small, you need to specifically look for it. Or you have signal changes within the brainstem, within the cerebellum peduncle or the cerebellum. You know that the pile plane has been breached and you're unlikely to get a decent plane at that point. So you should be very, very careful with
Yes.
those tumors.
And I think,
Otherwise, you can end up
sir,
transgressing into the brain
Yeah.
or the peduncle.
yes, exactly, sir. What do you say? In the primary tumors,
Satish, can I ask him a question?
Yeah.
So, Panikar, in those situations, there may be a reason for you to leave negligible amount of tumor in the brainstem area?
Absolutely, absolutely. See, a vestibular schwannoma is a benign disease. And at the end of surgery, your patient should be better off as they were before. So it is absolutely criminal to transgress. No, it is not a malignant disease.
Yes.
It is criminal to transgress into the brain and possibly give your patient a deficit rather than leave behind a bit of tumor, which very often if
may
it's
not
thin
grow.
enough,
May not grow.
never grow.
Yes.
And
So,
how do you clinically during surgery, when you're trying to remove the tumor from that area, your anesthetist
Yeah.
will say, sir, there's a bradycardia, sir, there's a hypotension. Right, Panikar?
yes, yes.
I think, yeah, see, that is the problem there is, I think, related to the tumor bulk. See, the first step, I'm sure Satish will address that in detail because this is a very, very important step of vestibular schwannoma surgery. The intratumoral decompression has to be perfect.
Yes.
If your intratumoral decompression is good, your capsule literally falls away from the brain and you can you can find your erectile plane very easily.
Yes,
The
yes.
problem is if you do not do that and if you have a chunk of tumor, then trying to manipulate that tumor will start putting pressure on the brainstem and then your anesthetist is going to complain. And that is something that has to be avoided. So the moment you
Yes.
begin finding that,
Yes.
go back into your tumor and decompress more.
Yes,
That
sir.
is the key thing.
Yes, sir. So the bottom line is, the important thing is,
to say anything, Dr. Gupta, our
Hello.
neurosurgeon friend.
boss, unmute.
Hello.
Yes.
Hello. Yeah, Dr. Panikar mentioned it very well and beautifully. These type of signals, particularly in the brainstem, are of poor prognostic. They are having a poor prognostic sign, and one should be very much aware of these signs, these imaging, and these will have to pick these signals and a complete thorough study of the MRI must be done. And according to that, we can explain preoperatively to the patient and his relative about the
Yeah, that's a
future
prognostic implication. That's good. Panikar sir, can I ask two questions here? Number one, as you mentioned about this arachnoid plane, can this plane be transgressed in a primary tumor? That can happen in a recurrence or in a different situation. Can this be transgressed in the primary plane, primary tumor?
Yes, possible. It is possible, especially with the larger tumors or your tumors
Okay.
where you have, say, you sometimes have a cyst at the periphery.
Okay.
You
Now-
can end up with this. So
Okay,
it's
that
very
can happen in
important.
a larger tumor. My second
Larger
question is, had this patient been having a peritumoral brain edema, what would have been the significance?
Again, the loss of the plane you anticipate that when you're operating, see, because when you operate these tumors and you're separating the capsule, one goes by trying to feel the arachnoid plane, and that is what you try to maintain. If you do not have a proper plane,
so in peritumoral edemas, do we not get this arachnoid plane?
it is likely to be breached. So
Okay.
that is the first signal that comes to your head, that anticipate loss of plane.
Yes.
And when you anticipate loss of plane, be careful of breaching.
Yes, that is so
Go
important.
slow, be very careful.
Okay, great. Now, one more thing, as sir mentioned, Dr. Pankaj Gupta mentioned about the plane. See this. Another thing I can show on this dynamic MRI. Can you see this basilar artery here?
Yes, yes.
Yes, yes.
And see the vessel arising from it. That is ICA, anterior inferior cerebral artery, and that is running through the arachnoid plane. Can you see very well?
Very good.
And that is the importance what he was saying. We need to stay in the arachnoid plane to save and preserve all the neurovascular structures. If we stay in this plane, we will never injure any of these structures. The moment we go out, we can end up injuring any of these things, and that can be diminished if the tumor has breached the arachnoid plane or if there is peritumoral edema. That is the important message we have got from him. Thank you, sir. Thank you, boss. Now,
Hello. Satish,
yes.
any symptoms related to fifth nerve?
To the fifth, no symptoms. I tried to evaluate the symptoms related to fifth nerve, ninth nerve, nothing. But they are in close proximity to the tumor we have seen. Now, another question to me for my, Panikar sir. I have seen many people getting MRI done and operating vestibular schwannomas. Honestly, how many of the neurosurgeons are getting CT scan of the temporal bone done before, vestibular schwannomas? Honestly.
Not too many, unless there is a specific reason to do it.
I will tell you reason.
I think, hello.
Yeah.
Yes.
The problem comes, you need to have a CT scan when you want to extend the drilling. I mean, if you're doing a retrosigmoid
Yes.
approach,
Yes.
and you want to extend the drilling of the posterior lip
Yes.
as far as possible, and your CT tells you essentially how far you can go.
Yes.
That.
See now,
And
at this CT scan, I want to enumerate, it's not about one approach, we should be able to do all the three approaches. I'll tell you the regions, and we have to choose patient befitting in particular approach, rather than pushing every patient to single approach which we know. So, what is the importance of CT? This pure evidence based. See, look at the CT scan of the temporal bone. What we get to know out of it, number one, the pneumatization of the temporal bone. How pneumatized it is, how extensively pneumatized it is. This is our region of the cerebellopontine angle, and this is the region of the mastoid. See now, if I go to the MRI, we have three prominent approaches to address these tumors. There are many approaches now people have described. The retrosigmoid, like sir is mentioning, translabyrinthine and middle fossa approach. These are three standard approaches. Then other approaches people have discovered are retrolabyrinthine, pre-sigmoid. For certain indications, those are narrow approaches that cannot be standard of care in the present context. Then a lot of people trying endoscopically also. There is again a narrow corridor with limited indications, and there are more chances of complication if you are not careful. So three approaches, how these three approaches are attacking. For example, to everyone, see now, I am drawing this. This is the temporal bone. Can you see here?
Yes.
This tumor is here. I am addressing it is directly from outside, right through the temporal bone head on. This is translabyrinthine across the labyrinth, through the labyrinth, and this is the most straightforward approach to this tumor. Head on approach. Now, other approach is, this is the sigmoid sinus level here. Other approach is retrosigmoid. What is this retrosigmoid? That is a very common neurosurgical approach, very fast, most versatile approach, I would say. You have to approach this tumor from this angle, okay?
Yes.
This previous approach is staying anterior to the sigmoid sinus, and this approach is from a little behind angle, behind the sigmoid sinus to this angle. And the third approach is what? That is middle fossa approach. How do you see the middle fossa approach as? Let me reconstruct this in the three planes and you will get to know easily. What is middle fossa approach? When you approach the tumor from above. When you approach the tumor from above, let me bring here. Yes. Now see, this patient has a tumor here in the, this is intra-aortic meatus in the coronal plane. In middle fossa approach, we approach the tumor from above. Like this is the temporal lobe, you elevate the temporal lobe, elevate, go extradural and approach from above the intra-aortic meatus. So all three approaches have their own indication and contraindication. But what all we need to know before choosing the approach, the adequate approach do we able to get in that particular patient or not. So how do we get to know? The pneumatization. That is what I put, why pneumatization is so important and how you can get to know by means of a CT scan. So CT scan is invaluable for many reasons. Invaluable for many reasons, and one of the important thing is in choosing the approach is the pneumatization system. For example, I have a classical patient for the translab. Very classical patient, hearing is already gone at the intra-aortic meatus component and I can easily remove by the translabyrinthine approach. But if I have less pneumatization, how do I go ahead with the translab? There are many ways by the experienced people, but by and large. So what we need to know, the pneumatization number one. For those going by the retrosigmoid approach, for example, sir is going by the retrosigmoid approach from here. Now, see this, what I mean to say here, how important is CT scan. This is our medial edge of the, see this is the sigmoid sinus. This is the sigmoid sinus here. I am going retrosigmoid and this is the medial edge of the intra-aortic meatus. Now if I have to go to the lateral part of the intra-aortic meatus, how much lateral part I can easily drill without any problem? How much lateral part? This much. You know, why not this? Now the vestibule is coming into the picture. Can you see? If we try to go more laterally, the vestibule may damage. It can, if you have a pre-op CT scan, you can actually calculate in millimeter that how much of the length of the intra-aortic meatus you can drill safely. Such a simple way of ascertaining we were discussing quite a few minutes before that how much the intra-aortic meatus one can easily remove or drill without endangering the inner ear. You can make out by means of knowing that CT scan that how much is your inner ear is close to. This is the vestibular aqueduct, this is the vestibule, and this much if I calculate this in this particular patient, see this how I can drill even up to 9 millimeters without endangering the inner ear. Mostly above 5 millimeters is a danger. Yes.
Satish, Dr. Satish, I am Dr. Achal.
Yes, boss, welcome.
Yeah. In looking to this CT scan, the tumor is on the opposite side because you can see the width of the internal prostate.
Yes, the same thing you can see here. See, I am coming from here.
So it is, So in this, when the size of internal prostate is more, you have to drill less, and you can pull the tumor also from the retrosegmental vestibule.
Yes, you can pull. Yes, that's what sir mentioned. That once you drill a part of the medial part of the intra-aortic meatus, you can use your endoscope, you can use your angle instrument and pull a tumor little bit. But that goes many a times blind. And
number two.
Yes.
As per the operating case which I have seen, the tumor is partly cystic.
Yes.
So if you decompress this, actually it's not cystic, it's a necrose part of the tumor.
Yes.
It also shows the high vascularity of the tumor.
Yes.
And when you decompress the tumor, you can handle the tumor while pulling it down, rather I would say that you have to drill in between, not in the beginning of this dissection or beginning of the dissection of the tumor, but in between your surgery, so that when you decompress the tumor, you have to drill less than required.
Yes. In that cases, when the tumor is decompressed, it may pull out and you may not have to go far laterally. That is your point. That is well taken, boss. So for everyone, we have Professor Achal Sharma, who is a professor in neurosurgery in Jaipur at SMS Medical College. Thank you, boss, for joining. And thank you for the nice comment. Now, we were discussing about the importance of radiology, boss. Yes.
Satish, I want to comment one.
Yes, boss. Yes.
While you are drilling, now you can take the help of navigation in order to avoid the injury to this vestibule.
So is it really so practical using navigation in vestibular schwannomas?
No. Just in order to save
Ascertain.
the.
Okay, maybe we have no experience. If you have used, that is amazing. If navigation can really help you by some millimetric distance to protect the inner ear while drilling the intra-aortic meatus, that is great. Now the second thing we discussed in the beginning are the value of CT scan. See, this is intra-aortic meatus. What you are going to drill with? The posterior wall. And see what is there in the posterior wall? Lot of air cells. Like Panikkar said in the beginning, when you have air cells in the posterior wall, you will close them with a bone wax or soft tissue or whatever. Now, first of all, if you have a pre-op CT scan, you can have a fairly good idea about the cellularity of the posterior wall of the intra-aortic meatus and their connection with the other cells. See, this is the labyrinth. These are retrolabyrinthine cells which have a communication. See this, if I go up, directly to the petrous apex cells, and that becomes a major source of a very frustrating problem, post-operative CSF rhinorrhea.
So sir, can we, yes sir, so then we can also do the combined approach retrosigmoid with retrolabyrinth.
Yeah, this is what Mario Sana is doing.
Mario Sana, yes sir.
That what Paramita is right. Panikkar sir, what she is trying to say, what Mario Sana group is doing now with all retrolabyrinthine approaches, they go pre-sigmoid also and drill away all these cells.
Yes sir.
They drill away all these cells by going pre-sigmoid so and obliterate with the soft tissue and bone wax. So even if while drilling the posterior wall of the intra-aortic meatus, even if you have communicated with some of the cells, it is not going to communicate further with the mastoid cell. That is to ensure that the CSF rhinorrhea is not going to happen. That is pre-sigmoid, additional pre-sigmoid drilling to the retrosigmoid approach, and that is something good. What it says, it is additional 40 minutes of drilling, but it gives you a very safety from the CSF rhinorrhea and the post-op. So what we need to know from the CT scan, the pneumatization pattern. Now those who are doing translab, if this translab approach is mostly criticized by neurosurgeons for the narrow access. Now, first of all, we should know from the CT scan that how much access we are going to get, number one. Number two, even if it is narrow, it doesn't make any difference to the experienced surgeon. The reason is, these acoustic neuromas are tumors within the arachnoid plane. Even if it is a large tumor, then your access, you can internally debulk and mobilize the tumor from the surrounding to your visualization. That's how. In Movani sir's workshop a few months back, I did a 20 centimeter square tumor through the 3 centimeter square approach by means of mobilizing the tumor into the field. But that cannot be done with non-acoustic tumors. So you have to be very careful in translab when you choose the translab, that you should have a clear-cut diagnosis. If you have a slightest of the suspicion, go by the retrosigmoid approach. So here, by CT scan, we get to know how much of the pneumatization is. For people who are doing translab, I'll give you the best way to assess is the coronal section. This is coronal section. How you can assess? We want to know how much is the access we have by the translab. For example, let me reorient you. This is sigmoid sinus. See this. Let me reconstruct. This is very important for all those who are doing translab. For example, if I show you, this is my sigmoid sinus. See, this is my sigmoid sinus. Okay? On the axial. And this is on the coronal. Let me pick up the coronal. Let me pick up the coronal. Enlarge it. Now this is my sigmoid sinus. What I mean to know here, above the intra-aortic meatus, see this. In translab, my superior limit is the middle fossa dura, okay? And my inferior limit is the jugular bulb. For this particular patient on this side, how much of the space I have below the intra-aortic meatus? Number one. How much space I have? This much. This much space I have, almost a centimeter space below the intra-aortic meatus to give me wide exposure. See, amazing. And how much space I have above the level of the intra-aortic meatus to the middle fossa? More than 3 millimeter. Now this is for a regular translabyrinthine approach. And thirdly, In the axial section, we get to know this is sigmoid sinus and this is your cochlea, how much of the distance from the sigmoid sinus to the cochlea that you have anteroposteriorly. So this much of the access you have with the bony margins. This is regular translab. What we are doing now is a enlarged translabyrinthine approach in which you can decompress all the wall surrounding. You can decompress the middle fossa above, you can decompress the sigmoid sinus behind, you can decompress even the jugular bulb, and you can enlarge your access much more. So the CT scan gives you fairly good idea that in particular patient would you be able to do a translab or not. Now if suppose it's a narrow access, if you are not experienced, don't do translab, go by retrosigmoid. Or if you are experienced, you can, you enlarge it by decompressing all around and internal debulking of the tumor and bringing the tumor into the field, the surrounding tumor, and still you can do it. Even with a narrow approach, you can remove any size tumor with a translab. So my point was with the imaging, how imaging can have impact on overall decision making, overall making your surgical course better, overall in giving you more and more information which has an impact on the surgical course. Any questions on the imaging before we move? Go ahead.
Satish boss?
Yes.
Sandeep from Pune.
Yes.
Yeah. So I just wanted to have your opinion about the extension of the translab. I mean, the transaortic approach, in what cases would you opt for it?
Yes, that's a very important question, and for everyone. We have Dr. Sandeep Karmarkar from Pune, who is a dedicated lateral skull-base surgeon. Along, he is a disciple of Mario Sana group. He has been to Gruppo Otological and worked there. So, boss, your question is valid. When to do transaortic? Transaortic means, first of all, to the audience, what is transaortic? In translabyrinthine, we drill the labyrinth from behind, semicircular canal and vestibule. The cochlea remains intact. If your tumor, like I said on the imaging, if your tumor is going far laterally, what will you do? For everyone. For even I will ask Achal boss, I will ask Panikar sir, if this tumor has happened to invade the cochlea, how would you address? That is what the transaortic approach is. Transaortic approach is what? When you drill away the entire cochlea and vestibule, keeping the facial nerve intact in position, and do a blind sac closure.
Yes.
So that is transaortic. For any lateral most extension of the tumor, the only way to remove that is transaortic. Panikar sir, what would you do otherwise?
No, I completely agree with you. You have these tumors that are very, very invasive, and you have this huge bulk of tumor with erosion in the petrous. Those are very difficult to remove by any approach. I mean, for that you do need to extend it, and those are the category where you need these extended approaches.
Yeah.
So when we have a high jugular bulb, then which approach will you? Can we also do transaortic in this condition?
No. The high jugular bulb has nothing to do with transaortic. Transaortic is additional drilling of the cochlea.
Yeah.
Now, keeping the facial nerve in position. High jugular bulb is something which is narrowing your corridor for the translab. Now that is something giving you more difficulty. If I am going by the translab and I have a high jugular bulb, what would I do? How would I access? That is the degree of difficulty given by the translab. That is simply, let me tell you to answer your question. In the translab, I had shown you just now the dimension of the, this is the jugular bulb and this is the space we got above the jugular bulb. Now, if this jugular bulb is high, suppose this is high, we will get a very narrow corridor for the translab, and a lot of people advise to better to go to retrosigmoid if you are not experienced. If you are experienced, what we can do, we have done in couple of cases, we decompress the jugular bulb. Jugular bulb, you have to be careful, the wall of the jugular bulb is different than the wall of the sigmoid sinus. Sigmoid sinus has a thick periosteum, which jugular bulb doesn't have. So you have to be careful, otherwise you can easily puncture the jugular bulb. It is a thin walled. What you can need to do is remove the bone over it. Most of the time in the high jugular bulb it is thin. You can paper it thin, you can remove your periosteum elevator, otherwise you can make it paper thin. Then push it down with the help of Surgicel and bone wax as much as you want. To get more and more access, the bone wax will keep in the place wherever you reduce it, so it doesn't come back. And that's how, even in the high jugular bulb, many a times you can reduce it to the X to the level that you can access your approach in the previous way. Now, another thing, once I forgot to tell you here, this is your jugular bulb. Now for everyone, what is this structure just above the jugular bulb? See this is jugular bulb. This is above the intra-aortic meatus. This is intra-aortic meatus. What is there in between this slit-like structure and this structure is going to the cochlea. This is cochlear aqueduct.
Cochlear aqueduct.
And see, in our translab approach, this is one of the greatest landmark. As an inferior limit. The reason is, as we go from above downwards from the intra-aortic meatus, our limit is by and large this jugular bulb. Just above the jugular bulb is this cochlear aqueduct, and just below the cochlear aqueduct is the origin of entry of the glossopharyngeal nerve into the jugular foramen. So keeping this cochlear aqueduct as your inferior limit always protects you from injuring the glossopharyngeal nerve. And to me, my jugular bulb is obviously the limit. My surgical limit is cochlear aqueduct. As long as you limit yourself to the cochlear aqueduct, you cannot endanger anything below. So that's a very important point. Thank you, Paramita.
So we can also talk about the transcochlear and the modified transcochlear approaches and its types.
Yes. So like Dr. Sandeep asked when to use transaortic. For people, what is transcochlear? Transcochlear is again devised by either, variety of transcochlear approaches A, B, C, D by Mario Sana. Yes. The classical transcochlear involves, this gives you widest exposure by any, lateral skull base approach. By transcochlear approach, I can remove any possible tumor in the lateral skull base, whatever the size is, whatever it is, transcochlear is the largest. So what is transcochlear? Transcochlear approach gives you widest exposure. My anterior limit of that approach is the carotid artery. See here. My posterior limit is the jugular sigmoid sinus. Inferior limit is the jugular bulb, and superior limit is the middle fossa plate. Every entire thing in between, including the labyrinth, is completely removed. What else come in the way is the facial nerve that is transposed posteriorly. So that gives you widest exposure, and according to Professor Mario Sana, I have seen him operating last February. When I was in Piacenza, he was doing a transcochlear approach for a tumor who was operated thrice by the retrosigmoid approach, had a huge cochlear involvement, had a complete facial nerve palsy and a dead ear. Now what all approach you need is so that you can remove the tumor completely. Now facial nerve is not in question, your hearing is not in question. Now why not to use the biggest approach so the patient can at least get a cure from the tumor. That is how the transcochlear, but you cannot use the transcochlear in a regular situation because it endangers your facial nerve. In posterior transposition, it gives some sort of weakness. But that is a definite indication of the transcochlear approach.
Almost like a total petrosectomy.
Yes, complete. Yes. So transcochlear is the biggest approach. Now before coming to the decision making, Achal boss.
Yeah.
Any comment before we go to the decision making part?
No. It is absolutely correct.
Please, boss, feel free to interrupt me.
No. I just want to ask you that while we are doing transaortic combined with the translabyrinthine, you have to transposition of the seventh nerve.
No. In transaortic, no need of transposition.
Okay.
In transcochlear, that is the widest of the approach, then you have to transpose. So we advocate transcochlear only when the facial nerve is already affected. When the hearing is already gone. Like for example, in any lateral skull base tumor which frequently affect the hearing and the facial nerve. Any lateral skull base tumor which has affected the hearing and the facial nerve, you don't have to think twice and go by the transcochlear, which gives you widest exposure. As simple as that.
Okay.
So basically modified transcochlear approach is transaortic plus the transcochlear.
Yes, I'm not going in detail, Paramita, here. What Professor Mario Sana devised, he combined the transcochlear with the other approaches and given the name as modified transcochlear A when it combines with the infratemporal fossa A. When he combines transcochlear with the infratemporal fossa B to go widest anteriorly to the petrous apex, that is transcochlear B. C is when he combines with the middle fossa approach, D when he combines with the far lateral approach. That's how you can get additional exposure by the combined approaches. So here now, the next part before we start the case operating, the most important thing is the decision making, and this is what everyone should be very clear about it. Panikkar sir, I know he's doing translab, he's doing retrosigmoid, and he's doing middle fossa all. And that is so nice to know when Movani sir was telling me that you have been doing all, and I have seen him once operating as well. So the rationale is why and which approach is most important for that particular patient. First of all, quickly let us see the advantage and disadvantage of all the approaches. Quickly, retrosigmoid to me is the most versatile approach. So fast, you can remove the bone flap and open the dura, and in 20 minutes you can be into CP angle. That is so fast approach. So in those patients who require quick surgery because of anesthesia issues and all, you can go by retrosigmoid. Translab on the contradictory part is it requires a lot of drilling of the labyrinth to go right onto the tumor. It may take hours and hours drilling sometimes. So most versatile, fastest, and hearing preservation is also possible if the tumor is not extending far laterally to the lateral intracaustic. Why these all approaches need to be discussed? What is the issue? Why one approach cannot give all the answer to everything? The reason is the function preservation. The hearing and the facial now are the two aspects where everything revolves around all these two things in terms of choosing the approach and other techniques. So the disadvantage is, like we have already discussed, it is a limited access to the lateral IAC or the fundus. Once you do by the retrosigmoid and your facial now happen to get injured, not found the facial now, there is no way you can repair the facial now to the external part. On the contradict, on the other side in the translab, if we have a proximal stump of the facial now available and we have a distal stump in the mastoid segment in the same field, we can put a sural nerve graft and anastomose at the primary surgery time. That is the biggest advantage in that, which is not here in the retrosigmoid. You cannot reconstruct the facial at the same time. A lot of people talk about, I don't know, it happens with the experienced people, air embolism, CSF leak, post-op headache. I discussed with the Pankaj Bose also yesterday about the post-op headache. He says it's no more a big issue for us. I don't know in literature, but you people are more experienced and you know how to overcome all these problems. Cerebellar retraction is an issue, but I know many of the neurosurgeons experience for them, it is no longer an issue. They drain the CSF and they have to retract the cerebellum too much. And even if they retract, they don't have any long-term complication. Is it true, sir? There is no long-term implication?
Yeah, absolutely. I think what you said is absolutely true. If you do a proper CSF drainage, your brain relaxes, and the need to do a static retraction by using a self-retaining retractor is very little. In fact, very often we do even moderate or fairly large tumors, even without any self-retaining retractor, maybe for a very short duration. That is not a great issue as of now.
Achal boss,
Satish,
yes sir.
A lot of people used to use the retractors for prolonged period with the pressure. The other problem was ataxia, post-op ataxia.
But it's not long lasting, I think. It's not long lasting.
No.
It's not long lasting, but people used to. Your patient will go to work in 3 weeks' time. Their patient will go work after 5 to 6 weeks' time.
Sir, theoretically it may be, but I know neurosurgeons are so used to this approach every day in and out that they overcome all these issues with their experience. I believe. I have seen, boss.
Yeah.
I have seen even neurosurgeon removing a part of the cerebellum to get access without any issues.
Yeah, they used to remove 1/3 of cerebellum once upon a time.
Yes.
There are 50 years back.
It was old days, sir.
Nowadays, at that time, what we can do is tumor. They used to get a 5.5 centimeter and those kind of tumors, you see.
Satish?
Yes?
Sir,
nowadays they have minimal complications.
Yeah.
Which is better.
Yeah. See, you have to choose the approach. I am coming to that decision making. But we should know the pros and cons of every approach. That's what I am, sharing with you. So, to me, the retrosigmoid is the fastest one.
Trying to make a comment, I think.
Yes. Yeah. So, the retrosigmoid is the fastest one. It's so versatile approach. For me, I already mentioned, for any tumor, if you have a slightest of doubt of being acoustic, don't go by translab. better to go by retrosigmoid, because it is such a versatile approach, giving panoramic view of the posterior fossa. Even if it is a meningioma, it turns out to be epidermoid, it turns out to be anything. You can remove with the same efficacy, which otherwise you may not with the translab. The reason is, those tumors you cannot mobilize like acoustic in the field. Those tumors tend to involve the neurovascular structures which acoustic doesn't. You know, once you're dealing with acoustic, you stay within the arachnoid planes and you don't damage anything. That doesn't happen with other tumors. If it is a meningioma, if it is epidermoid, they involve the neurovascular structures, and in those cases, if the tumor is going below, suppose inferiorly, superiorly or anywhere, you cannot mobilize. So better not to do translab, to go by the retrosigmoid, as it is more versatile. We should know the advantage of every approach. We should not be dogmatic. That's why our aim is, that's why this evidence-based medicine is existing, that we should be able to use a particular approach for that particular patient. That's why it calls for a teamwork between otolaryngologists and neurosurgeons to choose the particular approach for that particular patient. It's not that I know translab, I will push every patient for translab. If it's not that I know retrosigmoid, every person I will push for retrosigmoid. That is not evidence, that is not science. That's what we are discussing here.
Okay, thank you.
Yes.
The second approach is the translabyrinthine approach. We all know this approach, the biggest problem is inherent sacrificing the hearing.
Yes.
So this approach is indicated only when the hearing is already gone.
Yes.
The biggest
When the serviceable hearing is gone.
Yeah,
Hearing.
that's what I'm coming to.
Yes.
The hearing is already gone, or the hearing, whatever it is coming on the pure tone, which is not serviceable hearing. I will give an example what is serviceable hearing. You know, sometimes we get the audiogram done and the audiogram say 40 dB sensorineural hearing loss, and we can assume that this tumor we can remove by a hearing preservation approach and predict that we will be able to preserve the hearing. That is not done. We need to get, see this pure tone, for transferring the pure tone, you know, we need little cochlear nerve fibers. For transferring the speech, we need lot of cochlear nerve fibers. So speech as a whole requires a good cochlear nerve. That's why the parameter we use is a speech discrimination scoring. So if the patient has a good speech discrimination scoring, that reflects the serviceable hearing. That's how the classification has been proposed by Mario Sana and many, that if you have a better than 70 dB, 70% speech discrimination score, go for hearing preservation approach, whatsoever the tumor is. If less than that, less than 50, there is no point in preserving hearing whatsoever the audiogram is saying. Rather, sometimes, whatever the remaining hearing is, it gives perverted sensation to the, you know, the cerebral cortex, and it interrupts from hearing from the other ear as well. So rather it is better to sacrifice that hearing which is already perverted.
Very true.
That's how this hearing preservation. So this actually we are preserving the hearing is not or not, whether it is a fact or a fantasy. There is a very good publication from Professor Mario Sana, if you go through, that whether it is a fact or a fantasy. What is true preservation of the hearing? And there are many ways to predict that. I have a special slide for the hearing as well. So for the translab, the advantages which are proposed, which we all know. I've been doing translab for long. There is no need, like we discussed, they may not be so important. There is no need of retraction of the cerebellum. For that matter, in the retrosigmoid, you retract the cerebellum, doesn't make any difference. But the most important thing is, at the beginning of the surgery, when I reach the intra-auditory meatus, the first structure I see is the facial nerve. That is the biggest of the advantage I see in the translab. It allows the positive identification of the facial nerve, that too in the beginning. Yes. If hearing is gone, what else the function we are concerned with? Facial nerve. Yes. If the hearing is already gone, now bloody we should do best for the facial nerve, and that's how this approach is come up like anything. That's what Professor Mario Sana emphasizes. When it comes to facial nerve, there cannot be any match to the translab by any other approach, because there is always a positive identification of the facial nerve right to at the beginning. That's what I'm going to show today. The moment I open the intra-auditory meatus, I will see the facial nerve and then I can easily follow it. Number two, for the ISC, when the hearing is gone and you have a tumor in the ISC anywhere in the ISC, This gives the best access because it gives you first access to the ISE, then to the CP angle. CSF leak, it depends upon the person, how you handle the closure. I don't believe that this has a less CSF leak as compared to retrosigmoid. I have seen people, I have worked with neurosurgeons for long, and they do retrosigmoid so beautifully, and I have never seen practically for them giving a wound CSF leak. The CSF leak which is concerned here more is the CSF rhinorrhea. There are two kinds of CSF leak a retrosigmoid approach can give. Wound related, when you do an outer craniotomy, best what you can do, you can apply your bone wax. I have seen Pankaj Bose several times. He first applies the bone wax and then opens the dura. So that's how you can stop the communication with the mastoid. But the more important is when you drill the intra-aortic meatus. And then communication to the petrous apex cell is disaster. And that we should know. So the less chances of CSF leak, we need to interpret it, and for the experienced people it is same by both the approaches. That doesn't make any difference in choosing the approach. The most important thing is in reoperation. I want to know the comment from Achal Bose, Pankaj Bose and Panikar sir. If you have done a retrosigmoid sir and patient has some hematoma or something unfortunately happened to develop with long surgery you have done with retraction of cerebellum and all, and you need to go back, what I believe with the translab, we can remove the fat what we have packed and easily go in no time. In 5 minutes, I can go to CP angle in a reoperation situation, suppose 2 days after or whatever. How is the experience with the retrosigmoid in case you need to go back in the, in the near post-operative period?
Dr. Satish.
Yes, boss.
Yes, Dr. Achal. Basically, the time is not that important because in the both of approach, you can reach very fast. Because in the case of retrosegment also you can open the wound very fast.
But
no
does cerebellum interfere, boss?
Yeah. Cerebellum, it all depends. You must see the CT scan post-operatively that whether there is a hydrocephalus or not. Because if you have done the shunt rear, there is no such problem. Otherwise also you can take out the CSF or drain the CSF. And number 3, when you remove the hematoma, then again you get the space. So you can.
It's no more a big issue. That's what I wanted to know.
Yeah.
I had an impression that long retraction of the cerebellum giving cerebellar edema may interfere. That's what I wanted to know.
It depends. When, as Dr. Panikar has said, that it's hardly most of the time. You need not require to put the retractor for the retraction of the cerebellum.
You drain CSF and it is relaxed.
Yeah. It is for the protection of the cerebellum rather than retraction of the cerebellum.
Okay, great.
So it is not so much
big
important.
Issue. It's not a big issue. Yes, Pankaj boss. Your point is very well taken, boss. Great. Yes, Pankaj boss. Yes.
Yeah. First of all, we'll have to see what is the cause of the brain tightening. Post-op brain tightening means is it because of edema? Edema can be because of inadvertent injury to the venous system or arterial system.
Yes.
Second thing, what Dr. Achal has told about the CSF hydrocephalus.
Yes.
Okay.
Yes.
And third thing is inadvertent retraction of the cerebellum. So we'll have to see what is the cause of this brain post-operatively. Patient has deteriorated because of the tight cerebellum.
Okay.
So as already been mentioned by Dr. Panikar, what we are doing nowadays, of course, the craniotomy size has been minimized. We are doing mini craniotomy, and first we attack by the help of endoscope to the direct puncture of the direct opening of the cisterna magna.
Yes, sir has already mentioned.
That makes our life very very easy. And after
that we also do in the translab. We also do in the translab the same thing.
Yes. So, but we say that bone dust entering into the cisterns. In which approach it is more?
Paramita. Yes, you're right. In the retrosigmoid, when you drill the canal, the bone dust, but they know how to prevent it. I have seen them. They put sometimes some Surgicel gel form as a barrier.
Okay.
Yes, Pankaj boss, how do you handle?
Can I ask a question?
Yeah, we can put a paper of this like suture material or something like that, now,
Yeah,
over
to
the
prevent
brain,
bone dust
or we
from
can
entering.
we can put the piece of gloves over there.
Okay.
So after that we can wash it very well.
Okay.
Yeah, that's
Okay,
Dr.
important.
Boss,
sir.
can I ask a
Now,
question to Dr. Pankaj and Professor Achal and Dilip sir? What is the protocol in case they are planning a retrosigmoid approach and the tumor is very large? Do they always consider a pre-op shunting?
I don't think so. They do.
Not always,
Yes.
not always. I think the need for a shunt depends upon the clinical state of the patient.
Right, exactly.
Now, if your patient is already on the verge of decompensation with massive hydrocephalus and beginning to decompensate, then maybe one can consider a shunt. However, one option that you have is, see, the problem with putting in a shunt is you are giving the patient an implant, which they will probably have to live with later. The other thing that you can do is to put a temporary external ventricular drain.
The majority of the time it's not required, sir.
Re-establish CSF pathways, then the need for a CSF drainage subsequently is superfluous. Then you don't need it. So, if at all you need an external ventricular drain, so with the larger tumors with significant hydrocephalus, if you're going in for a primary surgery, it's a good move to drape supratentorially also, maybe put a burr hole and keep it ready. If you find that your cerebellum is swollen, it's very easy to put in a ventricular drain and relax the brain.
Yes,
Satish,
great. So,
Satish,
yes.
Satish, if the patient is having CSOM with acoustic neuroma,
Yes, sir.
the same year.
Yes,
If there
CSOM
is
with
an
acoustic
acute
neuro.
infection, if there is
Yeah, that's a very
active
important
infection.
point. Appa, that's very important point. Both for translab as well as retrosigmoid, I tell you. It's not that patient has a CSOM, I am doing retrosigmoid, I have no worries. It's not like that. I tell you the reason. If the patient has a CSOM, translab is absolutely contraindicated unless you treat the CSOM. Number one. Either you treat the CSOM first or do a complete subtotal petrosectomy and bind sac closure at the same time. So to avoid infectious problem, because the mucosa in the CSOM is in direct contact with the mucosa of the mastoid which you are going to drill. Same thing in the retrosigmoid. If you happen to have given a communication of air cell during drilling of the intra-aortic meatus and given a CSF rhinorrhea, communicated with a petrous cell with a CSOM in situ can be disaster. And then you need to immediately do a blind sac closure, otherwise can be a disaster. So you cannot ignore the CSOM in both the conditions. Yes, sir.
Satish, when she has got a CSOM, this patient won't get rhinorrhea, he'll get autoria because he's got a perforation.
Yeah,
Otherwise,
if CSOM is a perforation, otherwise yes.
yes.
Yes, sir. Yes, sir. So now, yes, Paramita.
So, and what about also, in which cases will you also go for the radiotherapy first, and after radiation, what will be your, when will you operate?
We are coming to decision making. We are coming to that quickly.
So, first, Satish, do you go for radiotherapy first of all?
Pardon?
In your books, when do you go as a first treatment? As
I am coming, sir, in decision making. I have a dedicated slide for that. So before completing this translab, two things to mention. As I have already mentioned, this gives the direct anastomosis of the facial nerve at the same time of tumor removal, and that is the biggest advantage. And more important is, in all the approaches, this translab gives more opportunity to injure the sigmoid sinus than any other approaches. Like Pankaj both said, if you have a venous edema, venous infarction or venous high pressure, it is all because of sigmoid sinus, and that happens mostly with the translab because you deal with the sigmoid sinus, it remains in the field all the time as compared to the retrosigmoid approach. So this is to me as a disadvantage. Now coming to the third approach quickly so that we move on quickly before we start the case, the middle fossa approach. Out of all approaches, this is the most uncommon approach, most less utilized approach, I would say. But there are certain advantages, and the only advantage because of this approach is discussed is the opportunity to preserve the hearing. So now, When the patient has a good hearing, you can think of this approach, provided the tumor is limited to the intra-auditory meatus. I showed through the MRI how you approach from above by elevating the temporal dura and go to the intra-auditory meatus. Now all those tumors which are descending into the cistern by 10 millimeter, 15 millimeter, whatever size, if you are going by the middle fossa approach, you cannot control the lower end of the tumor, the neurovascular structure. If any of the vessel happen to get injured, it's a disaster. You cannot handle it so immediately. You have no access to handle that. So this is the approach, only limited for the canalicular part, and for that this is excellent. This is the only approach by means of which the entire intra-auditory meatus can be accessed, preserving the hearing. That is the best part of it. So hearing preservation approach is middle fossa approach. It's purely extradural, no risk of CSF leak. We are not entering into the CSF space unless we open the intra-auditory meatus. The disadvantages are many. That's why it is not so popular. It is a very difficult approach for that matter. I had shown in the cadaver the middle fossa approach for the decompression of the facial nerve. There are many more indications. But in this in the acoustic neuroma concern, this is not a very popular approach, and the reason is you need to retract the temporal lobe a lot. So people having temporal lobe epilepsy, elderly people having fragile dura, you can damage the dura, you can give complication to the temporal lobe because you need to retract it for longer and hard. If you really want to go to the petrous ridge, you really need to retract a lot. And that is something, a negative point with this approach. The second thing is, if you see the orientation of nerves in the intra-auditory meatus, there are 4 nerves. Two superior nerves are facial anteriorly and superior vestibular behind. 2 inferior nerves, the cochlear anteriorly and inferior vestibular behind. Now, my superior nerves are facial and superior vestibular, and I am coming from above. Now, majority of these vestibular schwannomas are arising from the inferior vestibular nerves. I am coming from above, I have to go across the facial nerve to deal with this tumor. And that is what the disadvantage, to me this is the biggest disadvantage, as you have to manipulate the facial nerve a lot. So with middle fossa approach, there are more chances of facial nerve paralysis, injury, whatsoever you say, as compared to other approaches. That's why this is not a very, very popular approach. But yes, for intracanalicular tumor, good hearing, particularly tumor which is laterally located. Like Panikkar has said in the beginning, for medially located tumors, we can open the intra-auditory meatus from behind in the retrosigmoid. And that is a fantastic hearing preservation approach in that situation. But for those intracanalic tumors which are deep laterally located, retrosigmoid is never a first choice. And for them, if you really want to preserve hearing, middle fossa is the only approach. Otherwise, you will end up sacrificing hearing. That is the advantage of this approach, and that is what we need to know. Now, and quick, Satish,
yes. Satish, also tell how you are going to decide whether it is originating from superior vestibular.
Yes, we have discussed a lot. Pankaj we had always a discussion. There is always a, you can discuss whether this tumor is arising from the inferior or superior vestibular nerve. Because it has a prognostic implication. If we get to know, it is amazing. But many times in larger tumor, it is difficult. Because in that situation, as the tumor grows, both the nerves are affected. But in smaller tumors, if we get to know that whether it is arising from the inferior vestibular nerve, inferior vestibular being so close to cochlear nerve, if I know this patient has a tumor originating from the inferior vestibular nerve with a marginal hearing, I will never go with the hearing preservation approach, because this nerve being so close to the cochlear nerve, the infiltration of cochlear nerve is so likely. Even if you try to preserve the hearing, you will end up actually damaging the hearing by dissecting the tumor more closely from the cochlear nerve. So how do you can differentiate? By means of certain tests. We all know the inferior vestibular nerve supplies the posterior canal, posterior semicircular canal, and the saccule. And the superior vestibular nerve supplies the superior semicircular canal and the lateral canal. Caloric test is a function of lateral canal. If the patient shows caloric test positive, caloric test is still intact, that means the function of the superior vestibular nerve is intact, and tumor is likely to be originating from inferior vestibular nerve. Only the positive finding has a value, negative has no value. because as the tumor enlarges, it may compress both the nerves. Similarly, the inferior vestibular nerve supplying the saccule, which has an important bearing in giving vestibular evoked myogenic potential by means of sacculocolic reflex. So if your VAMP are still intact, that means your inferior vestibular nerve is intact and tumor is likely to be from superior vestibular nerve. That's how. The reason is, if the tumor has an origin from the inferior vestibular, it is unlikely to preserve the hearing whatsoever you do. Particularly, even if you try to preserve the hearing immediately, you may have the preserved hearing, but it may not work in long run. And secondly, if you try to preserve the hearing, you may leave the tumor, the small tumor cells onto the cochlear nerve, and that has a bearing on a so-called recurrence. So now,
sir,
yes.
sir, I've gone through a few articles where they've seen that they've said that you can track the facial nerve by the diffusion tensor tractography. So
yes.
What is
that's a MRI sequence by means of which you can follow the cranial nerves in relation to the tumor. So diffusion traction tractography is one of the modality by means of which you can see the entire course of the facial nerve in relation to tumor, how it is anteriorly pushed, anterior-superiorly pushed, anterior-inferiorly pushed. In up to 2% of the situations, even the facial nerve have been found behind the tumor in the acoustic neuromass. I have not seen in my practice, sir must have seen in his practice, a dorsal facial nerve to the tumor. Sir, have you ever seen? The literature has...
Dr. Satish.
Yes.
Dr. Panikar has a lot of work in this diffusion tensor imaging.
Yes, sir.
And as you said, that there is only 1% chance, 1% incidence of the dorsal placing of the facial nerve.
Yeah. We have never seen. You must have seen.
Yeah. Many a times. But Dr. Panikar has a lot of experience to using this DTI before the surgery to predict the pre-operative position of the cell.
Oh, sir, can you throw some light on it, sir?
Yes,
in
sir.
brief.
See, the DTI is a good modality, but it all depends upon your radiologist and the quality of the MR images. If you can get very good sequences, and if you have the patients and your radiologist has the patience to sit and track the fibers, then it's worth doing it. But what I believe, I don't do DTI routinely in my practice. I entirely rely on my electrophysiology, my intraoperative electrophysiology, and that is what guides me through the entire surgery. The DTI is predictive, it's fine.
Yeah, it's not everything. It gives you an idea.
It gives you an idea.
Yes,
but the most important thing, what I believe, is the moment you expose a tumor, you stimulate. If you do it, if you're doing it retrosigmoid, you expose the posterior surface of the tumor. Use your nerve monitor, stimulate the posterior surface before you make an incision on the capsule.
Yes, sir. That's what I'm going to show. We have been using this nerve monitor for every case, and that's what I'm going to show you, the value of the nerve monitor. Now, there are quickly the various classification systems, the n number of classification. This is what very popularly being followed according to the size of the tumor. Then this classification is very practical in the terms to define what tumor you have. And today we have a T4A tumor which is compressing the brainstem. And then this is what I mentioned about the Mario-Sana's classification. This is Piccirillo and Sana classification, which shows about the cystic vestibular schwannomas. And this is very practical. The difficult are the type B tumor where the cysts are in the walls of the tumor. If it is an anterior wall, it has a bearing on close relationship with the facial nerve. Similarly, posterior and medial to the brainstem. And this is how they classify. Today we have a A2 tumor where multiple intratumoral cysts of the moderate size with a thick cyst wall. This is what we have today. We have two cysts with a thick wall all around, and that is what A2. Now coming to the decision making, which is a very, very important aspect. This is what the actual science is. What approach, we have seen all the three approaches. What approach to be used in which particular case? And here I would like to have the generous input from Sir Pankaj Boss and Achal Boss on this issue, because this is very important and this should be a message to the colleagues that what approach to be used in which condition by you as an expert people. These are the points which we take into consideration before choosing approach. For me, every surgeon who is dealing with acoustic neuroma must be well versed in choosing all the approaches with equal pace. The team should be able to use the translab, the retrosigmoid and the middle fossa with the same pace for any case. So like the thing is tumor size. I'll quickly enumerate these factors why I mentioned tumor size. It has been believed that the retrosigmoid gives the widest exposure, and it's right. You can remove any size tumor so quickly. Translab, for the acoustic purpose, I can say any size acoustic neuroma can be removed with the translab. There is no issues at all. The reason is you have to do intratumoral debulking, and you have to mobilize the tumor in the arachnoid plane, bring in the, your visualization. If the tumor has gone inferiorly, which is beyond your visualization, what you can do? Do intratumoral debulking and bring it in your full field, and you can remove it. We have done several times. So for translab even, that size is not a big issue. For I have already mentioned for middle fossa, these are the big size tumor are not for the middle fossa. The most important thing in our practice in choosing the approach is the depth of intra-aortic canal penetration. Any tumor which is penetrating far laterally in the intra-aortic meatus, to me, if the hearing is good, obviously, if the cisternal component is not big, middle fossa. If the hearing is marginal, we need to take certain factors into consideration. If the hearing is gone, forget about everything translab, because translab gives you first opportunity to open the intra-aortic meatus in the beginning. With retrosigmoid doesn't give. So this point I mentioned here specifically, depth of intra-aortic canal penetration. If you have a tumor which is far laterally penetrating to the fundus, the best is to go by either translab if the hearing is gone or marginal, or by the middle fossa if the hearing is good. That's how you have to choose. Pre-operative hearing. We all know the retrosigmoid preserves the hearing, middle fossa preserves the hearing, and if it is good serviceable hearing, you cannot use translab. You cannot push translab to those patients. So hearing is an important criteria. Facial now. I have already mentioned about the middle fossa approach as a negative point about the facial now, because you have to go most of the time across the tumor. For facial now, by and large, out of 3 approaches, in the best of the literature, in the best of the experience, the translab has an edge over the retrosigmoid, because you identify the nerve at the beginning of the surgery when you open the intra-aortic meatus, which other approach doesn't give you that offer. Anatomical variations are important, like Paramita had mentioned about the high jugular bulb and all those difficult anatomical situations. You can change your approach. If you are not experienced with the translab, you can easily go with the retrosigmoid, because in any given anatomical situation, retrosigmoid is versatile. It is rare to see a posteriorly displaced sigmoid sinus. Sorry, have you ever seen? To limit your retrosigmoid approach, the posteriorly displaced sigmoid sinus limiting your retrosigmoid. Have you ever seen?
Yes, it is possible that there are some of, it depends on where the sigmoid sinus is. One of the practical problems with doing a limited retrosigmoid approach is when you stop at the edge of the sinus, you can sometimes end up with a big bone shelf over the sinus. And that leads to a different angle of approach and more need to mobilize the cerebellum.
Can I ask one thing here, sir?
Need to pull over the sinus onto the pre-sigmoid area, then you can mobilize the sinus a little more to do that.
Okay. Can I ask one thing? Like we have a situation in translab, you have a forward sinus, high jugular bulb narrowing your approach. Is there a situation when you have a, more caudal sigmoid sinus and a more inferior transverse sinus limiting your approach, and what do you do then?
Not really, because see the versatility of the retrosig approach is that you can extend your bone removal across the sinus on either way. See, the transverse sinus is less of an issue. Your sigmoid sinus can be restrictive, but then that is where you extend your bone removal over the sigmoid sinus into the pre-sigmoid area.
And you
what
can
happens
decompress
is when
it.
you do that,
yes,
your sigmoid sinus becomes mobile.
Yes.
So as you open the dural leaf and you retract it, your sinus itself moves a little bit. You get this added degree of freedom. You don't always need it, but that is where one of the versatilities of the retrosigmoid is there. That makes it a little more flexible.
Achal boss, Achal boss. Achal boss.
Yeah.
Any comment to make on difficulties in retrosigmoid any time? Difficulties.
No, as I have no idea about this retrosegment, no experience of translabyrinthine. So in retrosegmoid, the problem is not much looking to the sigmoid sinus rather than this translabyrinthine.
No, what I mean to ask, any experience of a difficult retrosigmoid approach because of the sigmoid sinus or transverse sinus?
Not so, because we are going beside of this sinus, and we are retracting cerebrum rather than this sinus. So one yes, of course, that you have to retract more.
Yes, if it is more behind, you have to retract more.
Yeah.
Yes. And the other point about the suspicion of the lesion that may not be acoustic, I've already mentioned. One and only approach, retrosigmoid. Yes. Yes, sir. You're not audible, sir. So whenever you have a doubt about the diagnosis of an acoustic neuroma, better to go by retrosigmoid.
In
Sir, your connection is not good.
United States, where what they
Sir, you are not audible. Can you re-log in? You are not audible, sir.
Morwani, so there is some internet connection.
Sir, your voice is breaking. Better you re-log in.
Can you hear me now?
It's breaking.
Can you hear me now?
No, sir.
Can you hear me now?
Hello? Not audible, sir.
Okay. I'll try it.
Sir, you re-log in, please. Okay. In the situation of
Can you hear me now?
a little better. Sir, can we go quick? Yes, sir.
Yes, sir.
So, coming on to the next point, the recurrence. This is very important. In the recurrent situation, क्या कर रहा है यार ये?
It's okay. Carry on.
Can you hear me?
Yeah, I can hear you.
So, in the situation of a recurrent tumor, I had a lot of discussion with Pankaj Bose several times. Our approach when we do together, if we have earlier operated by the translab, we'll go by the retrosigmoid now. If you have earlier operated by retrosigmoid, now you'll go with the translab. And it is so clear. The reason is, if you go by the same approach, you'll encounter more fibrosis and scarring. That is never a good thing when you go approach a revision tumor. Otology consideration we have already discussed. Age is a big issue. I tell you, for tumors which are for patients who are elderly, like we discussed the middle fossa approach, we should avoid doing that, and the dura is more thinner and more fragile. You can use translab and retrosigmoid with the same pace in the elderly people with no issues. And obviously the patient expectation, personal experience and preference, this is the thing which is leading in our practice. You know, out of all regions, I should have put this on the top. Personal experience and the preference, that is a major factor in decision making. A lot of people, I know this approach, so they will push in every patient for that approach. And that is not a science, and that is what happening unfortunately many a times. And these are the factors. Now, looking at these factors, we have certain inferences. For intracanalicular tumors, we have already discussed. Very quickly, if the tumor is limited to the medial part of the canal, the best is retrosigmoid if you intend to preserve the hearing. When the hearing is gone, translab for any part of the canal. And unanimously, without any doubts, when the hearing is gone, translab is the approach of choice for tumor anywhere in the canal. You can access the entire canal perfectly with the translab. But when it comes to hearing preservation, the tumor limited to the medial canal, retrosigmoid, lateral canal as we discussed, middle fossa, and the entire canal involved, then you have to take into consideration. If it is deep lateral penetration, if it is widened canal because of the tumor, widening of the canal is a sign that tumor is compressing on other cranial nerves. And then it is difficult to preserve the hearing and better to go by translab. Because it gives you good exposure.
The type of life you have gone through. There are not even 0.01% people who have gone through a life like this.
Sir, can you unmute? Can you mute?
Almighty God.
Dinesh, sir.
Wait, I'm just saying.
Okay, mute. So, as far as the conservative management is concerned, like Morwani sir has asked, what is your protocol for the conservative management? This is what the evidence says. For all, these are very, very slow growing tumor. You know, all acoustic neuromas are not growing. There are a variety of growth patterns we've described. The recent publication from Mario Sana, they've described 13 varieties of growth patterns. So, by and large, elderly patient with slow growing tumors we can observe, rather than, you know, subjecting them to any therapy unless they are growing. The moment they start growth, then you have to take a call. Either radiotherapy or surgery, whatever, depending upon the merit. But by and large, elderly patients, short life expectancy, slow growing tumor, nothing is required to be done, just observation. If growth, on serial MRI, either surgery possible, otherwise radiotherapy, if the patient is not a good surgical candidate. Or only hearing ear. Only hearing is another difficult situation when the patient has only hearing ear with acoustic neuroma. Lot of reports people have done removal of the acoustic neuroma and given a cochlear implant at the same time. It can be done provided your cochlear nerve is intact, not only intact, functionally intact, and then you need to do a cochlear nerve monitoring all the time to ensure the integrity of the cochlear nerve, and then you can implant at the same time as well. Otherwise, in only hearing ear, either you wait as it is a slow growing tumor. You can do a partial resection, decompression of the intra-auditory meatus by the retrosigmoid approach to release the pressure on the nerve, or you can give a radiotherapy, or you can implant in the other ear, cochlear implant, and handle this ear. There are so many options in those situations. So, conservative management has a big role in majority of the tumors. Up to 50% tumors do not grow. So that is a big thing, that every acoustic neuroma is not a surgical candidate. That we all should know. It doesn't mean that you find acoustic neuroma on MRI and you take a call for surgery of every case. These are the indications. These are the indications for us when the primary surgery is preferred. When you diagnose a case, you get a case and you need to operate. You can take a call. This was, Paramita was asking me when to operate. That was the question. And here any patient presenting with the cranial neuropathy like disabling vertigo is a straight away candidate for surgery. For larger tumor like this tumor is a grade 4 tumor almost. And young patient, because they have a long life expectancy, if you allow them to grow, if you observe them, you have to pay a big price in terms of losing the function. For example, if a young patient diagnosed with acoustic, if you operate in the earlier situation, you can preserve the function better in terms of hearing and facial nerve. We all know as the tumor grows, the hearing and facial nerve preservation is difficult. Why to pay that price unnecessarily with a young patient who has a huge life expectancy? Better to take a call in the young age to get rid of the tumor as well as preserving the function, because that gives the best opportunity to preserve the function. Cystic tumors is a straight away indication for surgery like this tumor. He all of a sudden expanded and presented, and that's how cystic tumor can expand any time and give complication of compression and all those things. So there are the straight away entries for the surgery. They are not good candidates for radiosurgery because radiosurgery is ineffective in the necrotic part. So these are the indications like large tumors and all when you have an impending complication, which is the straight away indication for surgery. There are some times we always look for a total removal. There are certain times when we think of planned subtotal removal, like sir mentioned, Panikar sir mentioned, if you have a tumor close to the brainstem, impinging on the brainstem, adhesion with the brainstem, it is better to leave that part of the tumor rather than giving injury to the brainstem. Cystic tumor, when you have a common wall with the neurovascular structure of brainstem, better to leave that wall to preserve the function. So these are the situations when you have to take intraoperative call of a planned subtotal removal, and like sir said, many of the time these tumors do not grow. You can have a serial imaging to follow, and if they tend to grow, you can take a call of a revision surgery or radio surgery or whatever. But majority of these tumors do not grow because they get devascularized also. Many of the times they do not grow at all. So that's a good, call to.
What about doing it for the only hearing ear, a planned subtotal resection for only hearing ear when you are not planning a cochlear implant?
Yes, that's I have already mentioned. For only hearing ear, I have many options. Number one, observation. If it doesn't grow that much on observation, I'll just keep observing until the hearing is good. Second option is I will implant the other ear and then take a call of surgery on this ear. And if you are operating, you can do a partial resection. You can decompress the intra-auditory canal to release the pressure on the cochlear now by slitting the intra-auditory canal from behind, just to decompress, not removing. Or you can use radio surgery. So all those means you can use to preserve the function, the hearing in those situations. Yes. So now we are ready for the surgical part, and we can take
bilateral cases. And what's the indication in that case? Which you operate first, and what are the indications?
In the NF, in an NF2 is a different entity. NF2 is a more severe situation. That is autosomal dominant situation. And NF2 tumors are more aggressive, more invasive. NF2 patients have a limited lifespan as well, and they have a tendency to develop multiple tumors at multiple levels at the neural axis. So taking a call of function preservation in NF2 is really difficult situation. Sir, Achal boss at the institute, you must be having, Pankaj boss have a lot of experience about the NF2. NF2s are most difficult tumors to tackle. Can you speak something about NF2? Please, Achal boss, Pankaj boss. Sir? Boss, unmute.
Yeah. I think what you said is absolutely true. Neurofibromatosis type.
We can discuss until I will wash up. Yes, sir. Continue.
The tumors in neurofibromatosis type 2 is completely different. They behave differently, they grow differently, they tend to involve the nerves more often. And because you have tumors bilaterally, you have various combinations of problems that you can have, including the degree of hearing involvement, the degree of other comorbidities, and the other tumors that the patient might have. So these are situations where you can consider, especially when you have larger tumors. And usually the way we see it is you have two large tumors. One side hearing is very significantly on the other side there is some hearing preservation, and you want to keep them intact as far as possible. These are situations where you can consider doing a planned subtotal removal and follow them up. The other thing for smaller tumors is to give radio surgery upfront, but invariably these people do progress, and there's a very high probability that they will over time lose whatever residual hearing. So it's very important to psychologically prepare them as well to be prepared to lose their hearing over time.
And in these specific tumors like the case operating today, as I said that sometimes it is difficult to manipulate, so we tend to leave the capsule behind. So when we keep the capsule behind, is there any chances of recurrence?
Yes, but Paramita, this has been very well answered earlier. Can you hear me?
Yes.
See, leaving a small part of the tumor, a sliver of the tumor, close to the critical structure is a good thing. It's a good strategy. That small part may not grow. Majority of the times, if you follow, it doesn't grow because that may have got devascularized, number one. Even if it grows, you have an option of addressing it again by surgery or by radiosurgery. If it doesn't grow, you don't do anything. If it starts growing and feasible, according to age and other factors, you can give gamma knife, simple. Or if it is bigger one, grown up, then you can again take a call of surgery. But the most important thing at that time is to preserve the function.
Absolutely.
Satish was comment on sudden onset hearing losses and acoustics.
Yes, that is important. That's an important point, boss.
Because we've lately had a lot of issues. Yes.
In our practice, we see a lot of sudden sensorineural hearing loss patients. up to 8% of the acoustic neuromas present with sudden sensorineural hearing loss. Up to 8%. Are you getting the picture?
Yes.
Yeah, very well.
Yeah, this is right here. And first of all, I'll come to that sudden sensorineural loss part, boss. My incision is an extended retroauricular incision because I have to do extensive drilling behind the sigmoid sinus as well, all around. So this is the extended retroauricular incision, a simple incision. And I need to have a good periosteum flap as well when I obliterate my cavity with the fat. That should be something to hold the fat in place to prevent the CSF leak. Hello? Yeah. So coming to the Sandeep Boss point. Sandeep Boss point about a sudden sensorineural hearing loss. Up to 8% of the acoustic neuroma present with sudden sensorineural hearing loss. And in those patients, you know, I would always advise or advocate MRI. Always.
Absolutely.
Many of the patients, in spite of having acoustic neuroma, with your conservative treatment, improve. Many of the patients improve.
Yes. Absolutely.
But that doesn't rule out the possibility of vestibular schwannoma. Even with the vestibular schwannoma, many of the patients improve with the conservative treatment. Still MRI is indicated because it doesn't rule out the vestibular schwannoma. Always order an MRI in all sudden sensorineural hearing loss patients. An improvement in the condition doesn't rule out vestibular schwannoma. That is important.
You said the slow-growing tumor. What is the criteria of slow-growing tumor in like acoustic neuroma? What is the criteria of saying? What is the criteria of saying slow-growing tumor?
Okay, slow growth. There are many definitions, but by and large I tell you, if the growth of the tumor is less than 2 millimeter a year, is considered slow growth. More than 2 years is considered, you know, fast growth, and then you have to take a call. The reason is, in that case, if you don't take a call and allow the tumor to grow, being asymptomatic, you may have to pay a big price for observation. Because we all know the function preservation, the condition of the function preservation becomes less and less, the possibility becomes less and less in the bigger tumors. Only the smaller tumors gives you opportunity to preserve the hearing as well as the facial nerve best. According to the larger studies, you know, all tumors above 2 centimeter, they have very remote possibility of a, you know, serviceable hearing preservation in long run. Even if you preserve in the short term, it deteriorates with time because of the ongoing fibrosis of the cochlea because of devascularization. So even if you are happy with preservation in the short run, it is actually not the goal achieved. So any tumor about 2 centimeter, according to Mario Sana, even 1.5 centimeter, the long-term serviceable hearing preservation is not possible. That's why he advocates all tumors above 1.5 centimeter, cisternal component. 1.5 centimeter means 1.5 centimeter cisternal component. You know?
Okay.
In the angle.
See now, this entire thing will come. I will not open the canal, and this will protect my, you know, the fat which I am going to push. I hope you got it what I am trying to say.
Yes.
What is the involved?
Pardon? Paramita, I can't hear you.
I'm saying, what if the tumor is involving the trigeminal nerve? Then what will be the approach?
Try the same one, the acoustic neuroma, the bone wax. Suction. Acoustic neuroma involving the trigeminal nerve. Involving means like any other nerve. It is not invasive tumor. Then
Compressing.
compressing the trigeminal nerve. You have to separate. The treatment is same. Dena bone wax. See, this is emissary vein. Can you see?
Yeah,
Yes,
very
yes.
good.
For controlling the bleeding in lateral skull-base surgery, there are many ways. For soft tissue bleeding, you can use cautery, you can use Surgicel. For bony bleeding, you can use either bone wax or your diamond drill. The dry diamond will clog the vessels, and you will see in this case as well, we'll be using all these maneuvers to control the bleeding.
There have been few articles about giving intraoperative vasodilators. So what is do you
Nimodipine.
Yes, sir.
Yeah, this has been evidence proven.
Yes.
Nimodipine, the neurosurgeons using nimodipine at various levels, not only this. But nimodipine is something which helps in nerve regeneration, It is always, we always add the nimodipine after, such surgeries to improve the nerve function. It helps in regenerating the nerves. It's a good
practice. What is the most common clinical presentation of these cases, like symptoms, signs?
Pardon?
What are the most common clinical presentation you observed in these cases in practice, clinical practice?
Acoustic.
Yeah, acoustic.
Acoustic. The most common presentation is hearing loss. Second most common in our practice is tinnitus. And it is unpredictable whether the tinnitus will, be relieved or not. And third is the vertigo. That is least common. It is in up to 20% of the patient. If vertigo is there, is a strong indication for surgery.
Yeah.
Satish,
Yeah.
any psychological symptoms of
Any?
Psychological symptoms?
Psychological.
Yeah.
Can you elaborate what you mean to ask? I didn't get.
Any manifestation like when the brainstem is compressed and the other involved?
No, it is not.
These are neurological symptoms, you can say. Why psychological?
Brainstem compression.
Yeah.
These symptoms can be because of secondary to the hydrocephalus in cases of large tumor.
Yeah, if the tumor is more than 4 centimeters, they complain.
No. Yeah, it can be. It can be more than 4 centimeters. It can be even in 3 centimeter tumors.
Yeah.
See, it is not always the obstructive kind of hydrocephalus. It is not always the tumor which is causing compression over the ventricular system, means fourth ventricle.
Yeah.
But there is some hypothesis in some literature. It has already been mentioned. It has been mentioned because of these tumors. There is a high protein secretion of the CSF.
Yeah.
So there can be communicating kind of hydrocephalus maybe there. And about the symptoms, what you are talking about, the psychological symptoms, basically the frontal lobe signs.
Yeah.
That is secondary to the hydrocephalus.
Hydrocephalus. Yeah. The one case is presented as.
Pankaj boss.
Yeah.
Since you are attached to the institution, I'll have opinion from Achal boss also. What percent of the cases you get advanced tumors? What percentage?
I think.
Presenting with hydrocephalus and brainstem compression and all those.
It is 60 to 70% cases.
Oh. How much? How much?
Very high.
60 to 70% cases.
Very high.
Because they are presenting very late. They are diagnosed very late.
Slow growing, no? Slow growing.
Yeah. But 60%, 70% is too much.
Yeah. When I was in SMS, it was just more than 70%.
Achal boss?
Because I think he had left.
So how many patients are having headaches, sir? Pankaj, sir?
Most of the patient.
Headache?
Yeah. Headache due to raised ICP.
Yes. If the protocol consists of any CT scan routinely for all the headache patients, maybe we get early detection.
No, they should all the headache patients, in my opinion, should be investigated.
Ideally, all tinnitus, all unilateral deafnesses should be investigated with an MRI. Otherwise, we'll never pick up small ones.
That is our symptoms. No, when you come to the headache, it is very common.
Exactly.
Satish sir.
Yes.
So Dr. Kranti Bhavna from Patna is asking about the details of the flaps that you are using.
Yeah, that's what I was about to tell.
Yes.
See, this is a thick flap down the periosteum I have raised to cover my defect finally. And these two flaps which I have raised are small flaps. You know why I have raised these small flaps? Before I bring this large flap down, I will keep through my, tie down threads. Keep my fat compressed with these two. I will use my tie down threads from here to here. 3 or 4 threads to keep the fat in place. And then finally I will bring this thick one until the skin so that my fat will not protrude. It will remain compressed.
Yes.
Okay? This is just to take the advantage of the threads. I raise this kind of a flap.
So Dr. Umesh Tone from Nasik is asking the indication for the gamma knife.
Yes, indications for the gamma knife I have already mentioned. For small tumors even, we advocate gamma knife only in the elderly patients when the tumor shows the signs of growth. To me, this is one indication and the most important indication. I have already mentioned in the elderly patient, we can observe the patients, The intervention is required only when the tumor shows some signs of growth. Okay? Some signs of growth. And once those patients show signs of growth, you have to take a call. If they are good surgical candidates, still you can take a call of surgery. But since it is a small, slow growing tumor, an elderly patient pushing for this major surgery, the best is to advocate the gamma knife. Gamma knife is not going to kill the tumor. It is going to contain the tumor. It will prevent the cell division. So that it will prevent the cell growth. And we all know, even after the gamma knife, after a certain period of time, the tumors show growth. But in elderly patient where the life expectancy is not about 25 years, you can take a call of gamma knife for those patients. For gamma knife, there are a lot of literature, there is varied opinion about the gamma knife. A lot of people claim very good result, 95 to 100% with the gamma knife. Believe me, majority of those studies are not long-term studies. Majority of those studies are not done with a control arm. And those results are always false results. I tell you, the indication of gamma knife is not for every acoustic neuroma. For only those on observation start growth. Now if you are giving gamma knife to all patients and showing your result 90%, that is not true result. We need to know the long-term results of those patients where the gamma knife was given only after seeing the signs of growth. So that's why the results of gamma knife, what we see, are not true reflection of the actual results of the gamma knife. Reverse karo. Reverse karo. Drill.
Satish.
Yes, sir.
Can you hear me now?
Yes. Yes, sir. Now better.
Can you hear me?
Yes, sir. We can hear you.
In elderly patients, even if the tumor is symptoms which are handicapping him, he doesn't do anything. He should be handicapped, and the hearing loss is not a handicap. Okay, for elderly patient we're talking about. People who are retired, we are sitting at home and they're not very active. If we get a disabling and steadiness, then that is a necessity for treatment, whether surgery or gamma knife. And Satish, what happens? Some of us are totally anti-gamma knife. Some of us are pro-gamma knife. I want neurosurgeon's opinion on it. Dr. Panikkar, what is your indication for giving gamma knife? Dr. Panikkar? After the subtotal resection, if the tumor growth, elderly patient when start growing, there is no otherwise. Let a neurosurgeon's opinion come in here.
See, gamma knife is it's a great tool. In the right patient, it's a fantastic tool. The problem is it often gets misused, and I always say the gamma knife should never be an excuse for bad surgery or an excuse to avoid surgery. What is unfortunately happening is there are a whole lot of people who will counsel the patient now saying that surgery is very morbid. You should not go in for surgery, but just go in and do a gamma knife, which is absolutely wrong. So the decision about whether you use gamma knife or whether you use surgery has to be the decision of the treating surgeon, not anybody else. Gamma knife, as has been rightly said, my indications are largely for small residual tumors that show growth on serial imaging. Very small intracanalicular tumors with a reasonably intact hearing, which show growth on follow-up, those ones, where there's a patient opts for a gamma knife, where the patient says, I do not want to have open surgery, and the tumor is fit for a gamma knife. But again, the important thing is the criteria of size. We sometimes see patients with 2 centimeters or more tumors, or even 3 centimeter tumors being referred for radiosurgery, which is absolutely inappropriate. The important thing to understand is the smaller the tumor or the smaller the tumor fragment, the better are the results and the less are the problems with radiosurgery. This is very important to understand.
One more point I would like to add over here when I'm doing mastectomy, sir.
Here, one thing, Deepak, Dr. Panikar.
Yeah.
Majority of neurosurgeons are trauma surgeons.
Pardon?
Majority of neurosurgeons are trauma surgeons. And
No, I don't agree.
Surgeon who are tumor surgeon, about 50% are lesser than a good tumor surgeon. Is it the right statement or wrong statement?
But sir, the young lot is all,
I would disagree with that. I would disagree with that.
It sounds like a drastic statement. See, now the last 10, 15 years, everybody is taking a lot of effort to learn every surgery, and that is true in the ENT also. For example, colostomy surgery, which was done by, let's say, 10% of ENT surgeons good. There may be 40% of people who are doing colostomy surgery. So the facilities to learn the surgery because of various workshops, various conferences, various YouTube availability is much better. We are getting better and better. Everybody is getting better and better. Whether it's an ENT surgeon, neurosurgeon, cardiac surgeon, whatever, because facility of learning are much more than what you were there once upon a time.
Yes, sir. Can I say one thing? Diamond, buddy. Hello. I tell you why I'm saying at this point of time while doing mastectomy. I have seen neurosurgeon doing mastectomy so fantastic. I have already mentioned, like, the Panikar sir, he does.
Let me tell you, there are not even 5% of neurosurgeons who can do good mastectomy. Let me tell you. Let me say in front of neurosurgeons.
Why I'm saying this?
It's not necessary for neurosurgeons to learn mastectomy. It's not necessary because this is a teamwork.
Yeah, but see, sir,
Panikar, are you doing mastectomy yourself or your ENT colleague is doing that for you?
Diamond.
I have learned it, so I can do my own approaches. But there are a lot of neurosurgeons who will depend on an ENT surgeon to do their approaches for them. I think it all depends on what you choose to learn. It's like
that is important, sir.
It's like the endonasal surgery now.
Can I add on, sir?
Yes.
It's like endonasal surgery.
Yes.
For PCs.
Yes.
Usually you have a team with an ENT surgeon and a neurosurgeon who will do the surgery, which is optimal. But we do know that there are either surgeons who can do the other procedure all by themselves. But it's all what you choose to learn. But the majority of us prefer to work with a colleague who is more adept at doing the other part, and that is what it's a teamwork that gives you the best results.
Yes.
Very
well said.
Hello.
Panikar sir, what is your experience of operating a case already given radiotherapy or gamma knife?
Drill.
Bad.
Hello.
That's bad.
Hello.
Sir, Satish sir.
Can you see some line of pani dal yaar?
Satish sir. We are with you. You were trying to say something?
Yeah.
Yes, sir.
Are you seeing some landmarks coming into the picture?
Yes.
We can.
So I was just quickly doing the lateral cortical part.
Yes.
See what I'm trying to say in contrast to a regular mastectomy. What I'm
Yes.
doing, this is your sigmoid sinus going down.
Yes.
This is your middle fossa plate.
Yes.
Herein, you have to go beyond and decompress it to give a wide approach, you know.
Yes.
Now, secondly, diamond. Every time I am changing to the diamond burr in between for the sake of controlling the bony bleeding. See this?
Yes. Yes.
You run the dry diamond, by means of the, bone dust, you clog the bleeders.
Yes.
This is important to understand. So here, I will keep going around the limits, going around the sigmoid sinus, going around the middle fossa plate so that I can wide decompress them to improve my access. So this approach,
so an extended middle translabyrinthine approach. When you're decompressing the dura,
that is not.
Sigmoid sinus, and dura you're decompressing in the middle fossa area. That is called extended translab approach.
Enlarged translabyrinthine approach. This is enlarged. The extended is once you drill the intra-aortic canal more to give a transapical extension. This is enlarged translabyrinthine approach.
You are right.
Yes, sir.
Satish?
Sir, so about this transapical approach that you said, so in which cases will you go for transapical approaches like 320 degree and 360 degree?
Yeah. Let me first, Diamond. Let me first tell the nomenclature to everyone.
Yes, sir.
I have already mentioned this is enlarged translabyrinthine approach.
Yes, sir.
Now what Paramita is asking is the transapical extension. In this enlarged translabyrinthine approach, we open the intra-aortic meatus by around 270 degrees.
70 degrees.
Yes. Beyond 180 degree, more and more, almost up to 270 degree. In cases where the tumor is extending far anteriorly towards the, towards the bones, far anteriorly towards the anterior to the brainstem, you can give anterior extension by drilling the intra-aortic canal more.
Yes.
So the transapical, what Mario Sana has given, classified transapical 1, when you drill the intra-aortic canal by 320 degree and 360 degree when you drill, it is called transapical 2, and that is many times required for meningiomas, with huge anterior extensions, if you are doing.
Yes.
Now at this point of time, my first landmark as I go deeper, see, I am not pressing these sinus and the dura more now. Because if I remove the bone now, it may hamper my, deeper drilling. I may damage the dura while drilling deeper down. So I will keep the bone intact here. And at the end, before I drill the deeper, when I drill the deeper part, I will come back and finally decompress the outer part. Okay?
Yes, sir.
Now my next landmark as I go deeper. My first anterolateral limit of the translab approach is the vertical segment of the facial now.
Yes.
And there are many landmarks to find the vertical segment of the facial now. See what is this? This is mastoid tip.
Yes.
See in the medial part of the mastoid tip, if you follow the ridge, that is digastric ridge. See, this is digastric ridge.
Very well.
Can you see? If you follow this ridge, anteriorly, where it ends, immediately medial to that is the facial nerve, the vertical course of the facial nerve, where it comes out to the stylomastoid foramen. Can you see this horizontal ridge?
Yes.
This is attachment of the digastric muscle. See this muscle? You can see the muscle popping out. That's the great landmark for the facial nerve. So my anterolateral limit is going to be the facial nerve. Now to see the facial nerve, I will define my facial nerve and I will stay medial to it to make my limit. Now see, the other landmark for the facial nerve we have discussed in temporal bone several times. I always take into consideration is the incus. See the short process of the incus coming into the picture.
Yes.
Can you see?
Yes, sir.
Sickle there. Goal there. Goal. See, this is the short process of the incus.
Yes.
My facial nerve, the horizontal segment, genu and the vertical segment, if I follow, the incus is always a lateral limit. Incus covers the facial nerve like mother's lap. If I go parallel to the incus, I will always preserve the facial nerve medial to it, as simple as that.
Yes.
Now, we were talking about the teamwork. Sir was talking about the teamwork. Believe me, I have seen the neurosurgeon doing with the same efficiency. When we have worked together, the Pankaj was being a neurosurgeon, he does such a fantastic mastectomy. You will not believe. You will not get to know whether the ENT surgeon is operating or a neurosurgeon that time. When we are doing endoscopy, the same thing we are doing. And the biggest advantage of doing it, what Morwani sir is saying, is the teamwork. The ENT guy can do in the team. Yes, he can do. But see, the active involvement of both the sides gives you the active hand. And that is more important in endoscopy. Like when we are doing endoscopic skull base together, supplementing each other with the active hand is amazing. That's why both ENT and neuro should be well versed with the anatomy of both the regions. Like if he is operating intracranial and I am assisting actively, is a big gain. If I am doing extracranial, so the active involvement can happen only when you know the entire depth of the anatomy of both sides.
Yes.
That is the main purpose of conducting such webinars, and so all come together.
Someday I can show the Pankaj was demonstrating a good face. He does the face so good, you can never appreciate that a neurosurgeon is operating.
Next case.
Satish.
Yes.
Satish.
Yes.
Endoscopic surgery can be 300 and 400 surgery. Transmastoid surgery is not 300 or 400 surgery. There's a major difference. That's why the neurosurgeon and ENT surgeon depend on each other totally. Whereas neurosurgeon can do a acoustic retrosigmoid approach without any help from the ENT surgeon. Where most of them believe that the retrosigmoid approach is the only approach for this kind of tumor.
Yes.
Where they've been trained that approach only.
Now, can you see the facial now coming into picture?
We can see it very well.
Yes, yes.
See, I am drilling still with a cutting bar,
Yes.
but softly. Now, at this point of time, I must enumerate, Diamond. If we are doing translabyrinthine and enjoying the good access of a pneumatization, believe me, it is at the same time counterproductive as well.
Yes.
More the cells, more are the chances of CSF rhinorrhea if you don't close them effectively.
Yeah.
Particularly here, see, at the facial nerve level, these retrofacial cells and the facial recess cells, these are, most difficult cells to deal with. And you must close each and every cell with a bone wax before you open the CSF space. The reason is, if I open up the CSF space and then apply the bone wax, the CSF which is draped the bone will not allow the bone wax to stick so well. So you should always apply the bone wax and close this cell before you open the CSF space. That is most important. Otherwise, if any of these cells communicate, with the CSF later on, the CSF rhinorrhea is more likely. The reason is, these cells have a lot of communication by the infralabyrinthine and supralabyrinthine roots to communicate with the petrous apex cells and then to the eustachian tube.
Yes, that is the comment.
So always obliterate these cells before you open up the CSF space. That is bottom line. Because if you don't do before that, if the CSF comes in contact with these cells, bone wax is not going to stick so well.
Okay.
That is a big problem, and you have to anticipate this and you have to close all these cells before. That's a very important practical point.
Yes.
Now see, I have seen my anterolateral limit. See my facial now?
Yeah.
And see, this is the digastric ridge, and see where it is pointing to. That is your facial now. Got my point?
Yes.
Yeah, beautiful, beautiful.
So digastric ridge, if you ask me, a single most important landmark for the vertical course of the facial nerve is the digastric ridge. It's amazing landmark. It is the body's natural anatomy which we are taking advantage of, you know. Sickle. Now at this point of time, yes.
Yeah. Can I ask one question, please?
Yes, please.
Yeah. Satish, for hemostasis purpose, you are using diamond bar for controlling the bleeding.
Yeah.
What is the effect of the diamond bar? It's only drilling effect of the bone dust or a thermal effect by the diamond bar?
Yes, I am using both. Good point, you have caught it.
Yeah.
See, I am using diamond for both the purposes. Hemostasis, in between I am changing.
Yeah.
But at the same time, I am using, see, intermittently you won't see the irrigation.
Yes, yes.
And I am using diamond bar to clog these cells. Can you see?
Yeah.
Okay,
I got it.
The moment you use diamond, with the bone dust, you clog these cells.
Yeah.
See intermittently what I am doing with the diamond.
Almost like obliteration.
Yes.
Yeah,
See here
bone-
in the facial recess what I have done. Use the
Yeah.
diamond.
Yeah.
Now I have removed the incus, you have seen?
Yes, sir.
So that I can effectively, you know, obliterate the editors.
Yeah.
Yes, with periosteum.
Yes.
Yeah, because some of the junior surgeons, when they try to attempt the controlling of the bleeding with the diamond bar on the facial nerve, they result in facial paralysis.
Yeah.
To control the bleeding, or sometimes they use or the diamond.
Overuse at that time.
Yes. Now see, where I am working is the retrofacial cells.
Yes.
Retrofacial cells, if I follow like this, I will go to the infracochlear cells and then to the petrous apex. And here we don't want that communication.
Yeah.
So here I am using diamond bar and ultimately will clog with the bone wax also.
So
This is to pneumatize the bone, and I will practically be more cautious about, you know, closure of all these cells to prevent the CSF rhinorrhea.
and not blocking the connection between the hypotympanum and this retrofacial cell. Because this leads to hypotympanum, no, you leave it.
Yeah, see now? These are all
Get us to
cells.
the jugular bulb also.
Yeah, here I am going to the region of the jugular bulb. We have already seen on the CT scan, and here my jugular bulb is going to be my lower limit. You can see the color change.
Yes.
Absolutely.
The cochlear aqueduct is a lower limit. You don't have to go up to the jugular bulb.
Sir, your voice is like you are drunk.
Cochlear aqueduct is a landmark. I am drunk in your company.
Yeah, I think your internet connection is a problem. I think you can do something.
Yeah, that is a problem.
Sir, as far as cochlear aqueduct is the lowest limit actually.
Yes, I will show the cochlear aqueduct. I will show you all cochlear aqueduct. Now see my jugular bulb, the lower limit.
And why that is important cochlear aqueduct? Because if you go near to that, there is a possibility of damaging that.
Glossopharyngeal nerve. Yeah.
See this. This is your lower limit. Now cutting this. Now your labyrinth is coming into the picture. Can you see? This is your lateral canal, this is your posterior canal, and this is your superior canal. We have seen this, anatomy of these canals in the temporal bone dissection. So here, since this is a translabyrinthine approach, we are literally going to go through the labyrinth,
So, sir, in retrosigmoid approach, is the endolymphatic duct the lateral limit?
In retrosigmoid, that is your safe lateral limit. Lateral limit means you have to preserve it.
Yes. Otherwise, we will lose the hearing.
End up losing the hearing otherwise.
Yes.
When you are drilling the intraocular canal, you mean
Yes.
See, in translab, one of the biggest, in comparison to the retrosigmoid, one of the disadvantages of the translab is the long drilling.
Yeah, 10
Yes.
Retrosigmoid had I been doing, I would have been right on the tumor by now. ये बंद हो गया. I would be on the tumor.
By damaging the endothelial duct or sac, you don't get deafness. Okay?
You make it, sir. You're likely.
So, but that gives us a limit not to breach it. Otherwise, you open into the posterior semicircular canal while drilling retrosigmoid.
Sandeep, Sandeep, I
Sir, good afternoon. Good evening. Good evening, sir.
बड़ी देर.
हाँ sir.
Yes. Sandeep Karamkar.
Sir.
Good sir.
Yes.
जमाना था 40 में लड़कियों का हमारा पेशेंट था, अभी बुढ़ा हो गया लड़कों का भी हमारा पेशेंट था.
Can you see the labyrinth much better now?
Yeah, we can see.
And see, this is what I have skeletonized the pre-sigmoid plate. Anterior to the sigmoid, you know.
Yeah, pre-sigmoid. Okay.
Lot of people have devised the retro-labyrinthine pre-sigmoid approach. In certain possible cases when you have a good pneumatization, by going to the CP angle, preserving the hearing. But there has to be good space behind the labyrinth and anterior to the sigmoid sinus.
Satish, that approach can be extended by drilling the partial thickness of the posterior cervical canal bone and the lateral canal bone also.
You know, the idea behind that is still you can preserve the hearing. Because the drilling the canal means, for everyone, drilling those canal means drilling the bony canal and obliterating the membranous canal so that you don't communicate with the vestibule. Still you can preserve the hearing. And that way you get, if I drill away this posterior canal, if drill away lateral canal, I get more space. But protecting the membranous canal and obliterating that, that is the idea behind that, drilling the canal.
That is,
yes.
in less pneumatized cases, it is possible.
Pardon?
Less pneumatized cases, this approach between the labyrinth and the sigmoid, access to the tumor, is it possible?
Through this?
Yeah, I know.
In this patient?
Yeah.
In this patient, not really.
Yeah.
That is mainly used for doing other procedures like vestibular nerectomy, some very small tumor at the CP angle, not for larger tumors like this.
Okay.
See, I am leaving everywhere the bony plex intact. Can you see?
Yeah.
And once I remove these bone plates, these or this, I will decompress it to widen. Then it will be much wider. Okay?
Correct.
Now let me drill the labyrinth. See this, we have already seen the lateral canal.
Yeah.
See the lateral canal I am drilling. See the ampullary and non-ampullary end.
Yes.
We saw this anatomy during the temporal bone dissection webinar.
Yes.
Now this is the posterior canal I am drilling. See that?
Yes.
All these canals have a close relationship with different parts of the facial nerve.
Is it 3 mm barbed?
Yeah. See, this posterior canal has a relationship with the vertical portion of the facial nerve.
Yes.
This lateral canal has a relationship with the genu of the facial nerve.
Second genu dissection.
This superior canal has a close relationship with the labyrinthine portion. See, this is the ampulla of the superior canal here. So this is the ampullary end of the lateral canal, non-ampullary end, ampullary end of the superior canal, ampullary end of the posterior canal. And if I drill away further, you will find the non-ampullary end of the superior and posterior joining each other to form the crus commune. See, they are opening in the vestibule. I am drilling away them fast with a cutting bud to save time.
Now we are in retrofacial area.
These are the same steps for the labyrinthectomy. If somebody is doing labyrinthectomy, Labyrinthectomy, the surgery we do for the for the difficult menial disease not coming under control and the patient has already lost the hearing. If patient is not elderly, where the compensation still can happen, labyrinthectomy is the treatment of choice. And that labyrinthectomy, for that you need to drill away the labyrinth like this, what I am doing. All semicircular canals, remove the neurosensory epithelium, including the epithelium from the vestibule.
What's the success rate?
That is transmastoid. Lot of people have described the transcanal labyrinthectomy as well. You can do, but that is never so effective as compared to the transcanal.
Sir, can I ask a question?
Please.
Dr. Kranti Bhavna has joined us.
Yeah.
Kranti.
Hello, sir. Hello, good evening, sir.
Welcome, welcome. Kranti is working in a premier institute and I have had a pleasure of operating acoustic neuroma in AIMS Patna in a workshop.
Ultimate case.
It was an excellent case.
Thank you, Kranti. Kranti is, she is prominent and working too hard to develop that department they have established. She has done a lot of work in cochlear implant surgery as well.
Currently struggling with COVID, sir. Totally doing
I know you have been fighting since day one, I saw. Superb.
Sir, I have a question about the labyrinthectomy.
Yes, your voice is breaking.
Hello, sir.
Yes, I
Hello?
can. Yes.
Yeah, it's okay.
Just one. I have a concern about a patient which we operated, that he had a labyrinthine symptom of vertigo for a long time, at 3 months, 4 months down the line. And we had an MRI, excellent results, no residual tumor, and everything is fine except that he has vertigo and vomiting.
See, the post-operative vertigo settles down with the compensation once you have removed the labyrinth.
So your experience as to how long does it
Generally, it doesn't take long. Generally, in larger tumors, already the compensation have occurred with the growth of the tumor. They are slow-growing tumors. Secondly, the problem of compensation happened to occur in elderly patients.
Yes, he is true.
Yes. On patients having central nervous system diseases affecting the compensation ability. Otherwise, compensation is never a problem.
Yes. So, now he has compensated well though. So he's
most of these patients are well compensated, and most of these patients will discharge in 3 days' time.
Okay.
So was he having severe vertigo or it was mainly ataxia?
It was ataxia per se. Or what was actually happening is when he was getting up from bed, it was some sort of vertigo for a while and then severe ataxia, and then he used to literally, vomit and then feel very prostrated.
Yeah, that is grossly uncompensated patient.
Yeah, and it has taken
And it may
around
take time to settle, but ultimately he'll settle down.
Yeah, it has settled down now. It has settled down. But we really had difficulty explaining the and his attendance.
Yeah, sometimes.
So many patients we did, but none of them had this kind of an issue.
So every patient, the reaction is different.
Very true.
So Dr. Pawan Singhal is asking, can we preserve hearing somehow with some modification in translabyrinthine approach?
Yes, a lot of people have, published the modification of the translab, like Sir had mentioned just now. They do the translab by drilling away the canals, preserving the, the membranous labyrinth, and packing the membranous labyrinth, pushing down to close the canal as well as the vestibule, so that it doesn't communicate to the entire system. And still you can preserve hearing in some patients. Though that is not standard of the care, it is never followed. And secondly, it compromises with your exposure as well. So that is not a standard of care approach. I mentioned there are a variety of techniques besides these 3 techniques. I mentioned the middle fossa, translab and retrosigmoids. Besides that also there are many techniques, but those are not standard of care.
Yes.
See, this is my area of the intra-aortic meatus.
Yes, sir.
See now what I'm trying to say.
And
This
very,
is
very,
external aortic
very-
meatus. Can you see?
Yes, yes.
Centralized.
In the same line is the intra-aortic meatus.
Yes.
Extra-aortic meatus, here is the intra-aortic meatus.
Yes.
What is projecting is, as my lateral limit is the facial now. See this?
Yeah.
Yes.
Vertical segment.
Yes.
Satish, yes. Can you hear me?
Yes.
Yes, sir.
Yes, sir.
Satish, you remember first acoustic neuroma I did in your place about 12-15 years back?
Yes.
A 13 or 14-year-old boy, he was running around on third day. And
Yes,
you
yes.
discharged him on fourth day. You
Yeah,
remember
yeah.
that boy?
Well compensated.
Yes, 13 or 14-year-old boy.
I remember
And he
in our
was
workshop.
walking around on second day and running around on third day.
That was in our workshop. See, this is your labyrinth, vestibule.
Yes,
First
sir.
acoustic neuroma to stop.
So we can also see the endolymphatic duct there.
No.
Duct.
Yeah, this is endolymphatic duct.
Duct. Yes, that is the duct.
Can you see?
Yes, yes.
See, this is going to the vestibule. See this?
Yes, sir. Yes, sir.
It's more of a sac than the duct. Duct will be little anterior. It's more of a sac, what you're saying. Whitish fibers, what you're saying.
Now, before going to the depth and happen to open the cochlear aqueduct or the, the CSF space, I will use my diamond. Give me diamond, buddy. And close all the air cells. Close all the air cells. And I will apply. Buddy, I will apply. Like, see my diamond. What I am doing. I will close all the air cells around.
Yes, sir.
Okay.
Sir, one more advice as to when you are drilling around the vestibule area,
Yeah.
how do you avoid entering into the, stapes? That is one of the complications which might happen.
Yeah, that's why your direction of drilling in the vestibule should be medial.
Okay.
And see, I have skeletonized the vestibule here. See this? Can you see?
Yeah.
Yes, we can see that.
So, as I go medial would be the intra-aortic meatus.
Yes.
So, if I go anterior, I am not supposed to go anterior there.
Yes.
And don't forget to show us the fat harvesting. People want to see.
Fat harvesting?
Yes,
No,
yes.
sir, the way you put the fat is one of the best thing which I
Even
learned.
how to harvest it.
Okay, boss. Because that part is done by our other team to save time. Okay. Now see,
Yes, sir.
I will specifically address some group of air cells here. See, this is the tip.
Also explain the superior and inferior aspect.
Yeah,
as to
the most important are
superior
these
crop and
retrofacial.
inferior crop.
These retrofacial air cells and the facial recess air cells. See this?
Yes, sir.
Parimata.
Yes.
These should be
Kranti.
completely closed. These should be
Question for you.
completely closed. See this?
Okay.
Cauda tympani.
Yes, sir.
Yeah, we can see.
These should be completely closed to prevent the CSF communicating with the any of the petrous apex cell.
Yes.
See now, completely closed. Now give me bone wax.
Dr. Kranti, question for you. How you manage that case for 3 months, 2 to 3 months?
Oh no, so that's it. So
Tough time.
basically,
Tough
it
time.
was a tough time. I had to admit him twice, and unfortunately, recent Corona time also had to admit him once. But all the moment that he used to respond with Stemetil.
Okay, Stemetil was there.
Yeah, it worked. It worked. And also some kind of, I started him on some kind of small VRTs, like in my lab, in my vestibular lab, and and also counseling. So usually they're very scared. They're very scared,
Pani matal yaar.
So usually he did and now he is okay. He is walking, and his son is in contact with us, and he's doing
Almost
well.
4-5 months are over.
Yes.
It was in February. It was in February.
Now,
Yeah.
It is now 4-5 months now. So he's doing well. And
Bone
the best
wax.
thing is MRI is excellent. There's no residual tumor. Everything is healed well.
Boss.
Here is fine.
Boss,
Yes.
see this area.
Yes, sir.
Periosteum.
Using the bone.
This area of the facial recess is most notorious.
Yes.
Any of the facial recess cells happens to, communicate anteriorly.
So does bone wax completely seal this off? I have read about cases where people have obliterated the area with bone wax, but it is not foolproof. So what is your opinion about bone wax versus other, be it cartilage or things like that?
Cartilage is different. See,
Okay.
on the bony surfaces, bone wax is the ideal material.
So Amit Kesri is asking, can we do cochlear implant in same setting?
Yes, yes.
While we,
What you have to ensure, what you need to ensure is an intact cochlear nerve, and at that point of time, you should be using the cochlear nerve monitoring.
Okay.
To ensure at the end of surgery, the intact cochlear nerve. Okay?
Yeah.
So then, sir, how will you ensure that?
The cochlear nerve monitoring.
Intraoperative. Yes.
You need to have a 8-nerve monitoring.
Yes.
8-nerve monitoring. A lot of people using ABR. ABR is a poor way.
Okay.
It is the 8-nerve monitoring which is ideal.
Okay. You must be using facial nerve monitor in this case, I think.
Yes, always. I would never advocate anybody doing this surgery without facial nerve monitor.
So could you also emphasize
Focus,
the
please.
current levels, people? It depends at how low levels that the facial is stimulating, and you can say prognostically how much well the patient will be. So could you just elaborate in that?
So when you use monitor, I will tell you. See, facial nerve monitor has many values. It is not only a great tool in identification of the facial nerve.
Yes.
That is important. One of the most important advantage. But at the same time, during dissection, if you are dealing with the facial nerve anywhere using too much of traction, it will warn you by the train responses. Then, at the end of the surgery, if your facial nerve is giving, response, that is a great relief to the surgeon.
Yes, sir. And the lower
Because
the
many a
threshold,
time, because of the traction, in spite of an intact cranial nerve, intact facial nerve, anatomically intact nerve may not be a functioning nerve. Because of the lot of traction and taking away the blood supply, you may not have that good facial nerve which is functioning. Can you see the glimpse of the intraocular meatus?
1 second.
Hello?
Little bit glare is there because the glare is little bit.
Glare?
Satish,
Yes, sir.
Satish, regarding the uses of the facial nerve monitor, what are the precautions to be taken by the anesthetist?
Anesthetist should not use a long-term, muscle relaxant, long-acting.
Yeah.
A lot of anesthetists avoid muscle relaxant.
Okay. Only IV anesthesia you will use.
Yes.
Relaxant.
Can you see the proposed site of the intraocular meatus?
Yes.
Yeah.
Now we can.
And see what I am creating. See, this is the bony wall which I have little broken. See that? Hello?
Yes, sir.
That is the periosteum inside. Can you see?
Yes.
Yeah.
That is the periosteum here. Can you see?
Yeah.
So what I am creating, this trough above and below the intraocular meatus. See this?
Yeah.
See, throughout the time so far I have been using the cutting bar. Can you see?
Yes.
To expedite my process, you have to use it very, very gently. the entire bone should go. I will remove the entire bone of my limits from middle fossa plate to sigmoid sinus to everywhere to give a large exposure.
Satish, the important point is that till you are using a cutting bud, don't expose sigmoid sinus, don't expose pre-sigmoid dura, don't expose the middle clear fossa dura. You finish your drilling work, so the shaft of your burr point does not damage the soft tissue.
If you use it gently without using any pressure, diamond, pani mat dalna.
Sir.
See, this is my inferior trough, this is superior trough.
Satish sir.
Yes.
Dr. Vijendra sir is watching you. He's asking if you can seal the eustachian tube by amputating the malleus head orifice to prevent the CSF rhinorrhea.
Yeah, that is the final solution. That is the final solution, what he's saying. So we take that measure in the situation when you have a post-operative CSF rhinorrhea. You know, when you have seen the intracranial space having hair cells have communicated to the mastoid hair cells, giving the CSF rhinorrhea, and then to prevent meningitis as a final measure, by after any approach, maybe after retrosigmoid, maybe after translab, the final solution is subtotal petrosectomy and blind sac closure.
Yes, the Rambo's modification.
That is the final. You have seen last time the subtotal petrosectomy. You have seen the eustachian tube closure which I had done. The same thing. You have to remove all perisinus, pericarotid, peritubal cells. You have to clear all petrous apex cells, looking at your CT scan, and then finally obliterate and do a blind sac closure. Obliteration, eustachian tube, blind sac closure, and cavity obliteration.
So Dr. Abhilash, Alex is asking, how do you control bleeding from the subarcuate artery?
Yeah, diamond. See how I control the bleeding there.
Yes.
See, I want a more than 270-degree exposure of the intra-aortic canal.
Yes.
See this?
Yes.
I am close to the bone. See this here.
Yeah, we could yeah.
Satish?
Yes.
You have mentioned about the axis of the external artery canal, internal artery canal is not 180 degree and 150.
Yeah, this is roughly around 156 degree.
Yeah. It is towards the posterior and superior or posteriorly?
What?
When access to the external artery canal.
This is not directly 180 degree.
Yeah, okay, 180 degree, but 160 towards posteriorly?
I didn't get what you want to ask. Towards?
No. If you draw a line from the external artery canal into the internal artery canal, towards the internal artery canal.
This is more. See, external artery canal is not directly medial.
Yeah.
Internal artery canal is more directly medial.
Yeah.
That is the difference.
Okay. The inclination is towards posterior.
Yeah, that's why it is, because it is steep inclining.
Yeah, inclining towards posterior direction.
See the skeletonized canal.
Yeah.
A pre-operatively done CT scan gives you a lot of information.
Yes.
Mainly pneumatization.
The cochlear aqueduct?
Yeah, it is here. I didn't go.
Yes. I think it's coming up.
Leave it.
What I mean to do here, because there is extensive retrofacial pneumatization. See that?
Yeah.
I have a fear I may communicate with the infracochlear cells now. So I have diamond the entire area, you know, so that I will apply here rather than opening the duct there. I'll apply my bone wax to prevent the CSF leak. Extensive pneumatization of the retrofacial area is something you have to be very careful. See, now I'm using only diamond.
Yes, yes.
I'm skeletonizing the canal, you know.
Sir, in retrosigmoid approach, if the mastoid cells are open and if there is post-operatively, if there is CSF leak, then that means there's a bony fistula. So how will we control that CSF leak? What is the treatment? Will you
Blind sac closure, blind sac closure. That's what I was saying, blind sac closure. It will not be easily controlled with the conservative measures because it is not a soft tissue fistula. It is because of communication of the air cells. The air cells which is opening towards the subarachnoid space has communicated on the other side to the temporal bone air cells, you know.
Yes, sir.
And that bony fistula may not be sealed with the conservative measures. Conservative means raising the head end of the bed, you may put lumbar drain, all those. That may not seal. You can try for 2-3 days. If it doesn't stop, better not to take a chance and do a subtotal petrosectomy blind sac closure.
Yes, sir.
See, too much of the drilling required.
Yes. So what about the promontory testing? Do you do it intraoperatively?
Intraoperatively? Why?
Yeah, I mean, for the promontory testing, what will you do about the promontory testing post-operative? So,
Post-operative?
Yeah.
No, why? Why? I didn't know. What do you mean to ask?
You have any idea about the promontory testing that we do?
Promontory testing is done to ascertain the integrity of the cochlear nerve.
Cochlear nerve, yes, sir.
So like when you are operating, you can take a call of promontory testing.
Yes.
If it is intact, you can go ahead with the CI.
Yes.
If it is not, then you may have to take a call of ABI.
Is it done routinely?
Not really.
Okay.
See, this is pre-sigmoid dura.
Yes.
See, a lot of bone to be removed still.
Remember in Patna, it was very forward-lying sigmoid sinus. You had to decompress it.
Yes. I remember Morwani sir's case. What a tough time he gave me.
When?
In Mumbai, in his workshop, the tumor had a dimension of 20 square centimeter.
Oh my.
And the opening I had less than 3 square centimeter. See inferiorly?
Yeah. We can see the bulb, I think.
Suppose had I decompressed this lateral part first. This would create a lot of problem during medial drilling.
Yes.
डाल पानी डाल, सोए मत.
Yeah, your transverse crest is developing very well now.
अब एक साइड छोटा दे. See my periosteum of the intra-auditory meatus, bipolar.
Yeah.
All the way. I hope the picture is good.
Yeah, it's okay.
Yeah, it's good.
You can magnify a little bit, Satish.
Okay. Okay, sir.
You'll be able to see the periosteum and dura much better once you magnify.
Yes.
That's better.
Sir. Here, just before the fundus, you know, when I'm drilling the posterior part of the lateral intra-auditory canal, see, I showed you that landmark for the, the singular nerve.
Yes,
This is
yes.
posterior canal. This singular nerve emerges from here, from the posterior part of the intra-auditory meatus, few millimeters medial to the fundus. See this, where I'm drilling.
Yes.
And there it goes to the posterior canal. When we see transcanal, this area is just below the round window.
Yeah.
रुक जा. अब एक साइड पतली दे. See, my superior trough is not complete. एक पतला देना है.
Yes, unit 3.
Paramita,
Yes, sir.
we can take question whenever you get time.
Yes, sir. Can you demonstrate? Can you show the cochlear aqueduct when you are requesting they want to see?
It is here.
There's the surface marking where he's drilling now. There's a surface marking of the cochlear aqueduct, just superior to the jugular
It
part.
doesn't open the cells, that's why he's avoiding.
This is sometimes a
Need
good
a landmark.
strategy to open the cochlear aqueduct to release some CSF.
CSF, yes, sir.
Little bit deep.
But here I am not keen to do that. I have a very strong, retrofacial limmatization. Very strong retrofacial limmatization. I really want to, take away. And see here I am improving my 270-degree axis inferiorly. See this?
Yes, sir.
कैरिसन रखना, छोटा बड़ा दोनों.
So Dr. Amit Keshri was asking if we close the adductus well, that is, what is the need to obliterate all the cells?
If we close the
adductus well, then what is the need for obliteration?
See, editor blocking is a different thing. if don't get confused. Suppose if I communicate through my retrofacial hair cell or perifacial hair cells to the cells anteriorly, infracochlear cells, CSF coming over here will be drained through that to the petrous apex and then to the Eustachian tube. Where is the editors coming? Blocking the editors is different goal. That you don't communicate the CSF space directly to the middle ear. But this is another way, another pathway. That is another pathway that is equally important.
Bony fistula.
So there's one more question which is asked repeatedly by many, is that will you always get a contrast MRI done in every sudden SMHL cases?
Yes. Not contrast. A regular, yes, contrast is essential, but nowadays you can, if you get a good, 3D cis image, you can get a good information.
I think it has medical legal value also.
Yes,
Going
yes.
for MRI.
See my intraocular meatus.
Yes.
Please enlighten about the bony fistula, about cellular cells.
Pardon?
Cells act as bony fistula.
Bony fistula what?
The cells with mucosa, if you don't block it with bone wax.
Appara, can you repeat your question, please?
Yeah. The bone wax role of closing the cells.
Yes, for bony surfaces.
Yeah.
This is my superior trough. See this?
Yes,
Inferior, superior. See, you have to give a lot of time to this because this is important in exposure.
Otherwise.
बंद हो गया. This is important. Give me a small carison. छोटा वाला देना.
In Bhopal, we remember it's very small contracted mastoid.
Yes,
Quite
sir.
difficult.
Dubey, sir.
Dubey, I mean, I remember the Bhopal case. Yeah. Dubey, Dr. Dubey's place.
Yeah, I remember his case. We did at Bhopal.
So what about the superior petrosal sinus?
Superior petrosal sinus I will show.
Okay.
Once I do a wide decompression of the limits now, I will show. Here I don't want to compromise with the exposure now.
So now if it would have been a low-lying middle fossa dura, then what?
Decompress wide.
Okay.
People are asking, just define why these patients have poor speech discrimination in spite of.
Yeah, I already mentioned, because for the speech discrimination to be good, the majority of the nerve fiber should be intact.
Yes, yes.
Now this is affecting the nerve fiber, this is not affecting the cochlear hair cells.
Yeah,
it is the speech discrimination which is affected. That's why testing the speech discrimination gives you a better idea of the disease rather than pure tone audiometry.
Yes, rollover effect.
I mentioned.
Yeah, rollover effect.
See, this is my jugular bulb.
Yeah.
Sir.
Now I will come. I've already applied bone wax. Give me some bone wax there. I will apply some bone wax right in the depth. Yeah, yeah. In the retrofacial, I am very, particular about this retrofacial cell. These are the culprit. These are the culprit. Because the post-op CSF rhinorrhea, if happens to occur, is a disaster, The दूसरा. And this I have to do right now. Once I communicate with the CSF space, this may not stick well. See that?
Yes, yes.
After opening the CSF space, this will not work
Yes.
that effectively. See, now it is stuck well?
Yes,
Satish, is there a role of glue and soft tissue to close the cells?
Yes, soft tissue has a value, glue has a value in certain areas, but the best is for the bony surfaces, simple, and the best is bone wax, knife dena.
Okay.
And now I'm harvesting little bit of the soft tissue, what you are saying, you know, for my editors here.
Yes, yes.
Because at this point of time, I want to obliterate. I want to obliterate before my area comes in contact with the CSF, you know.
Okay, okay.
See this?
Yeah. So you are sealing all the cells, and now then you are working on the dura and the CSF.
Yes. Man, if it comes in contact, it will not stick.
Yes, yes.
Bone wax. See this, I have, pushed it lateral and medial to this bone.
Yes.
Look. See, this will push my periosteum well.
Yeah.
So now I don't have to pay attention to all this later on. We'll focus on our tumor. All good?
Yes. Very good.
Complete? See? Hello?
Yes, sir.
Yes.
Appara, happy?
Yes, man.
Now, give me diamond, bigger diamond. Now I will do a wide decompression.
Yes.
And then go medially.
Yes.
Okay? Hello?
Yes, sir. Yes, sir.
सबसे बढ़िया. See, what do you mean by wide decompression now? This is most important part of the enlarged translabyrinthine approach.
Yes.
I have already developed the translab axis. Now this is beyond. Pani. You know, many a times it becomes so difficult to differentiate pre-op a vestibular schwannoma from the facial nerve schwannoma. Unless you are very particular at the CT scan to find the lateral extension. Otherwise, it looks same otherwise. You will find the same features in a schwannoma arising from the facial nerve as well. Got my point? So, you have to be attentive in CT scan. In facial nerve schwannoma, they have a tendency to grow along the facial nerve. For all these CP angle intra-auditory meatus schwannoma, they have a tendency to grow along the labyrinthine portion of the facial nerve, showing on CT scan a dilatation of the labyrinthine part. And that is something is a great suspicion if you keep in mind. Got my point?
Yes, yes, yes.
And intraoperatively also, how will it look like? See, I told you there are 4 nerves in the intraoperative meatus.
Yeah.
The facial being antero-superiorly and the superior vestibular being posterior-superiorly. So tumor arising from the facial now, how will it look like when the moment you open the canal, you will find a nerve over the tumor. And that would be superior vestibular nerve.
Yeah.
That is classical of a facial nerve schwannoma.
Okay.
इससे बड़ी वाली देना है.
Dr. Rajesh Jain from Bhilwara is asking if cochlear nerve continuity is not preserved, can we go for ABI in the same sitting?
Yes.
Yes.
Why not? It has become a standard practice at many centers now.
Dr. Rajesh Kapila is asking why bone wax causes so much of problems and granulation tissue formation in the CI cases and not here.
Why bone is not?
Bone wax causes so much problems and granulation tissue formation in the CI cases, in cochlear implant cases.
In cochlear implant, you are more worried, You are extra careful because of the cost of the implant. Because the child, if the infection happen to occur, your implant may go to waste. And that implant can be a source of infection propagating to the subarachnoid space. There the concerns are different, Here you don't want to take even a 1% chance there. Cutting the nose. An implant is a different scenario,
So Satish, it is the best time. Just show us all the structures with pointers, so the people can get oriented with all.
Let me drill a little bit, then I will show you everything. See, this is my intra-auditory meatus right now.
Yes.
The area of interest. This is extra-auditory meatus, vertical facial, and this is internal auditory meatus. See this?
Yes.
Now I little bit, I have decompressed the sigmoid. I have kept a thin bone over it. See this? Periosteum,
Yes.
You may not appreciate this, but let me show you. Well, periosteum, yeah. See this thin bone over it?
Yeah.
Yes, yes.
Can you?
Yes, sir. Clearly seen.
Yeah. I will remove it later. Let
so
me.
sidodural angle has to
Yeah. Now cutting, back to cutting.
Yes. So what if while elevating, if there are tears in the sigmoid sinus, like if there are moderate sized tear, then what will you do? And if large tears, then what can be done?
See, sigmoid sinus tears can be managed effectively. First of all, depending upon the site and size of the tear. A small tear, you can use a bipolar, picking up both the ends and cauterize. That will take care. For larger tears, Surgicel is the initial answer. You can push a little bit of the Surgicel and then pack with some gauze piece for a while, it settles down. You can use bone wax also over there.
Sir, one thing I wanted to ask.
Sandeep, Pramita,
Yes,
I'm
sir.
asking Sandeep. Sandeep,
Yes,
sir.
remember once our friend Sanjay Bhatia had given a big tear in the white
Yes.
Pardon?
and
Pardon?
we sutured it up. You remember we sutured it up?
So we can
And we had
suture.
that-
If there we can.
Cardiac thoracic surgeon was there. He said, "Kai wo ghabra tha, taake maru do char." You remember that? So bigger tear, Pramita, you
Yes,
can even
sir.
do a suturing. Okay?
Okay, sir.
And this is about 20 odd years back. Sandeep was my registrar in what, 92, 93? Sandeep? When you
Yes,
worked
sir.
with us?
Yes, sir. 93. 92
93.
93.
And we were a bit worried we were going to pack it and leave it. So cardiothoracic surgeon was passing. बोले क्या दर्द है sigmoid surgeon? टाका मारो. Take 50605 to suture it up.
Okay.
Kranti, you were asking something?
Yeah, I was asking about the dominance. Sometimes neurosurgeons, when we were discussing, they always have this dominance of sigmoid sinus, and for them, sigmoid sinus is a very, very important for all of us. And it's
Yes,
important
yes.
as you
So the right side is mostly dominant because it drains the blood from the superior sagittal sinus.
So does it affect your, your
So
operating?
so you have to have a complete information of the collateral venous system.
Yes.
First of all, when you are dealing with the sigmoid sinus. In case you happen to obliterate this, that should be adequate collateral system. Even this emissary one, in that situation, a compromised situation, even this emissary one alone can help a lot by diverting the blood to the vertebral venous plexus.
Emissary veins are there. The subcondylar, condylar veins are there. There are a lot of veins to take over.
Yes. So that's why the ligation of the jugular, vein in the neck doesn't have that much of the impact as compared to closure of the jugular bulb. Because there are a lot of communication in the jugular bulb with the condylar veins. Even if you ligate the jugular vein in the neck, the anterior and posterior condylar veins communicating with the vertebral venous plexus are intact.
Sir, can you just put some light upon what are the precautions you take when you are removing this for the
this bone?
Most difficult part.
See what you were seeing until now.
Very sharp. When you are removing the last part, it's a very conical part, and you get injured that. So,
bipolar
what are the precautions you take?
Idhar bipolar. Bipolar section is blocked.
Satish, good
let
evening.
me band hai yaar.
Satish, Pramita,
Yes.
what is the question now?
Yes.
Sorry, sir.
Bipolar
What
idhar.
is the question this lady asked just now?
How to prevent?
Bhavani sir, I'm asking what precaution which you take for petrosal sinus when you're removing the bone over the petrosal sinus.
What precaution will you take?
While removing the bone over the superior petrosal
It's difficult to
sinus.
injure the petrosal
Yeah,
sinus.
you have to thin out the bone first.
Yeah.
See what
So
I did here?
You have to thin out the bone. You have to thin out the bone. There should not be any sharp edge to the bone, okay? And your direction of elevation should be away. It should be towards the extradural area rather than intradural. You know what I mean?
So do you use Surgicel?
Yes.
You don't damage it, so you don't have to use anything.
See now what I have done. I have decompressed this dura, partly periosteum.
Satish, good evening.
Hi, Narayan.
Hi,
Where were
sorry
you?
about it.
Where were you, man?
I was in surgery, sorry.
He was in surgery. He just excused us half an hour from ago. It's okay. You carry on with surgery.
So good evening, sir. Purvani, sir. And hi, everyone on the panel.
Hello.
Hi, Narayan, Sandeep.
Hi.
See this?
Yes,
Hi, Narayan.
Hi, Appa.
Hi. How are you?
Just all good. Thank you.
Hello, sir.
Hi.
Bone nibbler.
Would you use a Kerrison punch for this, sir, or a big nibbler?
This was the bone nibbler.
Yeah. So,
Bipolar.
Even through cut you can use it. No problem.
So do you use
See this?
any?
Now what I am doing, see this? Decompression of the sigmoid.
yeah, very important step.
See, it has gone.
I don't have a surgery picture on my.
See, it has gone flat. Can you see?
Most fascinating part of this.
Dr. Gupta, Dr. Sandeep, Dr. Narayan in my picture. I wrote a surgical picture.
Sir, if you are mobile, kindly sweep it. It will come in the next. Please,
Dr.
please.
Kranti,
Yes, sir.
you were asking about this part.
Yeah.
See, thin out the bone and flake it off.
Yeah.
And then decompress. See, this sigmoid part was so swollen up, giving difficulty in access. I have flattened. And I will flatten it more.
We can keep a Surgicel and then use the bipolar also. That we
Bipolar directly.
In case you have a rent, you have a difficulty, you can do that. What I do, I keep the Surgicel and cauterize the Surgicel itself.
Yes, sir.
How about gel foam?
Not gel foam, Surgicel. See this? See this?
Yes, sir.
To settle it down. See, it has flattened. What I am doing, I am cauterizing the periosteum over it.
Satish?
Yes.
Can you enlighten about the power of the bipolar dithermy?
Yeah, this is right now 20 diamond.
20. How about on the tumor size also? Please inform.
Pardon?
When you are dealing with the tumor also, please let us know.
Yeah, depending. Yeah, I will tell you when I keep changing,
Very important, no?
Yes, man. Your everything what you are enumerating is important. That this is your practical experience.
Otherwise, it will injure the sinus.
Satish?
Yes, man.
Can you tell me the size of the tumor? I'm sorry, I missed the initial part. Can you tell me what's the size?
Size is 3 by 3. As a 2 large cyst. 2 large intratumoral cysts with a thick wall.
Okay.
Narayan?
Yeah.
So it is A2 cystic.
Okay. Satish, so you're not decompressing the posterior retrosigmoid posterior fossa dura?
I have enough ample of excess, man.
Okay.
I could do that. See what Narayan is saying. If I remove this bone, I can decompress it further.
Yeah.
Enlarge the translabyrinthine.
Yeah.
Satish, how do you describe the size of the tumor, like 3-dimensional or 2-dimensional?
Yeah, many ways. Simple, what you can see, the two common methods. One is a ABC method. All 3-dimensional of the tumor, 3 by 3 by 3 divided by 2.
Okay.
Another is, use the largest dimension, any single largest dimension, like I can say, I am dealing with a 3 centimeter tumor. That's it.
Okay. That's good. Okay.
Or my tumor volume is ABC by 2, 3 by 3 by 3 by 2, 9.
27 by 2.
3 by 3 by 3, 27 by 2, 14.5 centimeter square, cubic centimeter.
Yes.
That's
like a volume of the tumor.
Pardon?
That's the volume of the tumor. Volume.
Yes, volume, tumor volume. There are many other methods also.
Okay, fine.
So, Satish, did you discuss a high jugular bulb?
Yes. You want to say something more?
No. If you've discussed, fine. I'm just stimulating your discussion, nothing else. Sorry.
Yeah.
Any points to add, Narayan?
No, I'm sure Satish should have done it. I just keep asking questions so that Satish remembers to answer. I'm sure he tells you all the points any which way. I'm sorry I joined late. So
Yeah, I understand. Narayan, feel free, Narayan, for anything.
Yeah, he has enlightened the very important point that the thickness of the jugular bulb and the thickness of the sigmoid sinus is entirely different and is very thin. Jugular bulb is very thin, so we should be very careful. That's what information is given. Do you agree?
Yeah, I was talking of a high jugular bulb. I was talking of how would you manage a high jugular bulb. I'm sure Satish has spoken.
The most crucial part is this one.
Bipolar. See my pre-sigmoid dura?
Yeah.
Give me a small, bone wax here. See, what is this here? Hello?
Yeah.
This is marrow of the occipital bone.
Yeah.
See, this is marrow of the occipital bone. This is occipital bone here.
You have some suboccipital approach also?
Pardon?
Suboccipital approach.
Suboccipital. Suboccipital is same, retrosigmoid.
The same.
Forceps. I hope so far everyone is oriented.
Now it's just show it again because so many people are little bit.
Knife. Yes, I will. I was just trying to remove little bit of the bone to expose everything. For that matter, at this point of time as well, this is the right side which I am dealing with. Band hai yaar.
Sir, can you zoom in little, sir?
Yeah, I will. This is the right side I am dealing with.
Yes.
Yeah.
This is posterior. This is the sigmoid sinus, which I have partially decompressed. This is the middle fossa dura, which I am decompressing. See this? And this, can you see this? This is superior petrosal sinus. Paramita, you were asking where my periosteum is. Rukna.
Yes, yes.
This is superior petrosal sinus.
Yes, sir.
Very clear?
Yes, sir.
Satish?
Yes?
A thought just occurred to me that, I think it's all thanks to the great man. Most of us on the panel are all following the teachings of Professor Mario Sana.
Yes, sir, that's what we were discussing.
All of us on the panel would be following him.
Yes.
Narayan, I dedicated this day to Mario Sana.
Oh, wow. That's nice.
Not only we, everywhere in the world. Majority of the dedicated lateral skull base surgeons are Mario Sana's disciples, directly or indirectly trained by him, his work, his students, whatever. See, decompressing the middle fossa dura. See this?
Yes.
Settle down. And
what else means perioperative antibiotic profile in these cases? Which
prophylaxis?
Yeah, antibiotic.
Cephalosporin sulbactam we have given.
Vancomycin also, right?
See, thoda suggestion dena. See, this is my superior petrosal sinus all the way.
Yes. Yeah.
Yes.
Satish,
yes.
if your superior petrosal sinus bleeds, just for the sake of the juniors, how would you handle it?
I will bipolarize it, man, without thinking twice. Done several of the times, many a times.
Yeah. When one can try it.
Narayan, don't you do in middle fossa approach if you want to go to the depth of the intraocular meatus?
Dip it anyway.
If you want to go to the posterior fossa from there, you have to cut superior petrosal sinus and tentorium both.
Correct. So just tell people how to handle the bleed. That's what I was trying to.
Yes, bipolarized, simple. See, this is all dura.
Yes, sir.
Since I have a adequate opening, I am not enlarging it anymore.
Okay.
There's more than enough. Enough space.
See this? This
Yeah, we
is
can
tumor
see the
underneath the
tumor in
dura.
the-
This is tumor underneath the dura.
Yeah, very well seen.
Almost 2 into 2 centimeters. Right?
Now, give me a knife. Narayan?
So what? So
Drill,
what
drill,
size
drill.
nibbler were you using here?
Diamond. Pardon? Body diamond. Pardon?
What size nibbler were you using here, Dr. Rajiv Kapil? I
I use size 1 and size 4. I have all sizes here, depending upon the need. Now I am going to open the, dura. Now I am soon going to open the dura.
Any specific incision always on the dura or?
Boss?
Ritesh, what is the approximate size of opening, size of the
Pardon?
field? What is the approximate size of the field?
Size of the?
Field, mean.
Field, this will roughly.
Okay. Dimensions.
Size of the field, you mean to ask?
Yeah.
This is more than 2 centimeter in all dimensions.
Okay, fine.
See what I am doing. Scissors.
Sir, you have to tell us where all you're taking this incision.
Incisions, yeah.
Many ways, what I am doing here, give me scissors. I am making inferiorly.
Any shape?
See my dural cut?
Yes.
Satish, a lot of people usually ask what is the porous. Have you showed them?
What is the?
Porous.
Have you showed them?
No, not yet, not as yet.
Circular. Yeah, Narayan, comment please.
Yeah, just show them what is porous. Many people have this question when they are dissecting, is what is the porous? So if you can just show them.
I am.
Porous. Okay, porous. Porous is the medial end of the intraocular meatus. Fundus is the lateral end of the intraocular meatus,
How do you open the intracanalular part of the dura?
Yeah, I will show.
Focus, please.
Yeah. Carrison. A little bit of the bone.
It's not focus, sir.
Not focus?
Focus, please.
No, not very.
Okay, just a minute.
Out of the question, what is the best management for the vascular tinnitus, like high jugular tinnitus? How we put this?
Bipolar. What is the?
Vascular tinnitus, suppose a high jugular bulb tinnitus or something. That
High jugular bulb tinnitus is curable.
I mean, what is best way?
You have to line the jugular bulb with a, some bone wax and bone dust. That's it. That's a very rewarding surgery if you do. See, why I am not going here most laterally? Hello?
Dinesh, I would request to please mute the ones who are not talking because there is a lot of disturbance which is happening.
Patla.
Yes, sir.
See the lateral part of the IAM. Though this tumor is not ascending far laterally.
Yes.
I see that you're using a punch, okay? Kerosene sponge. Now, we prefer drilling. Tell us how you identify the, say, horizontal and the vertical crest. Once you use a punch, you almost lost your crest, isn't it? Your horizontal crest?
Yeah, it may. See, that's the dura of the intraocular meatus.
Yes.
Can you see all the way?
Yes.
Yes, we can see that.
Pardon?
Satish, did you show the horizontal and the vertical crest?
Yeah, I will.
Not yet.
I will. Narayan. At the lateral end, I have not gone far laterally.
Okay.
The reason was the tumor was not going.
Watchman at the lab.
I muted too, sir.
Yes, yes.
No problem.
Patla de. See my tumor coming into the view?
Yes.
Very well seen.
That is all tumor. Circular there.
So another thing, Satish, at what stage do you drain CSF? After opening this dura, now you
Yes, after opening this dura, I will go inferiorly. We have discussed this, Narayan, and I will open up the cisterna magna.
Sir, one question. In many of the surgeries which you see, do keep these dural flaps to stitch it later. So you do that in few of your
I
cases?
generally don't use this flap.
Okay.
My closure will be through the fat strips.
Okay, that's good.
Lot of people use it at the end over suturing over the fat strips.
Yes, yes.
Or muscle can be used, Satish.
Yeah.
Just watch Satish. He is going parallel to the superior petrosal. Satish, you're describing the.
Yes. Yeah, so that is the superior incision.
Yes, that is parallel to the superior petrosal sinus.
Petrosal sinus, yes.
Knife.
Are you going to use CUSA here?
Yeah.
I will use CUSA.
Yeah, without that it is very difficult.
CUSA is my favorite instrument. Nerve monitor is my favorite instrument. We all always use these two things in this surgery.
Yeah.
So now you are joining the two incision.
Not really. I have, removed that part of the dura.
Yeah, he is exercising that dura.
Narayan, what do you do?
I reflect the dura, Satish. I don't take this posterior incision pre-sigmoid. I take the other cut exactly as you did, and I would reflect the dura posteriorly back on the sigmoid. So you get a good view.
No, but do you really use it in the end?
No, it's not very useful. To be honest, it's not very useful.
Then why do you keep?
It generally gets tethered and resected.
My point is, why do you use? Why do you keep?
Why do you keep? It's just the fact that your dural defect is probably a little bit smaller, but there's really major benefit of it, Sati. You're right.
See the cerebellum?
Yeah.
Yes.
In fact, I don't keep it always because it sometimes obscures your removal.
Absolutely. Impedes your view.
Periosteum.
Where is the inferior petrosal vein, Satish?
Pardon?
Where is the inferior petrosal?
See what I am doing?
Yes, sir. I've just opened the.
See what I am doing?
Yes, sir.
Narayan?
Yes, great.
Yeah.
Very nice, sir.
I have opened the cisterna magna.
Yes.
Satish, tell them why you're doing this and what happened.
See, this is to relax the brain now. My cerebellum, we have discussed this lot, Narayan, earlier.
Yes.
Is Panikar sir there?
He's there. But he...
Yeah, I'm very much here.
Sir?
I'm enjoying your surgery, Satish.
I opened the cisterna magna.
Yeah. The very, very important first step when you do any of these tumors.
Yes.
Otherwise, you'll end up with a bulging cerebellum. You don't want to have that. That's a very important first step.
Bipolar. उनको बुला देना कहाँ गए बॉस
How much CSF you take it out like that? Or
It's not quantitative. It's a, you should see how your brain is relaxing, depending upon that. Now I'll have a good working environment. खोल दिया कहाँ रह गए कहाँ थे
everything is relaxed now.
Now see, draining some more CSF, you know.
Yeah.
See, my cerebellum has settled down.
Yeah.
Could you see? Petty.
Yes.
Petty, the petty.
Satish?
Yes?
Are we taking the advantage of the gravity also of the cerebellum retraction?
Not really.
Gravity wise also it's advantage, no? In this position.
Yeah, this is applying my petty over the surface.
Okay.
And see the tumor surface now.
Yeah.
See very well?
Yes.
Yeah.
See how big the tumor is.
Huge.
So Dr. Panikar, good evening. Narayan here.
Yeah, good evening, Narayan.
Scissors. This is the lateral part of the intra-auditory meatus I am opening here. Can you see the glimpse of the tumor?
Yeah, we can see.
So any special bipolar cautery will you use here with the tip will be different or the same one?
Yeah. Yeah, the same bipolar. You see, that's the arachnoid layer.
Yes.
That is important. That's what we were discussing.
Yes.
To stay in this plane.
Yes.
Yeah, the arachnoids should be gently separated. See that?
Yes.
And we should try avoiding using the bipolar or the arachnoid. It may make it sticky, you know.
Yes.
But that's an amazing plane. We never want to miss. And this tumor has a large intratumoral cyst. Patla dena hai. Patla. Section. Can you give a tilt to the table? Tilt.
What exactly location of labyrinthine artery? Because in this case, I think we're not important.
Pardon?
But I think
Pardon?
The exact location of the labyrinthine artery.
Labyrinthine artery passes deep in the canal. That is important when you are doing a limited tumor with hearing preservation surgery.
Yes. Not in this case. Yeah.
The protection of that is important, but here it is not. And in such a big tumor, you cannot find. See, the instrument I am using is a blunt dissector, you know.
So he's basically taking off the dura and he's looking for the arachnoid layer, right, Satish?
Yes, exactly, man. Give me irrigation. मेरे को दे.
You can also use the fine forceps to separate the arachnoid, Satish.
Pardon?
Fine arachnoid forceps to separate the arachnoid.
Yeah, I can see the arachnoid layer now.
Yeah. You can hold the arachnoid and can get separate from the tumor.
Yeah.
Or with the force of the bipolar ray, rather than using the bipolar
See,
current.
posteriorly, I am inside the layer.
Yeah, I am seeing it.
See this arachnoid, see there.
Yes, sir.
Let me show you there inferiorly. See the arachnoid layer?
Yes.
I hope it is clear.
Yes.
This is toward the inferior pole of the tumor.
Jagdish Naik from Oman is asking, would you advise hyperventilation by anesthetic at this level?
Here no need. Why? Here no need. Why? That is required in case you have a high pressure.
High pressure.
Here it is not needed. See, all around my plane is just inside the arachnoid. See this? Hello?
Yes, sir. Yes. Can you see?
It's 8 o'clock.
Once you go into the tumor surface, before I start intratumoral debulking, I'll go to the intra-aortic canal.
Yes.
TM elevator. TM elevator. No. See, this is my intra-aortic meatus.
Yes, sir.
I am taking here the advantage of tumor not going too lateral. Otherwise, I would go too lateral.
Lots of drilling in the lateral part.
Yes. And see, I am staying little inferior.
Zoom in possible?
See, towards the inferior part of the canal. Can you see something there?
So can you zoom in, sir?
That is the dura. No, that is not facial.
Okay.
I will show. This is not facial. Can you see the tumor?
Satish,
yes.
Satish, at this level, I would like you to explain how you preserve the facial, okay?
Yes.
And sir, also tell us the
See, Narayan.
fundus
My
and the
facial
porous.
is toward the superior part. Okay, give me the facial nerve monitor for everyone first.
Satish, show the superior axillary nerve, if you can.
Yes,
I am not going that laterally, Narayan.
Okay. So then how are you preserving the facial?
Yeah, otherwise that is one of the best landmarks. As you go laterally, you can find the superior ampullary nerve emerging from the superior vestibular nerve.
So also show us the porous and the fundus part and everything.
See my facial nerve monitor?
Yeah.
Can you hear?
Yeah, we can hear.
Can you hear? This is vertical segment. Now, if I touch there, see no facial now. Can you see?
Yes.
Yes.
This is all tumor. This is all tumor. See this? Can you see this?
Yeah.
Facial should be anterior to the tumor.
Yeah, see, I am on the anterior wall of the ISC.
Yeah.
Yes.
That is the periosteum.
Yes. Antero superior or antero inferior?
Inferior. See this tumor?
Yes.
Anterior superior I am not going because anterior superior is my facial now.
Yes, antero-inferior.
Narayan,
Yes, yes, Satish, go on.
what I am trying to say, I have reached the depth of the intra-aortic canal. See this?
Yeah, yeah.
Yes, sir.
Very
Yes.
clear? Very clear or not?
Zoom in, zoom in, zoom in, zoom. Yes, yes, yes.
See that? Anterior wall of the intra-aortic canal inferiorly. See this?
Yes, yes.
Yeah, now we can see.
But superiorly, I have not done anything. The reason is, superiorly, I don't know where my facial nerve is right now. Yeah, here it is. Could you see?
Yes, sir.
Yes, yes.
Yes, sir.
Could you see something? Give me the monitor. On. On, please. That is not.
Satish,
Yes,
tell
please.
how you're separating that for the patient now.
With a monitor.
No, no, okay, with the monitor. But if you don't have a monitor, how would you do that?
Pardon?
If you don't have a monitor, how would you use your hook and...
No, no, I will never do.
No surgery.
See this part of the tumor, I segregated here. Can you see?
Yes, sir.
Yeah, yeah.
That's a plane.
I told you it's a vascular from the MRI. Give me a patty.
So, okay, Satish, let me give that answer. When you go to the lateral end of the internal acoustic meatus, your tumors are usually from the inferior vestibular nerve, okay? Rarely from the inferior vestibular nerve. But there's always a bone in between your vestibular nerve, that's the superior vestibular nerve, and the facial, which is called the Bill's bar.
Yeah,
yeah. This is for the juniors, not for you and me. So that Bill's bar protects the facial nerve at the most lateral end of the internal acoustic meatus.
Yes.
Satish is brilliant. This is for a more experienced person, but a less experienced person I would ideally want you to start from the most lateral end of the meatus and use a
hook. Yeah.
Okay. Agree, Satish?
Agreed, absolutely.
Yes.
So what is Satish doing? He's trying to stick to the tumor. If you're sticking to the tumor and looking for the facial, in most probability you'll be able to save the facial. But you must be very careful not to cause stretch on the facial at this point. Exactly what Satish is doing. He's identifying the facial and sticking to the tumor. So many a time you blindly pull the tumor, not knowing where your facial is in a blood field, and there you'll end up damaging your facial.
Okay. See my intra-aortic meatus?
Yes, sir.
Dr. Panikar, you would want to add something?
No, nothing much. I think I think this is the right way of doing it. You work on the surface of the tumor and very gently manipulate the tumor away from the nerve. You do not go to the nerve and try to manipulate the nerve.
So that will otherwise give traction on the nerve.
Exactly. So it's a very gentle process. Once you
can you see the tumor very clear?
Yes,
very clear.
Very clearly seen.
See, this is pure blunt dissection.
Yes.
Yeah. With probe dissection.
Satish, can you hear me? Satish, can you hear me?
Yes.
Instrument is instrument. Sometimes your nerve monitor may not work. Remember that. You are tested naturally, but still, any equipment can hit you. So, appearance of facial nerve is important for you beside the monitor.
Sir.
Boss is always right.
Now see, I have seen my tumor here.
Yeah.
Well segregated. I can start debulking the tumor. Give me a
Sinus.
no sinus. Give me a bipolar. Find out. बड़ा दे section.
क्या हुआ?
Patty the patty है क्या? Little bigger, not so big. Give me a patty, small patty.
Some cerebellar bleed है.
ना थोड़ा surface का था. Give me a surgical there.
So one of the most important things I would like to pass on the message at this point is that your blood does not percolate into the CP angle cisterns.
Because of the tumor.
Yes.
Satish is taking care to see that and flushing. But if you allow blood to percolate into the cisterns, then it can cause blockage of cisterns and post-operative hydrocephalus.
Yes. You have to do a lot of things to prevent all these issues. Blood, bone dust.
And if the tumor is large and if you don't get a cleavage, then we will debulk the tumor first, right, sir? Alright, so?
Yeah, that's in the CP angle, yeah.
Yeah.
The internal approximator, I think Satish is doing a fantastic job. If the tumor is big in the CP angle, then you obviously have to do internal debulking and then take the capsule out separately.
See this tumor surface? Give me kusa.
Yeah, kusa will work here.
पानी ओए. कितने पे? अरे ये लगाना इसके आगे.
I think this is best time to kusa.
लंबा लगाना है. Hello.
Best time to start with kusa.
Yeah. I will use now. So first you need to see the arachnoid separated.
Yes.
Then the tumor surface a little coagulated. Tumor is little mobilized. See this?
Yes.
So you know exactly where you are going. See this?
Yes, beautiful.
But Satish, you haven't got your facial over there as yet, right?
Facial is there exactly in this corner. Man.
Yeah, but don't you want to see it?
See Narayan? This is all tumor. Agreed?
Yes.
Agreed?
Agreed, but won't you be more happier seeing the facial?
Pardon?
Won't you be more happier seeing the facial? That is the biggest advantage of the translabyrinthine approach.
Yes.
Identification of the facial at the early part of the
Because
surgery.
that is anterosuperiorly. Dena?
Satish, I know you're a great surgeon, but you must throw light for the junior people here.
Satish. Hello, Satish.
Yes.
Yeah. The most vulnerable part of the injury of the facial nerve when it enters to the canal. From the cisternal part, when it enters to the canal, that is the most weak and vulnerable part. And at this junction, sometimes we may need the sharp dissection rather than the blunt dissection.
Yes. At the superior part of the canal, where the facial taker angulation,
Yeah, that is the most vulnerable part.
Bipolar.
Most of the
facial,
time,
this was my kusa. See how vascular this tumor is.
Yes, sir.
This was all expected from the MRI.
Yeah. Looking to the necrosis part, it was not cystic, rather than it was necrosis.
Thereby, see the process. See now, my cyst is going to come soon, because this we know there is large cyst inside, necrosis.
Yeah. And it suggests the high vascularity.
Pardon?
The cystic portion shows the high vascularity.
Yes. See now, this I have taken for the histology.
Yes, sir.
Tell something about kusa to all, because
kusa is the ultrasonic aspirator,
Yeah.
This is to expedite your process. कम करा इसको.
Yeah, of course.
कितने पे?
In the COVID era, people are try to avoid the cruiser.
इरिगेशन कम करो उसका. इरिगेशन कम करो यार.
Satish,
Yeah, please.
precautions you're taking while using the cruiser.
Pardon?
Tell us the precautions you're using. What are the things you're noting doing the cruiser?
First of all, define your arachnoid plane. Stay within the arachnoid plane. You can coagulate the surface. See the cyst.
Yeah, big.
I think the most important thing to keep inside the tumor while using CUSA. And one more thing, when you are enough decompression has been done, the tumor starts mobilizing, moving with the suction.
Yes. Now, once this is, decompressed now, I'll have opportunity to mobilize it, the bipolar. Keep mobilizing, keep separating the separating the arachnoid plane, and then keep going inside. Some Sajji. Louder, what the TM elevator. This is interior of the cyst, See this? See, you have to be cautious once there are cysts. You may go across to the brain surface, Scissors there. If I go through the cyst, I may go across to the brain surface. So you have to be careful once you are dealing with a cyst. Bipolar. Arachnoid separate किया हुआ. See this? Now I will come behind, tilt towards me. Tilt towards me, please. Table tilt. Can you see the tumor surface?
Yes, sir.
Bas. Now I can take this part of the tumor. See this? Completely exposed?
Yes.
Hello?
Yes, sir. So Dr. Ashim Kumar Banerjee from Kolkata is asking, can cobblator be used over the surface of this tumor?
Not used. But I have used at other areas, not here. Yeah, the bipolar. Yeah, capsule पे कुछ नहीं चलता है. See this? See this more and more tumor surface?
Yes, sir, beautiful.
So I am pulling in my field. See, my arachnoid is there. Could you see?
Yes, sir.
Yes.
See now, if I remove this tumor, this is safe. This way you can expedite your process, you know. No, Musa. Scissors. Bipolar first.
Using the fossa intratumoral, be careful when you come to the periphery of the tumor.
Yes.
Else you'll cause damage with the CUSA. So it's like a, you know, you know how to use an instrument. You should know to use
Scissors. See this capsule. That doesn't come efficiently with the CUSA. See this?
Yes, sir.
So if you notice the technique that he's doing internal debulking, he's taking out bits of the tumor and
Biopsy.
reducing the size of the tumor. In large tumors, I think this is the correct technique, because if you pull on the tumor, then you're liable to cause a lot of damage in unseen areas. So you're slowly getting the capsule, debulking it, and getting everything into view.
See another cyst.
Yes, Satish.
Yes, sir.
See that?
Yeah.
Yes.
Yeah. त्यातला तो यार
Dr. Sanjeev Kumar
See,
Verma is
once
asking.
when you are dealing with a cyst now, you have to be extra careful.
Yes, sir.
Bipolar. Yes. See this arachnoid?
Yes, Satish.
Give me a petty. See the arachnoid?
Yes.
Hello?
Yes, sir.
So once I find the arachnoid plane, I push my petty to push the important structure away. See this? See this?
Yes, sir.
And get more tumor for removal.
Yes. Dr. Dipti Kanta from Cuttack is asking, Ms. patties are soaked with any hemostatic, or
Patties are?
is it soaked with any hemostatic agent, or just normal saline?
Yeah. No, just normal saline. Nothing else. देखो तो सही. See my area of the facial now is here. Or anteriorly, you know. Hello?
Yes, Satish, we're watching you. Nice.
See that?
Satish, why don't you use your probe now, facial probe in that area?
Yeah, facial probe there. there. On. On, please. Yes. Aina? Huh? What was that? Yeah, what is this? What is this? Yeah, I could hear. Yeah. Yes. Give the mic there. Yeah, I can hear. तो आ रही ना आवाज? That. See here. Yeah. What is this? What is this? Tell me.
Satish, tell him to put the monitor noise off. Monitor बंद करा. Monitor का आवाज बंद करा.
Can you show the monitor?
ये क्या है? तो वो माइक लगाना.
तेरा कार्डियक मॉनिटर का आवाज बंद करा दे.
हाँ. हाँ. See, I can hear. Give me a suggestion. What is this? ये क्या है ये आवाज?
Can you see the action potential?
Yes, see this.
Satish.
What is this?
Can you see the action potential?
Yes. I can see the bloody nerve.
Is that the nerve right on the superior most aspect, Satish?
Pardon?
Nerve.
Can you focus or tilt your microscope?
Superior aspect.
See this is. See this. माइक लगा दो उधर. Yeah.
Now we can see.
See, this is my facial now. अरे वो माइक लगा. Can somebody put ये लगा उधर माइक. उठाओ मेरा. एक बार ऊपर लगा दो.
.1.
Yeah.
Yes, sir. It's clearly heard.
Mic effect. Okay. Beautiful. We can see nerve very clearly also. Yes. Oh, super.
Everyone please tell me. Can you hear or not?
Yes, yes, very clearly, sir.
See such robust response.
Yes.
Now she changed the setting. Now it's very well anteriorly, and I left there and came back to the tumor. Now this part of the tumor I can remove. See this?
Yes.
Kusa. See, this way you can remove it fast.
Satish, if I could make a point, in the translabyrinthine approach, the nerve is always antero-superiorly in the IM, whereas in the CP angle approach, the nerve could be just anywhere in relation to the tumor.
Yes.
Right?
Antero-superior or antero-inferiorly?
Could be.
I think 70% in the studies it is seen as in the antero. The tumor pushes the antero-inferiorly.
No, in the IM, you're looking for the nerve antero-superiorly is what I'm saying, Paramita.
In IM, yes.
Looking for, oh yeah.
Yeah, when you're looking for
But usually the tumor pushes the nerve antero-inferiorly.
See what I kept there? The Sagittal.
Yes, sir.
See this?
Yes, sir.
My nerve is there. I have robust response. See, my nerve is there.
Yes.
And I don't want to put any traction over there right now.
Satish, when we do a retrosigmoid approach, don't you agree the nerve is variable in its position?
Pardon?
In a retrosigmoid approach, don't
Yeah.
you think the nerve is variably situated in relation to the tumor?
It is very invariably. Band ho gaya.
In the retrosigmoid approach,
Yeah.
the nerve could be anywhere in relation to the tumor, whereas in a translabyrinthine approach, it's always easily identified in the internal acoustic meatus. Right?
Yes, yes.
Isn't that a big advantage of the translabyrinthine?
Yes, that's what we always say. Now we have seen the nerve, so I know where I don't have to go. See this? I kept aside that area, in the beginning.
Yes, yes.
Narayan?
Yeah.
And now I know where I don't have to go. Now after separating the arachnoid, I am inside the tumor, So this way I am pretty safe. And you can work fast as well.
Kusa is very helpful at this time, actually. It speed up your work.
See this? You can carry out so fast. इसका इरिगेशन कम कर दो ना यार, इतनी बार कह दिया तुमको.
Dr. Prakash Munka is asking the role of Kusa and how it works and
Yeah, this is an ultrasonic tool. So it's like micro debrider,
Yes, yes. But it preserves your nerve and healthy tissue.
Cuts, irrigates, sucks, it does everything.
Basically, it has three parts: irrigation, suction, and cavitonic ultrasound, which the tumor gets fragmented in small pieces.
See, just keep on just keep on retracting the arachnoid. Stay on the tumor. Keep on pulling it in your field. See all this necrotic part. In no circumstance you are supposed to go to the outer wall from inside. See, that is the medial wall of my cyst. See, what I'm ensuring is that I stay within the arachnoid plane. By means of traction and counter traction, could you see?
Yes, sir.
Periosteum देना, periosteum वो अलग है. सुन बोलते, पैटीज. छोटी है. See my outer wall. Can you see?
Yes, sir.
Yes.
That's a very important movement, you know. Now this is a very important area. I cannot take a chance of giving traction to the patient now there. See, under magnification. Monitor. I may have to do a sharp dissection there rather than putting a traction, you know.
Yes, sir.
Sort of. On. See, that is now. Hello?
Yes, sir, yes.
Oh, patla de. कर दिया. See, because of the tumor size, it is expected to have a splayed facial now.
Yeah.
See my wall? See the arachnoid?
Yes, sir.
See the interior arachnoid?
Yes.
And facial nerve is here. See this?
Yeah.
Oh my God, tightly adherent.
Yes.
Okay, can you put a compressed gel form over there and it will expand and slowly create a space?
To create the plane?
Yeah, compressed gel form. It will expand and slowly it peels off the tumor.
Not very appealing, man.
Okay. Kusa. See this tumor I have separated? Yes.
Yes.
Into the lumen of the cyst.
Yeah. See, I have separated away from the facial now.
Yes.
I am within the tumor after separating the arachnoid.
Yes.
So finding the arachnoid plane and staying in the arachnoid plane is the most important
that is the only
step.
way here. That is the only way.
Yeah.
Bipolar.
So for irrigation, do you use formed a ringle acted solution?
They are using here simple saline.
Okay.
Now this is the inferior portion now.
Yes, sir.
Having seen our facial there, give me the monitor. Facial monitor, please. See how valuable this facial monitor is. How can one think of, see this?
Yes, sir.
How can one think of doing this surgery with? See that?
Yes.
Now, bipolar. Tumor holding there. Tumor holding. No, this is not tumor holding, Guru. Petty. See what I am trying to do? Separating the arachnoid. See this?
Yes.
Section. I can cut this dura. Remember? Now, this is the inferior pole of the tumor, you know.
Yes.
Inferior to this tumor is the lower cranial nerves.
Just check it. BSNL.
See this?
Yeah. Yes.
See the arachnoids?
Yes.
I hope you are oriented.
Yes,
Yeah.
Yeah. See, separating the arachnoid so that I stay on the tumor surface.
Satish, can you center better? Center and focus.
Center near?
Center and focus.
Yes.
Okay, it's fine.
Now better?
Yeah.
So this tumor, see this, I have separated the surface arachnoid. See that arachnoid being separated?
Yes, sir.
That is the arachnoid layer. And this is the tumor. See this? See that layer?
Yeah.
If you see closely, that is arachnoid. See that?
Yeah.
This tumor now I can remove. See how much I exposed.
Yes, sir.
So now I will remove this safely with the kusa. इसके सेक्शन को क्या हुआ? सेक्शन, इसका सेक्शन ब्लॉक है. Block please. First. See, the whole idea is your handling should be very gentle. Every time ensure that you are within the arachnoid plane. Separate the arachnoid away. Then stay on the tumor. एक देना दूसरा. See the arachnoid layer. See now completely separated. Can you see?
Yeah.
Yes, yes, beautiful.
Excellent section, sir.
Drill over. Kusa.
Focus, please. Yes, better.
So I said, this approach, whatever the access you have, you can remove any size tumor because you are doing intratumoral debulking and then mobilizing the tumor in your field. Whatever the size tumor is, if it is a acoustic neuroma, you can do it. पानी डाल दो बीच में.
Satish, I must admit you're going quite fast in spite of the oozing.
I have a habit of going fast, man. That's why I use Kusa too much.
No, but sometimes you have intratumoral vessels, and using Kusa also causes intratumoral bleed. And sometimes, like
No, any point of time, Narayan, I am not going to go out of my plane.
Yeah, I understand.
See how much tumor we have debulked.
Yes, yes.
Bipolar.
Satish is working in a easy field, but he's doing a fantastic job. I think for all us lesser mortals, we would probably want a little drier field, so a little bit of bipolarization, maybe going a little bit slower would help.
See, that is the arachnoid plane this side.
Yes, yes.
See the vessel? Right
Yes.
in the plane.
Yeah. It's very clear.
Suction देना. कहाँ चला गया? वो दो. See the vessel?
Yeah.
No, give me the patty.
Which one is this one?
Pardon?
Which vessel is this one?
Could be part of the ICA.
Oh, beautiful. Dissected.
If you have a thick, sharp arachnoid plane, you can do a sharp dissection as well. See this? Scissors. Scissors. See this vessel? Section. See, I just cut sharply the arachnoid adhesions, you know.
It's still attached. Let's do it.
That's ICA there.
Could be ICA or its branch.
Probably a branch.
Maybe branch. ICA should be more medially.
Okay.
इसका section नहीं चल रहा है इसका यार.
More bigger also.
नहीं चल रहा देख लिया. मैं बोल रहा हूँ नहीं चल रहा.
Principle is that you must
Give me the
not
section, please.
unless it actually bleeds.
करो थोड़ा इसको छोटा करूँ.
Narayan, what is the size of the vessel? ICA?
Give me suction, please.
I don't know, sir. It's a major
Suction in this is not working.
It's up here. It is probably
Suction क्यों नहीं चल रहा?
diameter wise. It will be probably a little bit bigger than this diameter wise.
Okay.
I don't know exact diameter, but it appears like
Yeah, Narayan. In cystic tumors, you cannot rely on the diameters.
Okay.
Narayan,
Yes, yes, I agree with you, Satish.
कर रहा है इसका सक्शन काम? नहीं कर रहा. सक्शन प्लीज यार. कुसा में सक्शन नहीं चल रहा है. See the check the suction of the kusa. Suction 1. Kusa ka suction.
Satish, you use a regular suction, is it?
I am waiting for the kusa suction.
What's in your left hand now? Regular suction, right?
Yeah.
Regular suction.
Because without the suction in the kusa, it doesn't clear the area effectively. See, Narayan, in spite of this much of the bone removal, this overhang is something, suction nahi chal raha. What is the problem? Why the suction is not working in the kusa?
Sir, Dr. Palaniappan is asking what is the other equipment you advise if you don't have a kusa?
What is the other?
Any other equipment you would advise if you don't have a kusa?
Bipolar. It will take longer, There. You can keep bipolarizing, removing, keep bipolarizing. People take hours and hours,
Yes, sir.
चला नहीं रहा हूँ. Working? See how it works so nicely.
Yes.
And I am so addicted to it. Without kusa, you don't feel like doing acoustic. Bipolar.
The laryngeal vein of the carburetor can be used over here, no problem.
Pardon?
Laryngeal vent of the carburetor can also be used here.
Laryngeal vent. I have not used, but not a bad idea. See? Yeah. See, that is the plane inferiorly.
Yes.
Very clear?
Yes.
That is your inferior pole, you can say.
Yeah, you can now.
Can you see the brain stem?
Yeah.
See in the depth? That is brain stem and that is ICA, most likely.
Yeah, looks like ICA.
See the big vessel?
Yes.
Could you see or not?
Yes. Very clear.
Now I have elevated this pole here. Give me kusa. See beyond my brain stem is. That is the brain stem. Can you see?
Yes.
bipolar. I hope everyone is oriented.
Yes, sir.
Pura. My arachnoid plane is here. I have separated the arachnoid plane. See that? I will. That is special.
Yeah.
Hello?
Yeah, sir. Yeah.
Could you see?
Yeah, you can see that.
I will show clearly. Narayan,
Yes, Satish.
things are in control.
Fantastic, Satish.
Now I will take away. See, I am well within the tumor. See?
Yeah.
The beauty of Kusa. Petty. हाँ छोटा.
You can see quite clearly by the back.
Is Panikar sir there?
Yes. Wait.
Panikar sir? Panikar
Just coming.
sir?
Just gone for something. He will come back.
Okay. Yeah. Now this area. See, we saw some vessel on the surface.
Yeah.
And now we have to overcome that. I may have to do a sharp dissection. See this vessel?
Yeah.
Wash. मेरे को दे. Yeah. Give me some surgery, sir.
You can bipolar it.
See this venous bleeding on the surface?
Yes.
Surgical. Yes, I will leave a little bit of surgical here. Petty. See, you have to all around go like this. Tilt towards me. Anupam. Tilt towards me. Anupam. Tilt towards me. Sleeping. So my majority of the work has been done,
Yes.
Very soon we'll be through. But this is critical part. Bus. Enough. Yes. See some venous roots. Hmm. Okay. See the plane.
Yes, sir.
Can you see my arachnoid here?
Yes, sir.
Patty. Keep separating all around. See this?
It's 9 o'clock.
Yeah.
See this? Keep separating all around. See this? In the arachnoid plane. See now I am inside. Arachnoid is separated outside. Kusa. Now by the time you must have understood the whole scheme.
Yes.
See, once you are in the right plane, onto the tumor, you can take it. With us? Yes.
So what is the bipolar setting now?
20.
Okay.
Hot. See, this is how you have to keep removing the tumor. This is under very high magnification.
Yes.
Patty.
So nearby the brainstem, what precaution will you take before the dissection? Dr.
Pardon?
Dr. Palaniappan is asking, nearby the brain stem, what precaution will you take before dissecting?
At brainstem, what brainstem? What is that?
What precaution will you take?
Where?
Near the brain stem, what precaution will you take before dissecting the tumor?
Everywhere the same precaution. Stay within your arachnoid plane. Don't pull too much.
The same vessel is bleeding out, I think, tumor. This one, yeah.
Give me scissors.
It is going into.
See this vessel?
Yeah, it's using it.
Which I am going to dissect sharp. See that?
Yes.
This is so tightly adherent. Suction. See this vessel.
But you have to cauterize it, I think.
See this, so tightly adherent. What now? Petty. Venus. Give me a. See this vessel, so tightly adherent. See that?
Yes.
Some suggestion.
Hours.
सर्जिकल के साथ पैटी, अरे यार look. Yes, two areas where I have to push surgical. Yeah, surgical, give me surgical, one. Yes. See this venous bleeding from the surface. You have to put surgical and press with the patty, okay?
Yes, sir.
Surgical again. Because this is highly vascular. And patty. No issues, okay? And now I can resect this. Give me Kusa. Kusa. See this tumor now?
Yes, Satish.
I can resect this. Narayan?
Yes, Satish.
Yeah, where were you?
I'm here only watching you. I'm happy about one thing. Usually when you do your surgeries, you do it in such a bloodless field, we wonder whether it's really normal. So this is more like our type of field.
See how vascular it is.
Yeah.
Are you using the room temperature saline or any cool saline?
Room temperature.
Room temperature.
Bipolar.
How often do you find the facial nerve to be splayed? Not really like a nerve, but splayed out, almost like a fan.
Yeah. Larger the tumor, you will always.
Pardon? Say again?
Larger tumor, you will always find like that. Completely splayed. Larger tumors, Narayan.
Yeah, I understand. But the message is it's not always appearing like a straight nerve. It can sometimes be almost fan-shaped or like a banana leaf.
So now, are you trying to coagulate the vessel there or?
No, I am coagulating little bit of the veins over the surface. Saaf karna. See this? To make the tumor accessible for removal.
Yes,
See now the field has improved.
Yes, sir.
See such a big vessel there.
Yes.
See?
Yeah.
Zoom in please, little bit.
Katunga. Yeah. See lot of tumor vessels. Lot of tumor vessels. Give me scissors. Now, in order to separate this main vessel, see this main vessel below?
Yeah.
Yes, sir.
I will cut this branch. Cut this branch to keep the main vessel away. See, that is pushed beyond. Bipolar. This is
Dr. Vinayak from Mumbai is asking, when blood is into arachnoid, does it block the CSF absorption?
yes, it may. See now my inferior plane. No.
Yes, that's why you need constant irrigation and suctioning.
See this inferior aspect?
Yes.
Lower cranial nerve side?
Yes.
and I have separated, okay?
Yes.
And I have elevated this tumor now for removal. See this tumor?
Yes.
See, Narayan, the vessels over the tumor,
Yeah, yeah.
amazingly vascular.
It's antero-inferior portion of the tumor, Satish?
Pardon?
Antero-inferior portion of the tumor? That's
No, inferior, right inferior. I have elevated it, and see now this tumor is there for removal. This tumor.
Dr. Nageshwar Rao is asking the treatment for CP angle cholesteatoma is same or different?
Yeah, CP angle cholesteatoma is also known as epidermoid.
Yes, which you've said before.
Epidermoid is a different pathology, not like acoustic. Epidermoid doesn't respect the arachnoid planes, you know. It doesn't respect. And it can go, वो लगा ना आगे सक नहीं कर रहा, काट नहीं रहा. So arachnoid may envelop the neurovascular structures. Okay? It's a more complex pathology. So now this tumor I have elevated from the inferior pole.
Yeah.
And I can easily remove it now. See this? Lakusa. Bipolarized. See how much tumor we have elevated. Clean. Now, coming this side. See this vessel.
Yeah.
Give me the. Scissors. See this vessel, the big one?
Yeah, very, very big. And attached, firmly attached. Oh, branch is going. Beautiful. Beautiful.
No. Wait, हाथ मत लाओ. Small patty. देना यार. See, this is a small patty which I am inserting to separate this. So that was an important vessel that need to be dissected sharp, you know. And now this tumor is available.
In this case?
See this tumor I can remove now.
Yes,
Yes, sir.
Yes, sir.
and I can go below in the arachnoid plane further. See that?
Yes, yes.
पहले कुसा दे हटा दूँ give me kusa suction. See now, once tumor is separated, you have to remove it.
Yes, sir.
Hmm. 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 अभी देखता हूँ bipolar. कुसा कुसा This suction is not working. Kusa suction, I am not happy. देखो ना कुसा suction. See here, the majority of the tumor has been removed for bipolar. See again, I will see how deep I am.
Yes, sir.
I am reaching right over the brainstem.
You use endoscope over here?
Pardon?
Endoscope. Use of endoscope at this place.
I will later. At the end, I will definitely confirm with the endoscope.
So there was a question from Iran. Dr. Abdullah was asking, how will you ensure that your tumor is out totally? So
No, it's not out.
No, how will you ensure after it is out? How will you ensure? So with the endoscope, you will.
Yeah, we'll ensure. First of all, the way we are dissecting, we get to know.
Yes.
Same thing is, same question asked Dr. Madhusudan Rao. He asked the same question.
Tumor forceps. Yeah. Yeah, I will show you all with the endoscope. Suction. Suction.
Okay. मैं तो बोल देता हूँ तरीका हो गया बराबर बिल्कुल तो कुछ बता जाएगी
See this? Hello? Hello?
Yes.
Area which we have left for the last is the facial now. You know? Hello?
What about this post-operative means drain? Any drain you would put or any drain, lumbar drain or any?
Not really.
There's a question from Dr. Yogesh Agrawal. He's asking, do you prefer shunt or lumbar drain in pre-op hydrocephalus with
Not really.
CPA tumor, or you go for...
Even if there is pre-op hydrocephalus, most of the time you don't have to put any drain. You open up, remove the tumor, take care of the pressure part, majority of the time.
Okay.
Right. Give me other one.
Dr. Krishna Kishore from Vishakhapatnam has rightly commented that cool mind and lot of patience are the prerequisites here.
This requires only patience.
No, but we must all appreciate that it's not very easy to operate in a oozy field like Satish is doing it.
Yes.
It look rather simple, but it's not as simple as it really looks. Okay, it does pose you problems when there is a lot of oozing, and Satish is moving very fast in spite of doing it.
It takes a lot of time, to dissect. To dissect in the right plane. See how you have to develop the planes.
Yes, sir.
See this?
Yes.
See the medial surface,
Yes.
the brain stem. Venous. Now this much I have elevated. Oh, petty. Fast. Now give me Kulsa. See this? This much of the tumor I have elevated.
Yes. Satish, Dr. Achal Sharma is on with us right now, so you can ask. Dr. Dilip is also there. Dr. Panikkar is also there.
Achal boss.
Dr. Dilip, Dr.
Achal
Panikkar is also
boss.
there.
Yes, Satish.
Yes, boss. I have removed the maximum of the tumor.
I am seeing. Now you are at just juncture of where the most weakest point of the spatial nerve is.
Yeah.
And you may require sharp dissection.
That's why I am working first all around and lastly go there.
Yeah. You may require now separating with this type of seizure sometimes.
No, I may go deeper to the surface now. See, I am not going across the cyst.
Yes.
You never know.
Where vessel is there? One vessel is there.
The depth. Oh, depth is, now. I am working superiorly and there is a trigeminal now.
Yes, sir.
Could you see?
Yes, sir.
I will show. See that below. Kusa dena. See my arachnoid plane there? Can you see?
Yes, sir.
Yeah,
We can
beautiful.
clearly see.
And can you see this now below?
Yes.
I do नहीं.
Pardon?
Yes, sir. Very clearly see.
Yeah, bipolar. This is your trigeminal, you know.
Yes. So you're keeping.
लगाता हूँ.
No, I do नहीं.
So you're keeping a patty between the two?
I'm keeping all around patties in the arachnoid plane, you know, between the tumor and the arachnoid.
Yes, sir.
Once elevated, now I can remove the tumor.
Yes. So on MRI, we had seen how it was in close proximity with the trigeminal.
Yeah, you can see.
Yes.
See, the tumor you can remove so fast.
Yes.
Now, give me the facial monitor, please. कोई बात नहीं. Remove this. See the patties.
Yes. My God, 10, 12, 13, 14, 15.
And now, squat up. Yes. यूँ करना, यूँ करो. लो, monitor. Yes.
Deep, I think.
एडजस्ट पहले की तरह करो. हाँ.
Centralized?
Yes. Is it?
Yes, okay.
उसने सेटिंग बदल दी क्या? That is brain stem. करो.
So how much blood loss this patient had in these 2-3 hours?
No, hardly anything. Boss, it is under magnification. That's why you are able to see.
You don't, but you keep blood in this case, really.
Satish, your current is at 0.5 milliamperes, correct?
Pardon?
The current of the facial probe is 0.5 milliamperes, correct?
Yes.
So the take-home message is that the lower the current, 0.5 milliamperes, and you still get a robust response, means your nerve is not even having paresis. Okay, and if you have to use a higher current to get a response, it means your nerve is a little paretic. Right, Satish?
Yes. See, this is the tumor that is the brainstem below. Hello?
Yes, sir. Yes, sir.
सेटिंग सही दी है सेटिंग
That's a trigen. Dr. Nageshwarao is asking if you're practicing, are you practicing frozen section study in these cases?
These patients do not need frozen section. Why? We don't have any doubt about anything here. Why frozen section? Yeah, that is facial now. See that?
Yeah.
Right angle. Right angle, right angle. No. Yeah, that is facial now. See this? See how thin the layer is. See?
Yeah.
What the facial? What the facial?
There are many queries on CUSA actually. It's a
Many queries on?
CUSA. It's new to everyone, so they want to know the cost, availability, and exact mechanism, and they're asking if cobblator can be used instead of CUSA.
No, we have already mentioned this now.
Yes, sir. So you can,
Cobblator, I don't know.
what about the availability and cost of this, sir?
We have never used cobblator, number one.
No, the cost of CUSA and the availability?
Cost of the CUSA is 30 lakhs. Minimum. See how closely it is, you know. This is what happens in tumors, bigger tumors, and the relationship with the patient now.
Hmm.
It is
Very good,
placed.
very attached.
It is placed on the wall. See this?
Yes, yes.
Yes, sir.
Just zoom a little bit. Zoom in.
See now?
Yes, yes, yes.
It is so tightly adherent, No words.
Satish, are you considering a near total excision?
Pardon?
Would that make you consider a near total excision?
Consider what?
Near total excision.
Not. I cannot say right now. But
I
this
know you
wall,
go for total, but I'm asking you,
this wall looks like, this wall looking like so tightly adherent. See this?
that's exactly
Can
why I'm
you?
asking.
Can you see?
Yes, yes, yes.
Totally enveloped,
So why don't you want to go in for a near total? Let me put it this way. I
Yeah,
know
you
you're
can leave.
See the final part of the tumor. Hello?
Yes, sir. Yes, sir.
Satish, you can use the fine sharp micro scissor to separate this part.
Sir, micro scissor, if I use, I may leave the tumor behind. I am afraid. That's why I could use that. Your point is valid. But here I really want to lift it up. See the nerve.
Satish,
Yes, yes, man.
again the same question to you. Why don't
See
you
the
consider
nerve.
a small?
See the nerve
Yes, yes, sir.
Yeah, very
Clearly
good.
seen.
on the under surface. Could you see?
Yes, sir.
See how splayed it is. And this is a thin wall, my God.
Please zoom in a little bit for, I think we can.
Yeah, I will.
If it is comfortable for you.
Just a minute. Yeah, I will. This is the nerve below.
But
See
see
the
your
nerve.
comfort because, yeah, we can see.
Yeah.
See the nerve below, Narayan?
Yeah, it's played out. You can see it. You're removing it beautifully.
Oh my God, it's played out. Just a ribbon. See this, just a ribbon.
Yes, sir.
That's what happens. See, this nerve has an enormous capacity to stretch.
Yes, yes.
Yes.
Even in such large tumors, the nerve, which is so enormously stretched, yet patients do not present with facial palsy.
Because it is slow growing.
Yeah, this is the ability of the nerve, See this, I have completely elevated this portion. Little bit of the wound, venous oozing will take care later.
So I asked Satish the question twice, but let me give you the answer. Satish is going to go for total removal wherever possible, but then there is also a concept of near total removal where you could leave a small capsule behind on the tumor, especially if it is very tightly adherent to the facial nerve. It's all about facial nerve preservation. Satish, any thoughts, comments? Satish doesn't want to answer this question.
No, we have already discussed on this. Sir has already told us about this near total removal of the tumor. So the capsule is left behind and.
See this?
Yes.
Narayan,
Yes, Satish.
see this?
Very nice.
Now you tell me, total or near total?
You know what you're going to do.
रुक जा गुरु. अरे रुक जा यार, एक सेकंड. Remove this. Oh. Scissors. See, the whole game is facial now. And it is larger tumor, it becomes so difficult. Sometimes even if you preserve the anatomical integrity, because of stretch, it may not work.
So on this, there's a nice article by Miguel Aristegui. They had studied tumors of all the top people in the world, that's above 4 centimeters. And they said that even if there was anatomical preservation of the nerve in tumors above 4 centimeters, the rate of functional preservation was hardly in 50%.
Yes, correct.
And this includes great people like Professor Mario Sana, Majid Sami.
Yes.
How much loss do you expect in this case, this post-operative?
How much?
Loss means facial weakness will you expect in this case?
Depends individual. See the nerve.
Post-op will be grade 6. Post-op will be grade 6.
That means after 2-3 months, how much?
Hey, go there. Oh, Guru. Petty. See, this part of the nerve is absolutely intact, you know?
Yeah.
See this nerve?
Yeah, just strict. Beautiful.
Scissors.
Zoom in. If you're comfortable.
No, I have no issues. See final part?
Yes.
And this is so tightly adherent. See this?
Well,
yeah. Wait.
Well done, Satish. Keep it up.
Wow.
Forceps.
Amazing, sir.
Forceps. See this?
Yes.
Tumor removed. This is the facial nerve.
Yes.
See there?
Yes.
That is brain stem below pani there.
Now just to find all the anatomical landmarks, people are just waiting for that.
Now see the complete removal. Only this sliver of tissue.
Yes,
see this 1 mm on the facial nerve. Could you see?
Yes.
Just this.
To protect the function. And rest of the nerve is completely intact down to the brain stem. See this?
Yeah.
How it had become like ribbon. See?
Yes.
So thin.
We could preserve it because in the beginning we saw the nerve in the intra-aortic meatus. And looking at this, we went around and did our work. Got my point?
Yes,
Next. Under.
Satish.
Madam? Yes, madam?
Satish, just stimulate the nerve with...
Yes, I will do all. Narayan, I am slowly removing all these patties. My first goal now is hemostasis. Hemostasis is there, but I will ensure. See now, so many patties. Hey, pani dalta rahe. Thoda.
Satish.
Yeah, please, sir.
Patience of hemostasis I learned from neurosurgeon.
Pardon?
Neurosurgeon has so much of patience about hemostasis.
Yeah, I have seen I have seen, you know, you will not believe. I have seen Pankaj boss spending almost an hour for hemostasis.
This is what the amount of patients they have.
Yeah.
Moronic ENT surgeon do
Petty
not
there,
have that
petty
much
there.
patients.
No, no, वो रुक
So
रुक
whenever
रुक.
I do a surgery,
Yeah, the
in the
surgical
end, in spite of I see no bleeding, I tell
Yeah.
my neurosurgeon, please sit for 5 minutes and confirm.
Yeah, you must do an perfect hemostasis.
That is the most important part. This is a
Yeah.
question to
Petty,
Panikar.
petty.
Panikar,
Yes, Dr. Mogwani.
there is a rule of thumb that every case of acoustic neuroma, as a neurosurgeon, you are supposed to take CT scan same day, evening, or next day morning. Do you do it?
Always.
Always.
Always. Every
And
patient.
Panikar,
What I want.
we had more than about 380 cases. I have never done it.
I think we should. I think we should. I think it's mandatory because anything you do intracranially, I think it's absolutely, imaging is absolutely mandatory.
This is what you've been trained for donkey's years.
Give me,
It's not that I
wash.
never did it. I've done it when the symptoms are sign demand. Narayan, what do you have to say about it?
Yeah, I agree with you completely, sir.
See
We
now.
have done the MRI, CT or anything post-operatively, or in the next post-op day. In fact, we always believed that you should be an early
Bipolar,
mobilization
bipolar.
only for the night. And
Hello.
next day morning, the patient is out of the ICU and
You
we
lagana
believe of
tip.
mobilizing on the first or second post-operative day.
So, it's a rule of thumb. It's a brilliant rule. You know.
Hello.
I think I would very
Yes, sir.
strongly disagree with this because we have seen surprises.
I knew you were going to disagree. That's why I spoke to you.
Yeah.
Every neurosurgeon all over the world, they believe in it and do it.
Absolutely. Absolutely. I think it is very important. I think it is very important, at least for the surgeon, you know what you have done. It's not always looking for complications. It's you know what you have done. And sometimes, believe me, there are surprises, sometimes pleasant, sometimes extremely unpleasant. And you don't often want to wait for a clinical situation to evolve before you realize that there is something amiss. So, especially for the younger people.
As a rule of thumb, you must do it. I'm not disagreeing with you.
Yeah.
I'm not disagreeing.
This is especially for the younger people. I think it is very important that especially you should always factor it in.
Satish, ask Satish.
Hello.
Satish, how often you do
What?
CT scan next day morning? How
Pardon?
often after acoustic neuroma you do CT
How
scan next day
often?
morning?
I didn't get your question.
How often do you get a CT scan done next day morning post-op?
If any symptom warrants.
Okay.
This is a problem with dumb ENT surgeons. I call them dumb. But as Panikar said, you should not be taking chances. You know what I mean?
I agree. When a patient is fully conscious, standing, sitting on the bed with no symptoms, why do? You on the safer side, I am not against it. You can do a CT scan.
Satish, this is what I just now told them that I don't do it. I know you mustn't be doing it also. But this is what teaching of every neurosurgeon.
Yeah. The people
every
have,
institute all over the world will do it.
Sir, there are different practices for the same thing. I am not denying the importance. If he is doing, I am not saying that he is doing wrong, but yes, you have to take your call. As simple as that.
Yeah, but this is a message for every junior ENT surgeon who is indulging in doing acoustic neuroma. Please listen to what international rule is, not what Satish or Morwani does it.
No, this is not international recommendation, sir.
No,
society has recommended.
Every neurosurgeon will do it.
No, not every neurosurgeon is doing. Achal boss, are you doing every day?
Not.
Boss, are you doing for every case?
No.
Sir.
Sir. Usually not the next day.
Yes.
But depends upon the patient as well as.
Yeah, if the symptom warrants.
As well as. Yeah, of
No,
course. And now
sir,
number two.
Morwani sir.
Just now, 2 minutes back, Panikkar said that everybody does it.
Yeah, sir, but not everybody. And number two is to confirm your total dissection and your further study and your this part.
And second thing, I do not like too much surgical on brainstem. Panikkar, your response.
Any hemostatic material should always be used very judiciously.
Yes, of course.
Very judiciously.
These are things which make a lot of difference.
A little bit of pressure and heat for a while.
See, this is what Satish.
Yes.
We try and finish the bloody end in 5-10 minutes. Neurosurgeon will take too much time. We won't be using too much of surgical unnecessarily.
Yeah, that is
Do you
right.
agree with me?
That is right. Agreed.
Yeah.
But I have seen, sir.
Give up pressure, and even if I put surgical,
Sir.
X, Y, Z amount.
Sir.
Gradually, after 10, 15,
अरे
20
sir,
minutes,
सुनो तो
I would like
सही.
to take away as much surgical as I can.
Sir,
Panikkar?
I have seen many neurosurgeons. There is a divided opinion. I have seen them using Surgicel like anything. You know, I agree with Panikkar sir not to be used too much, but I have seen many of the neurosurgeons, very senior neurosurgeons, using Surgicel generously.
I won't call it generously, I would say ungenerously.
Whatever your terminology is.
Using too much is not good.
Sir, these are the sir.
मेरे को रुकने की आदत नहीं है, तू रुक ना
सर वो बात मेरी और तेरी नहीं है. Sir, what you are talking.
उड़ने की आदत है, उड़ते हम लोग.
No, sir, you are going in a different direction. Sir, it's not about you and me.
Why can't we learn from them?
Sir, you are forcing something which is not a practice parameter. This is different in different conditions, you know, in different hands. How can you direct? You ask here 3 neurosurgeons, 2 neurosurgeons do not get CT scan done, one is getting. It's not wrong. It's a practice pattern difference. So you have to take your own call. How can you direct that something is right or something is wrong? Nothing is hard and fast.
Satish, I am also saying I don't do it, but ask partly is a rule of thumb.
I am not saying he is wrong.
Like Atul Goyal does it in every case, okay? Like, we are discussing, it's not what you are doing is right or what I am doing right. We are saying what is the structure followed by the people around the world.
Okay.
I am not saying you are wrong or I am wrong.
Okay. Paramita, can we take any other questions?
So there are...
Satish?
Yes.
Satish?
Can we take any questions?
Satish?
Yes.
At the end of the surgery, do you want to stimulate the facial nerve close to the brain?
Yes. We are just now.
And so after the tumor removal, do you also do
एक मिनट facial now probe. Just a minute.
Do you also ask the anesthetist to do Valsalva or something after you remove the tumor?
That is after CSF rhinorrhea, not here.
See, here there is no need, Paramita.
Okay, sir.
I know if you want to see any bleeding point about anything, I have like posteriorly there was some venous area, so I would like to leave there is no bleeding, but still I would like to leave a single layer of Surgicel. So it is different.
Okay.
See this?
The picture, microscope picture is not there.
I will show you the course of the nerve. I will remove it.
Satish, microscope picture is not there.
Oh, microscope picture? Why you removed? Please, microscopic picture.
Ganesh, microscope picture.
Please connect microscopic picture to removed. Break लगा है क्या इसका? Break लगा इसका. Okay, just a minute, boss. Yes. Are you getting the picture now?
Now we are getting.
नहीं पहले forceps दे. Yeah. La. See. Can you see?
Yes, sir.
Can you hear?
Yes, sir.
Yes, Satish.
Can you hear?
Yes.
Yes.
Narayan?
Yes, Satish.
Beautiful.
See, such robust response.
Yes, sir.
Narayan, happy?
Yes.
Very much.
So this gives a sense of relief. Anatomical continuity with responses. That means my patient is going to do well.
Very
Simple
nice,
as that.
Satish. Well done.
If possible, just show us the endoscope if all the structure is possible.
Yes, sir. Show us endoscopically all the structures if possible.
Oh, I have removed the gloves.
Okay.
Okay, no problem.
What I have done, I kept the, the surgicel and the patty. Boss is going to look at the hemostasis if any required, because we'll keep it open at least for half an hour for hemostasis.
Yes.
We are not going to close it.
Okay, sir.
And if fat you take from abdomen or you take high
Pardon?
fat for this thing.
Pardon?
You take high fat for this thing for closing. Fat from thigh or fat from abdomen?
From thigh. What we do, we'll make long strips of fat. Long. So they will go vertically down in the CP angle. 1, 2, 3, 4, 5 like parallel. And close the entire tunnel. It's not a single point closure of the leak. It is closure of the entire tunnel, and we'll pull some fibrin glue also. So this will, like this depth of the tunnel, like this depth of the tunnel, the entire depth will be blocked with the fat pieces. So that leaves rules out any possibility of CSF leak. That is the best one. And then we'll put our flap. First we'll suture both the superior and inferior parts of the medial part of the half of the flap. So that will keep the fat tightly into place, and then we'll place the lateral part.
Closure of the eustachian tube. Closure of the,
No. Narayan, the editor's closure, retrofacial, facial is closure already done. That I have already done before, opening the dura.
Middle ear is intact.
Middle ear is intact. So we'll just keep it for half an hour to see for hemostasis, and then we'll close it. Yes.
Fantastic job with the splayed out nerve.
Yes, sir. So you can just little bit enlighten us about the cochlear implant and ABI at the simultaneous sitting?
Yes. If if you want to do implantation during surgery, you have to ensure the integrity of the cochlear nerve. You have to have a cochlear nerve monitoring, and you have to be very practical about which cases are possible. Let me show you. Let me show you a few slides about the hearing and the facial now. First of all, can you connect the laptop? Yes.
Yes.
See, this is what we are discussing about the serviceable hearing. There are many classifications, Sana and Robertson Gardner. So by and large, if your pure tone threshold is within 30 decibel and the SDS is above 70, or at least above 50, it will be called serviceable hearing. This class A and B is called serviceable hearing. Number one, whenever you talk of hearing preservation. Number two, these are the situation. A lot of people talk about hearing preservation, that they do the pure tone and consider hearing preservation is a joke. Secondly, if somebody says that he has removed 4 centimeter tumor with preserved hearing, is nothing more than a joke. Not possible. Practically. It's not immediate and long term. So these are the situation you can see on the screen, wherein you can think of hearing preservation. There is a possibility, likelihood. If the tumor is small, according to Professor Sana, who is such an experienced person who has done more than 3,000 acoustic neuromas, he has seen each and every possible situation. And according to him, more than 1.5 to 2 centimeter tumor, it is impractical to preserve the hearing. Whatever hearing you preserve, rather it is detrimental because of the perverted
sensations coming from the other ear rather disturb the hearing from the other ear. You know, it is better to sacrifice those. So small tumor, all, fat lip. The all medially placed tumor not extending into the fundus, we have already discussed. Any tumor extending to the lateral part fundus, forget about hearing preservation, as simple as that. As I mentioned in the beginning, tumor arising from the inferior vestibular nerve are in close proximity to the cochlear. They involve the cochlear early in the course. Even in the small tumors, it is difficult to preserve. It is possible mainly for the tumors arising from the superior vestibular nerve. Secondly, pre-op hearing status is very important. As I mentioned, class A and B, when you have a good speech discrimination along with the pure tones, and pre-op ABR response is equally important. And nowadays, you know, pre-op, this transient evake OAE, if you have all 5 frequency band TE OAE intact, believe me, you have the best chance of preserving the hearing. This is another added on investigation to predict the hearing preservation. Then, any history of previous radiotherapy, all cystic tumors, forget about it. These are the most complex tumors. Cystic tumors, fast growing tumors, they are unpredictable tumors. Hearing preservation is not possible. And post radiotherapy, we know the reason. Whenever you give radiation, you know, there are chances of more fibrosis, adhesions. And you can't, with this kind of, you know, the nerve, how I separated from the wall. I think I was not so gentle. People would spend 1 hour or more on it. To gently separate, sometime not pulling, sharp dissection. So I am happy I have good robust response, but this is something very, very important. So in those situations of post-radiation and all, it is impossible to separate. Forget about hearing preservation. The reason is, you know, there are so many regions which are the impediment to hearing preservation. Traction on the nerve. You saw the nerve, how it was, you know, the facial nerve was being preserved.
Yes.
When the cochlear nerve in the intra-auditory meatus, particularly when the intra-auditory meatus is expanded, or a large tumor, wherever, whenever you remove the traction of tumor removal on the nerve, even the nerve has a severe adhesions. Ischemia may happen when you remove the tumor. Even the intra-auditory artery preservation is difficult. And in close proximity, even the microscopic invasion of the tumor you can't rule out. If you try to preserve hearing more, rather you may leave the tumor behind, you know.
Yes.
And even if you are preserved, what happens post-op? If you have a reasonably good result, you may not sustain those results because of the scarring and the fibrosis in the intra-auditory meatus and the cochlea afterwards. And that too mainly happens when you take away the blood supply. So there are so many, you know, reasons for not preserving the hearing. And according to Professor Sana, if you have a tumor about 2 centimeters, however good you are, whatsoever you are, it is practically not possible to preserve the serviceable hearing. And if a person like him, who has done 3,000 acoustic neuromas, says it's a dictum. As simple as that. Narayan, what is your take?
Absolutely correct. Satish, 200% agree with you.
Satish?
Yes.
There's a take of ENT surgeon. Ask neurosurgeon.
Yes. Yes. Panikar sir, Achal boss, please.
Yeah. May I ask a question?
Yes,
the question is related to bilateral acoustic schwannoma, where the patient may lost the hearing, even if you are doing the site where the hearing was previously present. So what is the role of cochlear implant if you plan for it?
Yes, so cochlear implant is possible in those situations when you have a small tumor, when you have a cochlear nerve monitoring at the same time, and at the end of the surgery, if you find that you could preserve the cochlear nerve and your monitoring is showing good response. Only those limited situations are there where you can think of putting a cochlear implant, otherwise ABI.
Okay.
So that is for very limited indication. That is for very limited indication, sir. Intracanalicular tumor, very small tumor. You have a complete hearing loss, only hearing ear. And you have, because of the small size of the tumor, your experience and you can still separate it. That gives you opportunity to separate as well. And with the facility of, at now monitoring your experience to separate the tumor, those are the things which makes you do that implantation. Otherwise, it's not possible in large tumors.
And so there have been articles by Professor Sana only where he has said that in the dorsal cochlear nuclear action potential that we do, if it is positive response and good chances of cochlear implant. Even if it is negative response, then it is not sure if it's a permanent cochlear nerve damage or a temporary contusion. So in such cases, he has proposed to insert an intracochlear electrode at the time of the surgery to avoid the cochlear ossification.
And you can take a call later on with promontory stimulation.
With 12 promontory test.
Why still we are so, biased towards doing this? The reason is, the worst results of the cochlear implantation are better than the best results of ABI. So, whenever possible, think of implanting, if possible, implant then ABI. This is something, is a truth. You cannot deny it. That's why we are, forced to think of cochlear implant and making conditions for that. And if finally fail, ABI is the only answer. Then something about the, facial nerve. We did the facial nerve. This was 3 by 3 by 3 centimeter tumor. Still we could preserve it. And I give the credit to this approach as well, where I could see the facial nerve, predict the facial nerve, see the facial nerve with a monitor in the anterior superior part of the canal. What I did, I went around the inferior, posterior, everywhere, leaving that part intact. Because I had a full information that my facial nerve is there. Now remove the rest of the tumor all around without putting traction on the nerve. See, it is not the anatomical continuity of the nerve which is important, it is the traction on the nerve which is responsible for the ultimate result. So, having done the tumor removal from all around and finally coming to that area to minimize the traction. Then once you come to that area with a minimal tumor, you can see the nerve below at the brainstem level. And now once you have seen at both ends, now you can easily, preserve it. Just 1 millimeter of the sliver of the tumor, I intentionally left over it because I believe this 1 millimeter is not going to give problem. They are devascularized and they may not grow. Majority do not grow. And if still they grow, we'll do with the MRIs. And we can take a call with such a small part without any problem. So
Satish,
like for the facial.
Ask the opinion of neurosurgeon about that. Ask the opinion of Panikar.
Yes, sir. Panikar, sir, please.
About what small tumor left behind.
Panikar, sir. Achal, boss.
Yeah. You are absolutely right that you can leave the tumor. It is, although it's very slow growing, and when you disconnect from the both ends, usually it does not grow, and you can leave very well a thin capsule of the tumor over the nerve rather than damaging it. Number two, the functional preservation of the facial nerve has another aspect where the traction and the vascular supply of the facial nerve, multiple factors are there for the post-operative function of the facial nerve. So there are multiple things which we can think about.
Yeah, that's great. So this was 1 millimeter. There is hardly any tumor, I would say. Now, the second credit I would give to the facial nerve monitor. Without the monitor, you can't think of doing vestibular schwannoma surgery. In many of the countries, it is mandatory to have a facial nerve monitor before doing any acoustic neuroma surgery. And I can't even think of. For that matter, if you ask me, it is mandatory to have this.
Satish, we are talking about facial nerve monitor today. we
Yes,
did
sir.
not have 10 years back.
10 years back, yes, I remember.
Am I saying?
See, that's
Hello?
how the science is evolving.
Am
We
I
are
saying
improving.
patient monitor is not essential? It's absolutely
No,
mandatory, as you
no,
are
no,
saying.
no, sir.
It's absolutely mandatory.
We have to talk the best possible.
Hello. Hello.
This
It's
doesn't
absolutely
mean
mandatory.
that you recommend.
Hello.
Hello.
I'm not recommending anybody not to use it, but knowledge of anatomy, the look
Yeah,
of
that is
patient are very
important.
often defined.
That I am
And
not
looking at a
undermining.
patient, now you should be able to identify patient on every mess.
Sir,
This is very important.
it's not a matter
And that's
of.
a clinical experience.
Sir, I am not undermining that. That is implied. You are not doing vestibular schwannoma surgery without that. That is implied. Now, these are the factors which are important in decision of, in predicting the facial nerve, preservation. Like some unfavorable factors like brainstem compression, edema within the tumor, and the surrounding brain edema, tumor consistency with vascularity, all these are negative factors. Irradiated recurrent tumor, all these are difficult. Then your surgical technique matters. Obviously, your surgical experience matter. Intra-monitoring, adherent tumor. Now, this point is very important. Distant from acoustic neuroma to fundus. In a very, very laterally placed tumor, sometimes it is difficult. Particularly if you are using a hearing preservation approach like middle fossa. An extremely laterally placed tumor, because that fundus area is very narrow. And trying to remove the tumor from there sometime can, endanger the facial nerve. And then I showed on the MRI tumors which are projecting more than 1.5 centimeter anteriorly from the porus of the intra-auditory meatus. Anteriorly. That much of, anterior displacement is detrimental. That makes the nerve more, like a ribbon. And it is difficult. It makes the preservation of nerve more difficult. And, these are the reasons why what happens to the nerve we have already discussed. The way it is thin and elongated and adhesions and so many things we have already seen. We discussed earlier the dorsal shift of the nerve. In up to 2% of the cases, it has been found that the nerve is placed behind the tumor towards the surgeon. So it is all, these are the
Satish, we have
factors.
discussed one important point. Satish?
Yes.
Hello?
Yes, sir.
Satish,
Yes.
how often you extubate the patient on the table?
How? Almost always.
Often? Huh?
Almost always.
Okay, this is the difference between we and the neurosurgeon. Most of the neurosurgeons do not extubate the patient on the table. Number one.
They keep it
They
relaxed
put
for a
the
day or
patient
so.
on the ventilator.
ऐसा तो कुछ नहीं है ना?
They will put the patient on ventilator.
Sir,
That's
this
the
is
worst thing.
sir, this is not
Sir,
sir, क्या हो गया आपको? This is not hard and fast. What are you talking?
No, sir. We are extubating.
Hello.
You ask the neurosurgeon
We are
here.
talking about particular person.
अरे अभी इन्हीं की तो बात कर रहे थे, अब इनसे ही पूछो ना.
No. We always we always extubate during just after surgery in the OP before shifting to the ICU.
It is not guideline that you don't extubate. We almost always extubating.
Hello. Ask Panikkar how many centers people extubate immediately.
Ask Panikkar sir. Panikkar sir, what is your opinion?
Almost always.
Yes, no. Bas.
Yeah.
Finish.
This is an important
Almost
statement.
always. I think the days when we used to ventilate are no longer there.
Listen, Panikkar, what was 20 years back? What was 15 years back?
Sir, we have to talk of now. As of now, what is?
No, I don't think anybody
hello.
ventilates overnight unless there is a problem or the patient is not waking up or the patient has been oversedated. I really don't think so.
Sir, I think all this discussion is getting very confusing for all of us. So I think we will just follow the panelists who are sitting here, the neurosurgeons who are sitting here. We'll
So
just
now-
follow their views.
I will watch up again and show you the closure. Okay? And then we'll move on to the next case.
Yes, sir, we want to see the insertion of fat and...
Yeah. Few minutes. I'm back. You can continue discussion.
Anita?
Panikkar, sir, you were saying something about the extubation. You can go ahead, sir.
No, I think the vast majority, the thing about ventilating overnight or keeping the patient on ventilator used to happen earlier.
Yes.
In this day and age, I don't think anybody really ventilates a patient unless the patient has been over-sedated or they are not waking up well, or there is some other medical issue.
Okay.
But otherwise, the vast majority of people are extubated on table.
Okay.
Yes, sir.
Yeah.
Okay. And so what about the post-operative management that you all follow? What is the post-operative management for this case that has to be followed?
Nothing in particular, just routine antibiotics. We give very short, at least I use a very short course of steroids, perioperative steroids, which
Okay.
get tapered off very rapidly
Okay.
in the next day or two.
Okay.
If there has been significant compression of the nerve or the nerve is very stretched, I usually keep them on nimodipine for a few days.
Okay. So
That
how
is
much dose
more
of
to improve
nimodipine there
the
was?
vascularity of the nerve, causes a bit of vasodilatation and improves and affects the
Paramita,
vascular nerve.
Yes, yes, sir.
we use 30 milligram 5 times a day.
Exactly.
Okay.
That's
Okay.
that's a low dose, and that is continued for a week or so,
Okay.
and that's it.
Okay.
Otherwise,
Post-op,
there's nothing in particular about the
post-op steroids, sir. Any post?
What they suggested?
Any post-op steroids and any
a short course of steroids, short
Shoulder,
perioperative course of steroids.
ये पंचर कर दिया.
Patient put on dexamethasone the day before, or the night before, or they're given a shot on induction,
Okay.
and that's it. And then if the patient is well, about 48 hours later, it's generally tapered off.
And so what about your experience of lumbar drain post-operatively?
Not really.
Okay.
Not really. Unless there is a CSF leak or something, that's all. Otherwise, really nothing. There's no need for CSF. See, the whole thing about once you remove your tumor, you're re-establishing CSF pathways.
Yes.
And once you re-establish CSF pathways, the need and your closure is good. You
Okay.
really do not need any kind of an external drainage.
Okay. Okay, so. And so any special consent, the normal consent we know. Anything else you would like to add as far as consent is concerned?
I do not know the kind of consent of what this thing is generally taken in amongst the ENT surgeons who do vestibular schwannomas, but the usual things about cranial nerve injuries and neural injuries and so on and so forth. The usual.
Panikkar, I have a question. What incidence of morbidity you give to the patient as a neurosurgeon, and what are the chances of getting hemiparesis, for example? You tell the patient.
Hemiparesis?
No.
I don't think hemiparesis is a
Yeah, but no.
No.
Lot of patients have come to saying that they've seen A, B, C person. He said the mortality rate is XYZ during the surgery. Hemiparesis chance is XYZ. So I want the people to know that these things are almost up past tense.
I don't think you can really say that your incidence of neural injury is going to be zero. It
Negligible. So, some people are fond of doing radiotherapy. They tend to terrify the patient of death on the table. They tend to terrify the patient of hemiparesis and things like that. These things practically do not exist today.
Dr. Morvani, I think every surgeon knows that you can swing your patient either way depending on how you emphasize or overemphasize or underemphasize your complications. I think the important thing is to be as factual as possible.
Yes,
what is
sir.
also important is for each surgeon to be cognizant of their own morbidity rates, their own cranial nerve preservation rates or their outcomes.
Yes,
rather
sir.
than simply quoting literature. I think
Yes, sir.
that is something that is very, very important. What are the outcomes in your hands? And that is something that's very important for the patient. When you
Yes,
talk
sir.
to patients, I think that is very important. See,
Right.
anecdotes will always be there. The good and the bad, that will always be there. And these are stories that keep circulating all over the place. These are incidences, these are anecdotes that keep circulating. And they keep popping up ever so often. Once in a while, they keep doing so. But
Yes,
what matters is if every individual surgeon has their own clinical audit, you know your own outcomes, you know your own rates. I think that is what is probably the most convincing argument vis-a-vis what is there in standard accepted literature.
Yes. Yes, sir. Agreed.
And Sonika, what are the incidents of CSF leak by either approach, literature-wise, post-op?
I don't think they're very vastly different. I mean, both have the incidences of CSF leaks, but I don't think it's anything. In the past, yes, there used to be a significant incidence of CSF leak with either, but I mean, in this day and age, I can't remember offhand that CSF leak, apart from being mentioned that it's theoretically possible. Yes, in either way, you can have the paradoxical CSF rhinorrhea where, you know, either way obliteration is not complete or there is a pathway that remains open, or your patient develop hydrocephalus, or you have an unaddressed hydrocephalus. Those are issues. An unexplained leak, look for hydrocephalus, that's important. That's something that has to be addressed.
So, Monica, how often you do your cases translab? How often you do retrosigmoid?
I think sir usually follows retrosigmoid.
I mean,
Yeah,
I
as
use,
sir had.
see, it's very circumstantial.
No, let's say in your series, percentage-wise, whether you did a 50%, 60%, 70%, either way.
I think it's changed over time. The simple reason is the circumstance in which you work. Now the system in which I work, I generally don't get in for my patients right from the beginning. Now there was a phase when I used to do predominantly translab surgery. But now because I don't get in, I have colleagues who operate as well. So I step in and assist them. Now, many of them are not as comfortable with the translab approach as what I am. So if I have a choice, if I have an appropriate tumor, I get in from the beginning and do a translab. But I don't always do it. So if you look at my practice, it's not an individual practice. It's a practice of, we are at least 3 operating.
So this is what the problem is. We as a ENT surgeon, we haven't trained adequate number of surgeons to be familiar with translab approach. This is why the neurosurgeon can't get a help from an ENT surgeon. Because ENT surgeon is so happy to do a regular surgery, you know, do a 1 hour tympanoplasty, 2 hours tympanomastectomy. He is not keen to learn. You know, people are not learning. People don't want to learn. If you had a more population of ENT surgeon, if you had more population of ENT surgeon in India, any particular city, doing translab.
I don't think any questions. They all are interested to see the multi-layer closure.
Yeah, let him start now. Let him start. Till he starts, we are talking.
Hello.
Yes, sir.
Yeah, Paramita.
Yes, sir.
Yeah, for the closer part.
Yes, sir. So you have to tell us about the thigh fat that you've taken. You've soaked into the rifampicin.
patla dena.
We have next case, Glomus. Is ready? Is prepared? So Satish?
Pardon, boss? Yeah, Glomus is induced. Already induced.
Yeah, just
already induced.
Take incision. Tell someone to take incision. They can do.
Yeah. That will be good to save time, you know. Now see.
I think, no, sir, we are still on the PPT.
Are you getting the picture?
No, sir, not yet.
Okay, just a minute. Oh, fat la. Fat. Lambi bana liye. Glue. Are you getting now?
No.
Are connect karao camera yaar.
Still it is PPT.
Can somebody ask to connect the camera?
Dinesh. Yeah, now it's coming.
Now coming. Focus. See, we have given almost half an hour for the hemostasis. See this?
Yes.
Yeah.
And absolutely some surgery cell behind. in the areas of the venous oozing, you know. See this brainstem? This is your facial now. Again, you can see the facial now.
Yes, sir.
See, this is the facial now. This one.
Yeah, very good.
Ribbon-like facial now. And now, what I will be doing is the fat. See now, everything, everywhere is. We have already closed the editors. We have already closed the, you know.
Satish, one
Yes.
question to you.
Yeah. Yeah, Narayan.
Yeah,
See this, see this, see this. I have closed the editors. Can you see?
Yeah.
Yes.
I have closed the retrofacial cell. Can you see this?
Yes.
This is too important. This is the facial recess, Narayan.
Yeah.
See this with the surgical. These are 3 areas. Never take a chance.
Absolutely.
Never ever take a chance in these areas, you know.
And people were discussing CSF.
Yeah, give me telescope, please. 0 degree. Let me show you the intracranial structures at this point of time, okay?
Yes.
With the telescope. Yes, Narayan.
Just one question for, I don't know whether you have discussed this, but there are a lot of people watching this and we would love to know this. Suppose you didn't get a good, robust response for the facial nerve. What would you do?
Yeah.
You have
So, if I have not got a robust response,
the nerve is anatomically intact, but
Yeah.
you don't have a robust response.
yes,
What would you do?
I am coming to it, Narayan. Just a minute. See now, are you getting the endoscopic picture?
Yes, sir.
Can you
Yeah,
give
we're
me
getting
30
it.
degree also? This is 0 degree.
Yes.
Okay, now see this now anteriorly, which is rising up to the Dorellos canal.
Yes.
Yeah, beautiful.
That is 6 now. Can you see?
Yeah,
This is 6 now, boss.
beautiful.
Can you see this? Now,
Yeah,
above, can you see the 5th now?
Yes.
Yes.
Yeah, beautiful.
The
Wonderful.
thickest of all 5th now.
Yes.
Now see the 7th, now see the ribbon-like.
Even like, yes.
See how it is ascending up. This is 7th now, okay?
Tentorium, sir?
Tentorium is up and above. You know, it is above this. I don't want to disturb here.
Okay, sir.
See the arachnoid bands there?
Yes.
Yeah, we can see.
And now inferiorly, you know, these are lower cranial nerves. Can you see?
Yes.
We can see.
Can you see the 9th now?
9th, we can see very clearly.
And what is this bone? This is occipital condyle. Now this is the, ICA. You can see.
Some oozing is it?
Going
From up, I think.
Oh, it is going from here laterally.
From outside.
Yes. From the, I got it.
I think better to close it. Yeah.
Yes. There was some little tear while they were cleaning on the sigmoid sinus.
Satish,
Yes.
it may be a good idea to show them, now since you're doing a glomus, maybe a good idea to show them how the lower cranial nerves are related to the jugular bulb or medial wall of the jugular.
Yes.
Maybe a good idea for them to
See what I'm trying to show. See. Can you see the pica there lower down?
Yeah, you can, yeah.
This is pica in relation to the lower cranial nerves. And see where it is arising from. See the big vessel there anteriorly? That is vertebral artery.
Posteriorly, yeah.
Can you see there?
Yes, sir.
Yes, very thick, very big.
And see, these lower cranial nerves, they ascend down up there in the medial wall of the jugular foramen. This is occipital condyle. This is occipital condyle in the medial wall of the jugular foramen.
Yeah.
These nerves ascending in the jugular foramen, and they run underneath their, dura in the medial wall of the jugular foramen to come down vertically 90 degree into the brainstem, towards the brainstem. And this medial structure is occipital condyle. 9th, 10th, 11th are here. See this?
Yes.
And the 12th, if I go down medially, you can see the 12th.
Beautiful.
Can you see that?
Beautiful.
That passes through a separate canal in the occipital condyle to come down
medial to the jugular foramen to come out of a separate canal, hypoglossal canal. And that vessel, that hypoglossal, is closely associated with the vertebral artery.
Vertebral artery.
See that? That is the medulla oblongata, and this is about the intracranial anatomy.
Yes, sir. Now it is complete.
Okay?
Yes, yes. Perfect.
Yes. Dr. Mayuresh Verma was after me since long time. Boss asked him to use the endoscope. Might he can.
Okay.
So many were requesting for
I forgot to show earlier, so
Now Paromita seems happy.
Yes, yes. Very happy.
So you have not when you obliterate the instrument tube in these cases?
Not nearly, boss. Not why. Only when if the post-op there is a situation of a CSF rhinorrhea.
Yeah, and.
So I'm more interested with Narayan Jaishankar, Dr. Narayan's question that it's an interesting question about the facial nerve which he had asked. So what is your opinion about it?
So that question now, in case you have no responses on the monitor,
yes,
you preserve the nerve anatomically, but no response, what to do? Now first of all, you have to wait. See, once you have kept the nerve anatomically intact, you have to wait. And few months, many of the nerves start functioning again. Sometimes the response may come late, even 6 months after. So it is advisable to wait for few months before taking a call of, the 5-7 anastomosis or anything else.
Okay.
Number one. Number two, you can predict by means of post-operative electromyography. Because electromyography can detect the recovery of the nerve function, even before the clinical recovery. Okay? That is another important point. Now, thirdly, if your nerve is suppose sacrificed during the tumor removal,
yes,
what to do? In this approach, if I find the medial stump at the brainstem here, suppose, because this approach only gives you that opportunity. The medial stump at the brainstem, I can anastomose with this vertical segment facial nerve. See, that is there in the vicinity. I can harvest the sural nerve and I can place the sural nerve right from here to here and anastomose with the vertical segment. And it is amazing because this is going to contain the, the facial nucleus discharge, and it is still going to give a spontaneous smile, though maybe grade 3, but it's still that is the best option available. So that can be done at the same time. That cannot be done in any other approach.
Okay.
Okay. Glue आ गया.
Satish, now shadow from Satish.
पतले बना.
Satish.
बिल्कुल पतले लंबे. यूँ लंबे बना.
Satish.
Yes, boss. दो जने पकड़. Yes.
Shadow from Australia just asking.
Yeah.
Can we use protein-rich plasma over the facial nerve in all the cases? Like we have.
Any?
Protein-rich plasma or PRP over the facial nerve in such cases.
Yeah. In case you do anastomosis, I prefer to use platelet-rich fibrin, PRF, not PRP. PRF, there are many ways of, you can use the platelet, the PRP, PRF, APRF, many things. I use PRF, which can be prepared by the autologous blood by, centrifugation for 3 minutes at 700 RPM. Remove the RBC and the rest is a PRF, and it, it is a membrane. So you can,
put over there.
Use that membrane and wrap the nerve around. It works, it gives growth factors, and it is really useful.
Okay, sir.
Now see, I am going to show you our layers.
Yes.
काटे जाओ, दिए जाओ, काट. पकड़ना.
Rajiv Kapila ji, any comment? Rajiv Kapila has joined us.
Yes. See now. See now.
Demonstration.
Sir, you have to tell us what solution you've.
This is same rifampicin.
Only rifampicin.
See, the advantage is why we are using this. This is not a single dimensional closure.
Yes.
It's a complete tunnel. Through and through we are closing.
The most important thing in this is, you see, he's not stuffing his fat into the CP angle area. It is partly intracranial and partly
extracranial.
Yeah. Lade.
Yeah.
Sort of almost seals the dura like a cork.
See this? The entire glue का है?
Today's thigh must be free from fat. One-sided.
See this area below, there was a small rent on the, jugular. I covered with this.
Sigmoid.
See, there is no pressure on the facial now or anything in the CP angle.
Yes.
And I'm using thin strips, not thick ones. Overall, this approach, if you take care of, like I used, that bone wax all around to the possibility of cellular areas. Remember? And then these fat strips all the way. So this is not a two-dimensional closure, This is a pure three-dimensional closure, Hey, what else? It's a pure three-dimensional closure. See, through and through the entire length. It's not a single sort of perforation where the CSF can come.
Okay.
Yes.
It has to pass all through the, length. Radhe?
Satish, center it better.
Yes, man. Now?
Yeah.
Look. यार बाल क्यों आए? Now, once you place this, the other fat layers cannot be disturbed,
Yes.
They are pressing on each other. See now, completely pressing on each other. Can you see?
Yeah, beautiful.
And forget about CSF leak. We have done so many, and touch wood. Yeah. Ab bada de. Yes. See now, this is overpacking. Hello?
Yes, sir.
No pressure inside the CP angle.
Yes.
Now what we'll do, we'll put 3 or 4 stitch from this flap which we have retracted, to this flap we have retracted above.
Yes.
Yes.
See that? Those 3 or 4 absorbable stitches, and then put the big flap over it. So it will never go anywhere. Got the idea?
Yes.
Yeah.
Satish,
Okay.
zoom out a little.
Yeah, boss. Now all around I will place this fibrin glue. See this?
Yes.
Just to keep in place. That's it, forceps. Patli. I hope you got the full idea.
Yes, absolutely, sir.
See, this is 3-dimensional closure because the entire length, entire tunnel is completely compressed
Yes.
by the fat.
No free fat in the brainstem area.
Pardon?
No free fat. This fat is not entering into the brainstem area.
Not at all.
Not at all.
There's no pressure.
Yeah.
So now our next case is ready, and let me quickly give you the details of the next case.
Yes.
Is again a young male. Young patient is an indication, For again the same story with the glomus. Like acoustic, for young patient, yes. Now that patient name is
Yes. Let me give you. Where is the CT? Asif. Yes. Can you connect? Yeah. Yes. Are you getting something on the screen?
Yes.
The most important investigation which I like for such vascular tumors is the CT angiogram. This is a contrast NN CT scan with a complete angiogram to give you complete information about the extent of the tumor, vascularity, cross flow, and how the vessels are entering into it. Let me show you. Yes. Now, look at the temporal bone of this patient. See the jugular foramen of the opposite side? We discussed in the last case of the Glomus, the radiology in detail, you know?
Yes, sir. Yes.
So here I will just highlight the important points. Are sun? Just a minute. Hello?
Yes, sir.
Yeah, so that we can start the case quickly. So, we discuss in detail. Now here see, on this side, the normal jugular foramen, can you see?
Yes, boss.
See the jugular foramen here, normal? And look at the opposite side, what is happening.
Huge.
See this widening sort of a mouth-eaten appearance of the jugular foramen.
Satish?
Yes?
Sorry to interrupt. Your faculty, Dr. Panikar, is saying that he's got an early case, so he wants to leave. So
Yes, yeah. We are indeed grateful to sir for giving this much of time. And we really had a great, input and learning experience from sir.
Yes.
His comments
Thank
are
you so
always
much.
like he is an authority,
Yes.
and his experience speaks. Thank you so much, sir, for coming and being with us.
I don't know, has he left already, Paramita?
Yes, he is left. Just left.
Okay, we'll convey him.
Yes.
Thank you. So now, see on the opposite side, jugular foramen.
Yes.
This is the big mass, and see the carotid artery on this side. See the carotid on the opposite side. What is there the relationship of the jugular and the carotid normally? They are separated by a, bone. And here you see there is no bone. This vertical segment of the carotid artery is all the way in relationship to the tumor. See, I am in the neck. Come above, see the portion in the neck, a little bit of the tumor below. As I am coming up, this is the jugular foramen. This is vertical petrous carotid artery, vertical. See this? Now the genu, until there it is in relationship with the tumor behind. And now the moment it becomes horizontal, there is a bone over it. Can you see, Narayan?
Yes.
The tumor is involving the entire vertical portion of the carotid up to the genu. And the horizontal is absolutely free. This is how the involvement of the carotid is. Now, we need a lot of information from CT angiogram for that matter. Chalu kara diya? Dekhna, kya hai? Bolna hai. So, what information we want? Let me show you.
Mr. Burman? Yeah. Sun Pharma team is still there with us.
Oh, yeah, I'm with you, sir. Always.
We go up to 2, no problem.
We are bothering him so much.
I'm enjoying his way that
you want to convey anything for all
Yes,
the
sir,
very
thank you, sir. Once again, thanks. I mean, it is
We are
a great opportunity for all of us. I mean, for us in Sun Pharma, and thank you very much for the opportunities. I mean, I feel that it's a great association with Dr. Satish and Dr. I mean, you and Dr. Paramita and other various specialists who come every session, and it's a great opportunity for us to be associated with all of you. Thanks from Sun Pharma.
Now, quickly, thank you, sir. Quickly, can you see the common carotid now?
Yeah.
Dividing into external and internal now?
Yes.
Can you see here?
Yes.
Now, see, this is the first branch from this. See, this is the first branch coming from external.
Yes.
Now, see, keep an eye on the branch. Keep an eye on the branch. Here it is going medially into the lingual. That is the lingual artery.
Yes.
Then this is another branch, very small branch staying here. See this. This is ascending pharyngeal.
Yes.
See, staying here. I am keeping an eye on this. Keeping an eye on this. Where my cursor is. Cursor is. I am going up, 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 up. No, this is thyroid. See, going in the thyroid.
Yes.
So this is superior thyroid branch. See, this is how you can trace. What I want to know, the vessels which are coming off to supply the tumor. Now, this is the third one. This is gone inside the tumor. See, another thing. This is the jugular vein and this is the common facial vein entering into the jugular. Okay? Big common facial. And this artery, now we have to go up, 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 up. This is the external carotid, carotid, carotid going. See, giving so many branches there. So many branches going behind. Now the most important, it gives a big branch behind. Can you see this where my cursor is?
Yes.
This is occipital artery and this is the main supply to the tumor. See this. This is the main supply to the tumor. And see, this is the main supply to the tumor going into the tumor. So we have from ascending pharyngeal and the occipital, there are two major branches, particularly the occipital going to the tumor. And what we'll do, when we expose the neck, we'll take control of that vessel. So first we'll go in the neck and take control of the vessel to devascularize to some extent. That is going to be our aim. Now, if we follow the carotid up, this is, the foramen lacerum, this is, the cavernous carotid. Going up, now dividing into anterior cerebral and middle cerebral. This is ACOM. And at this point, this is the PCOM joining to the posterior cerebral. So it is a good, cross circulation as well. Here's the opposite PCOM is your hypoplastic, but this side PCOM is good along with the ACOM. Clear?
Yes, sir.
So this is what the information we want from such tumors. That whether how the cross flow is, what are the vessels supplying, what is the extension of the tumor. This tumor is typically, see this occupying the jugular foramen, was going in the neck here little bit, and this is the medial wall of the jugular foramen, it is not going intracranial. See the posterior surface of the carotid artery, it is invading. That is the area where we have to separate from the carotid artery. This one. And this is a thin periosteum now, see, which is separating from the carotid artery. If you see, closely observe it. Can you see?
Yes, sir.
This is the thin periosteum which is separating. That's how this tumor is. So to me, it is a C2 tumor involving in relation to the vertical petrous carotid.
Yes, sir.
Does this patient has a dominant sigmoid on left side?
No,
dominant sigmoid on left side?
It is enlarged because of the tumor. It's not dominant.
Okay.
The opposite sigmoid is also good, normal. And see the opposite carotid, opposite sigmoid. But this is widened because of the tumor. See how big the tumor is. Now to confirm how vascular it is and confirm that it is paraganglioma, we have this T2-weighted imaging. And T2-weighted will show, see this, see the flow voids in the tumor.
Yeah.
Can you see the vessels in the tumor?
Yes.
See, so much a bunch of vessels is classical of a paraganglioma.
Salt and pepper.
There could be many lesions in the jugular foramen, could be schwannoma, meningioma, but this rules out everything. So radiology is, something which substantiates your diagnosis.
You can't take biopsy in all these skull-based lesions. You have to rely heavily on radiology, and this patient has a characteristic radiological features of a paraganglioma. So now, our tumor, is a C2 tumor invading the jugular foramen. Patient pre-op facial now is normal. And let's see now, in the last patient, if you remember, the facial was invaded.
Yes.
And since Professor Magnus was of opinion that if I could separate quite a bit of it from the this tumor from the nerve, I should preserve and be preserved.
Yes.
This should be uninvolved facial now, what I suppose. It's my prediction. And if it is, we'll show you a proper steps of transposition. Right from the bifurcation, beyond the bifurcation, the parotid to the first genu. The moment we lift the facial now out from that area, our jugular foramen is right in front of us, medial to the tympanic bone. The moment we remove the tympanic bone, the neck and the temporal bone becomes one unit. Start okay? And then we can remove the tumor thoroughly. Any question, Narayan? Anything at this point of time? Apparav?
Yeah, I think you've explained it very well, so there's nothing.
Satish, just tell them the signs, symptoms with which the patient presented to you.
This patient has a pulsatile tinnitus and hearing loss. He has a mixed hearing loss that gives me a suspicion of involvement of the cochlea. Let me tell you. Even the last patient had involvement of the cochlea. Now see, on T2 weighted MRI. See this cochlea? Hello?
Yes, sir.
See this cochlea on this side and this tumor. It looks like this tumor is going towards the intra-auditory meatus. See, this is intra-auditory meatus?
Yes, sir.
It is rising high up towards the CP angle, towards the intra-auditory meatus, and probably it is involving the cochlea as well. I am not very sure. Let's see intraoperatively because this MRI is not very good.
CT bony windows?
Hearing loss?
Pardon?
Bony windows on CT, yeah. Yeah. These bits possible.
Yeah. So here, see this tumor component going in the extra-auditory canal.
Yeah.
The entire middle ear.
Yes.
Yeah, boss, even the posterior cranial fossa
See this,
bone
this is the
not there.
cochlea.
Yeah.
This is the cochlea, and see this tumor in close proximity to the cochlea. See this here.
Yes, sir.
Maybe invading the bone of the cochlea. Most of the time it invades in such tumors. And you have to drill away. In last case, if you remember, I drilled away the part of the cochlea to remove the tumor because that is one of the regions of the so-called recurrence once the tumor invades the deep bone. And that bone, if you don't remove it thoroughly, radically, it is bound to come back.
How is the internal artery canal, Satish?
Yeah, it is good, but tumor is in close proximity. See this. See this tumor? See this tumor? Rising high up to the intra-auditory meatus. See this?
Yes.
Though it is separate, it is not invading. Can you see?
So boss, does this mean that it is involving the medial wall of the jugular foramen?
Yes, up to the medial wall. See the medial wall of the jugular bulb here.
Yes.
See, it is limiting the tumor to the intracranial spread. It is not intracranial at all. But reaching up to the medial wall, and I believe looking at this condition, we should be able to separate it from the underlying nerves. Our goal is to preserve the facial nerve. You know, after transposition, there has to be some sort of weakness. But that is going to improve if the transposition is done with minimal traction, number one. Number two, the preservation of the lower cranial nerves. We have to have utmost care at that point of time when we separate the tumor from the medial wall of the jugular bulb. And there we have to keep our cautery away. We have to keep that, we have to leave that medial wall intact. And if the tumor is not invading the medial wall, that automatically separates the tumor from the medial wall. So that is
Satish,
yes?
This CT scan shows the pre-sigmoid bone is gone.
Yeah, bro. Absolutely.
The tumor is sitting on the dura or is infiltrating the dura. Do a MRI to show them better.
Here, this dura.
Plate, they show them MRI.
This dura. That is the medial wall of the jugular bulb, sir. This is the medial wall of the jugular bulb. Sigmoid sinus is here, sir.
Lower down will be medial wall. This is a medial wall. Yes.
Sir, sir, let me show. This is the sigmoid sinus, number one. It is far off from the tumor. Tumor has nothing to do with the sigmoid sinus. It is miles away from the sigmoid sinus here. These are the mastoid hair cells. Now see, if I am going from right all the way, from below up, see there, the sigmoid sinus is completely separated from the tumor. No way.
It is not sigmoid. It is a pre-sigmoid dural plate. Dura is tumor is sitting on pre-sigmoid dura.
Yeah, this is pre-sigmoid dura, sir. This is pre-sigmoid dura. It is intact. That is in the mastoid. It is absolutely intact. This tumor is not extending into the mastoid. Where is the tumor in the mastoid? There is no tumor in the mastoid.
Mastoid, yeah.
Pre-sigmoid area is in the mastoid. Pre-sigmoid.
Pre-sigmoid dural plate is gone.
I don't see here.
What you said, transdependency approach, जो अभी बता रहा था ना.
So that is what
sigmoid sinus, your pre-sigmoid plate, that is gone.
Sir, now that's what I am trying to show you. You see here, this is the sigmoid sinus and this is the pre-sigmoid plate. It is absolutely intact. It has nothing to do with the tumor.
The medial wall of the jugular foramen is involved.
This is the medial wall of the jugular foramen where the tumor is going.
That is involved.
Yes, the pre-sigmoid plate is absolutely intact.
Yeah, so you plan to do cul-de-sac closure in this case?
Obviously, a complete subtotal petrojectomy.
Yes.
The infratemporal fossa A approach involves inherently the subtotal petrojectomy, blind sac closure, and then, facial nerve transposition, making the exposure of the jugular foramen widest. Then, while removing the tumor from the jugular foramen, you can add maneuvers according to the extent of the tumor. Like, I almost always, when the deep part of the jugular foramen is involved, I always add on the transcondylar approach to it to give access to the posterior-medial part of the jugular foramen. Because that gives me direct access to the posterior-medial part. So I can have a full control over there and can remove the tumor completely. So that is add-on at the time of tumor removal.
Okay. And so the pre-op hearing, what did you say? Pre-op hearing
Pre-op, the moderate mixed hearing loss. That's why I'm suspecting, the sensorineural hearing loss because of that, the cochlear involvement. The tumor you have seen is coming in the extra-auditory canal, occupying the entire middle ear. You see this?
Yes.
Movani sir?
The cranial functions are normal, boss. Right?
Movani sir? Hello?
Yeah, bolo.
See, this tumor is completely occupying the middle ear and going to the extra-auditory canal. I don't see.
Just pushing your
going
drum
up to the genu of the carotid.
How is the cochlea?
The genu is involved.
Pardon?
Cochlea?
Pardon?
How is the
This is pushing the drum. Okay, let Narayan talk.
cochlea?
What cochlea?
How is the cochlea?
Cochlea is here. See this.
Okay.
Cochlea is see here, and this part of the cochlea, this, this part and this part of the, towards the intra-auditory meatus, this tumor is ascending up. This is up. I am going down and see how superiorly the tumor has come to the, towards the intra-auditory meatus. And see inferiorly, this is jugular foramen. So I can show on the, on the reconstructed image. Here you see the superior relationship. Yeah, let me show you. This is the tumor. Now see, this is the jugular foramen. This is the jugular foramen.
Yes.
Now see very clear. Yeah. And, now see the tumor in the jugular foramen. Can you see?
Yes, sir.
And see how it is ascending to the, this is intra-auditory meatus. How this is ascending up towards the intra-auditory meatus. See this? Almost to that
The
level.
floor of intra-auditory meatus is gone, Satish.
It is not gone, sir, but it has eroded the inferior wall. Because we saw in one section that the intra-auditory meatus is intact. See this? But see this thin bone is intact. But it is almost approaching the intra-auditory meatus.
Now it's not intact.
Yeah, it is approaching. And now see the cochlea. This is the cochlea.
Yes,
See the
sir.
cochlea, this inferior. You know, this basal ton, this tumor is
Yes, sir.
approaching till the basal ton. So
Yes,
here
sir.
up to the intra-aortic meatus, here up to the basal ton, this tumor is going, and here it is coming towards the extra-aortic canal. What a wonderful picture in the coronal section.
Yeah, wonderful. Ultimate.
Now see the course of carotid in this section. This is the carotid artery going up, going up. See, this is a carotid artery.
Yeah.
And this is the cochlea, you can see. And this carotid artery is turning here. This is horizontal carotid. Horizontal carotid, this is foramen lacerum. And this is running as a, paraclival carotid. Is that clear?
Yes, sir. Very clear.
See this carotid, entire course of the carotid you can see.
Any history of vertigo, Satish?
Not really. Doesn't have vertigo. Surprisingly. Many of these patients do not present with vertigo.
Yeah, slow growing. No?
The compensation actually.
Yes. So vertigo is rarely a presenting symptom in these patients. Yeah, Paramita, we can quickly take questions before we go ahead.
So there are, right now you've answered all the questions, sir.
So,
What is the hearing status of this patient?
Mixed hearing loss was.
Mixed hearing.
So, Satish, was cases like this where the medial wall is involved, they have high chances of involvement of cranial nerves post-operatively. So, how do you counsel the patients?
Pardon? Yes, any question?
So, boss, cases like this where the medial wall is involved of the jugular bulb, there are high chances of cranial nerve involvement post-operatively also.
Almost.
So, how do you counsel these patients?
You have to counsel them for many things. Number one, the carotid artery injury. Number two, the facial nerve paresis or palsy. Because in up to 10% of the patients, 5 to 10%, in spite of a normal functioning facial nerve, you may find the nerve involved and you may have to sacrifice it. Third is the lower cranial nerve palsies. Because all these things will require, they have implication and will require further management. Like lower cranial nerves, suppose, get paralyzed. In elderly, it's a disaster. In young patient, they can tolerate, and you may do some, further surgeries like cricopharyngeal myotomy and, thyroplasty and all that to improve the function, to prevent aspiration. For facial nerve, you may have to do some anastomosis later on, if you have not done that time. For carotid artery, you may have to take call of, reconstruction, stenting, so many things. So carotid injury is a disaster if you have not seen the pre-operatively the cross flow, and abrupt closure of the carotid artery can be a disaster. So all these things have to be counseled to all these patients. Fourthly, the hearing loss. This subtotal petrojectomy with blind sac closure inherently has a 60 dB hearing loss, along with whatever the sensory neural component is. And in case you have to drill out the cochlea, patient may have a profound hearing loss as well. So you have to have a consent of all this. If it remains only conductive, it can be, rehabilitated with the use of Baha later on. But if it is profound one and you have to drill out the cochlea, there is no way you can rehabilitate it further. So all these things are the part of, consent. Yes, sir.
Show them a vertical course of facial nerve and the relation of tumor. Vertical course of facial nerve and the relation of tumor.
Vertical course of the facial nerve and?
Relation of tumor to the vertical portion.
Yes, it is mostly affecting the vertical portion of the facial nerve.
So show them a CT scan now.
Sir, actually, this was a CT angiogram. We do not have a proper CT scan like we get a HRCT. But see this. This is the facial canal. Can you see?
Yes.
And see medial to that, immediately medial to that is tumor.
Tumor is there.
Laterally the facial canal, medial is the tumor. Let me come to the, reconstruct it from the axial. Because this is CT angiogram, this is not high resolution CT scan for the temporal bone. But still we can have some information. Now, I will show this, the same thing which I had shown you just now.
You do tracheostomy in these cases, preoperatively, prophylactically?
No, not really. Why?
No.
See,
No.
this is the facial canal in this, and this is the facial canal in the axial section here. That is the facial canal in the axial section here. And this is how you can, let me reconstruct again, because you can, yeah, this is facial canal in the vertical segment here, this one. And
Let me tell them what is the importance of this. See, when patient comes to you.
Here it is the facial now, and immediately that medial to that is the tumor. That is what I wanted to say here.
Yes.
This is the facial now, all the way, and this is where the tumor is. Immediately, I can see this is the facial canal. See, this is the stylomastoid foramen.
Yes, sir.
This one, and this is the facial now, and this is, you never know how, no wonder it is involved by the tumor as well. Let's see. Sometimes, remember sir, in your course, one patient had a facial now completely, engrossed in the tumor, and I could preserve subperiosteally the facial nerve, if you remember.
At Satish, we did one fashion on neuroma in your place I brought from Bombay. You remember?
Yes.
There was no fashion and patient and no clinical palsy or paresis at all.
And what was your diagnosis? What was your diagnosis? Paraganglioma.
No, not mine. Prasad. Prasad diagnosis and Vijendra's diagnosis. Your and my diagnosis was fashion on neuroma.
That can happen because all these lesions look like same. If you focus on the MRI, if you focus on the MRI, you can clearly differentiate.
See, when the tumor is away from facial nerve, and the patient wants to wait for 3 to 4 months, let's say he's got exam to appear, uski ladke ki shaadi hai, XYZ. If the tumor is away from facial nerve, I don't mind waiting. But if tumor is eroded the fallopian canal from underneath, I don't want to wait. I'll tell them there's a chance of facial nerve palsy, so get the surgery done. This is a clinical significance of this CT scan.
In facial nerve schwannoma, you can take all these chances because this is a benign tumor, slow growing. As long as the facial nerve is working well, let it be.
And we are talking about glomus. The relation of glomus to the fallopian canal.
Yeah.
Satish boss, can I ask one question?
Yes, please.
Sir, I think so you get washed and then we can discuss in the surgery.
Yes, Kapil, come with your question. Come.
Angiogram. Can we come to know that whether this tumor has a blood supply from middle meningeal artery in this patient?
In this patient,
yeah, on this
middle meningeal artery is nowhere in the scene, number one. Middle meningeal artery can supply this tumor if the tumor goes anterosuperiorly, more anterosuperiorly.
T3, T4 tumors.
Yes, in close proximity to the middle meningeal artery. Middle meningeal artery crosses the horizontal course of the carotid artery, horizontal portion of the carotid.
Yeah.
So the middle meningeal can come to supply if the tumor goes beyond crossing the horizontal carotid artery. Then
that
only.
Is C3, C4.
Yes.
Okay, boss.
So we are all set here. Because of the time, we have already, opened. And I will go directly to the neck. Bulleted.
Yes.
I will go directly to the neck and take the vessels in control first. Take the probable vessel supplying the tumor into control and then come for subtotal petrojectomy. Okay?
Yes, sir.
See this? What has been done?
So no we are not getting the microscopic picture.
Lagao bhai. Aur connect karo.
Okay. Yeah, we got it now, boss.
See what has been done? The cul-de-sac closure.
Yeah, we can see the sutured cartilage.
Yeah. We are about to show, but because of... Now see the tumor.
Tumor in the external artery canal.
Yeah. Can you see?
Yes.
Yes, boss.
And see carefully.
Big.
See carefully the pulsations. This is the tumor filling the external artery canal. Okay?
Yeah.
Now, the first thing I am going to do is to go to the neck. We have to go to the neck for many reasons. Number one, to take control of the neurovascular structures, identify them and follow them up. Number two, for the sampling of the lymph nodes in level 2, 3. And number three, for the continuation of the tumor which is going into the neck. See now, I am going in the neck.
Zoom out, please. Zoom out a little bit.
थोड़ा extension देता ना यार इसको.
Zoom out.
Boss, this is, the minimum zoom.
Okay, got it. समझ गया.
आजा राजा.
Boss, anything different in the post-auricular incision and flap raising than the other
Yeah, nothing. Little extended retroauricular, because we have to go, do a subtotal petrojectomy, and we have to expose the sigmoid sinus completely for the
Tell
closer.
them how far join the post-operative group.
Pardon?
A little behind. How far it is? Where is the incision? How far behind?
Incision.
Explain that.
Incision. You can say a rule of inch. See this. 1 inch behind the retroauricular sulcus, 1 inch above, 1 inch below.
Okay, boss.
Now this is your stenomastoid.
Superiorly raised periosteal flap in these cases?
No, this time I have not raised the periosteal flap.
Okay.
Now see, this is some vein. I am doing everything with the cautery. I told you I am so used to it. Right from the skin. We have seen the anatomy of this thing detail in the day when we did a supraomoid neck dissection.
Yes. Yes.
If you remember.
Yes, absolutely.
See this vessel. डिटेक्टर लगाना. Can you see something? Give me a retractor.
Post-auricular.
Can you see some vessel?
Yes.
Yeah, we can see the big bluish underline.
What did I tell you that day?
Boss, do you preserve greater auricular in this case?
Greater auricular, yes, you can preserve, but difficult in this because we have to transect the stenomastoid also at some point of time. You rakhna yaar yo. See, can you see these vessels?
Yes.
Hello or not?
Yes.
Hello?
Yes, sir. We can see.
I told you that day, if you remember the name. See these vessels. What are these? Chokers.
Yes, sir.
Remember?
Yes,
Okay,
sir.
yeah, so to identify the spinal accessory nerve.
See the spinal accessory there?
Yeah, boss.
Yes,
Yeah,
yes.
we can see that, yeah. Absolutely.
Forgot, Paramita?
Yes, sir. No.
This is how Devendra Chokar defined,
Yes.
published this. Right? You can easily identify, this is a routine protocol every day.
Amazing, boss. Straight away on spinal accessory. Beautiful.
Simplest way of identifying the spinal accessory.
And we can see the glimpse of IJ internal jugular below.
Yes, yes. See now it is crossing laterally.
Yeah, it's crossing laterally,
most of the time.
Yeah, boss.
And this is your
internal jugular, yeah.
And this is your digastric above.
Okay.
See this?
Yes.
This is your stenomastoid. You have to separate all these, ultimately.
Yeah, boss.
See this?
Even digastric also, yeah.
Yes, yes, I will. Why to waste time? Hey, kya kar raha hai? See this vessel? What is that?
Facial? Is
Oh
it
no,
facial?
immediately medial to that is occipital, man.
Okay, yeah, the vessel is occipital, yeah. I mean,
Immediately medial to the digastric muscle is what? Occipital artery. See, that's the main vessel. See this?
Yeah.
See the big one.
So even the occipital artery supplies this
Yes,
tumor.
even occipital is one of the main vessel.
Yeah. Occipital and ascending pharyngeal. Right?
Yes, see, take this. This was our goal. See this?
Yes.
Please pardon me if I am going little fast. Yeah?
Super fast, boss, not fast.
Because this is my routine, the way I use the cautery. Yes, chal sir, kar. Idhar. Okay, so that is our, the spinal accessory and the relationship with the yes, leave it. See this?
Yes.
Okay. Now, coming. See, these are certain lymph nodes if you see carefully.
Yes, yes.
This is level 2B.
Yeah.
I am just taking for the sampling,
This always comes as a hyperactive.
See, these tumors, sometimes they are considered malignant, not on the basis of histology, on the basis of
centralized, boss.
on the basis of metastasis. There are no histological criteria to define them malignant.
Yes.
That's why I'm taking these lymph nodes for sampling,
Yes.
See this splenius capitis muscle down?
Yes.
Yes.
So level 2 and 3, both.
Level 2B.
This is level 2B. So ideally you have to do a block dissection of level 2-3.
2, 3, that is okay.
Just to rule out any malignancy. Metastasis is the evidence of malignancy, not histology.
In all paragangliomas, now boss, you told this even in carotid body tumor.
Yes.
Yes.
Everywhere. Anyway, now, that is the jugular. Come fast. Slow. Gentle. You कर इसको रिट्रैक्ट करना. See, this is the jugular, and see what vein is this? Anybody I mentioned? What vein is this? I showed on CT angiogram.
Common facial vein, boss?
Yes.
Yeah.
There's a huge abnormal vein anteriorly. Now see this vein?
Yeah, that is anterior one is common facial.
Yes.
It's a big one, boss. Yeah.
Yeah, we could notice on CT angiogram.
So why is this so big, boss?
The venous anatomy is variable, boss.
Okay.
Venous anatomy is always so variable as compared to the arterial. And now I can see the glimpse of the carotid artery.
Yes.
क्यों फोड़ रहा है इसको?
Satish?
Yes, sir.
For glomus jugulare, this vein looks too prominent.
Pardon?
For glomus jugulare,
Yeah.
the vein should be partly collapsed because of no circulation being raised. This looks very prominent.
Yes.
Forget about your common facial. Even jugular vein looks prominent.
Yeah.
Sir, even the sigmoid sinus was little bigger on this side.
You see what I'm
No,
taking
but
now? See what I'm taking now? These lymph nodes.
Was centralized.
Yeah, these lymph nodes at level 2. Can you see this?
Yes, boss.
Clear?
they almost always come negative. They always come negative practically.
Yes, see this. Yeah, provided there is no malignancy and it's not common.
Unless they've been given radiotherapy.
So, radiotherapy can turn these tumors into malignant, boss. Sir.
I seen 3 cases.
Pakad. Pardon? Radiotherapy?
Can radiotherapy turn these tumors into malignant ones, sir?
Yes. Even the acoustic.
I give the names of doctor. One was patient of Dr. Vikas Kakkar from Rohtak. One was patient of Preetham Arora from Panipat. One boy was given radiotherapy thrice.
Wait.
And then
Section. Okay, what happened to that?
malignancy.
Oh.
This is Vikas Kakkar from Rohtak. He's a professor in
No, it is here.
His known
Leave it. Yes.
Common facial vein only, na boss?
Yes, some abnormal vein there. Yeah, a lot of venous,
Yeah, this patient has too much of venous engorgement.
Yes. इसको भी ले ले. Yes. Now. So, like it fast. See, all these are abnormal veins. Now my next goal is to see the cranial nerves and the carotid artery.
Yeah, boss.
Quickly.
Taking control of both common and external carotid.
Yes. See the carotid artery here.
Yes.
See the carotid?
Yes, boss. That's common carotid. Right?
Yes, that's a fork.
It's a fork. Okay.
That's a carotid fork you can see.
Yeah, boss. Right. Clear. So that is most likely external.
Let's see. Unless you don't see the 2 branches, you cannot say. Not 1 branch. Always look for 2 branches.
Right, boss.
No. Guru. That is hypoglossal, man. What are you doing? See that hypoglossal crossing?
We can see. Very good. Fine.
Coagulate.
Today Rajiv has done a good, wonderful case. Rajiv?
Yeah, boss. It was a pituitary. I did a pituitary today in which the normal pituitary was completely compressed anteriorly.
Yeah.
And the tumor was lying posterior to the normal pituitary.
Super. Super, Rajiv. Now see the hypoglossal going.
Yeah.
Bada retractor. The big one. Yes. Now, now see the external carotid and the branches. See this?
Yeah, we can see 1 branch, boss.
Yeah, this is the internal going behind here.
Yeah.
And deeper. Can you see?
Yes.
Crossed by the, that is, see the internal below.
Yes.
Here it is.
Yes, boss. Absolutely.
Choda.
So we remember, boss, how you preserved hypoglossal in carotid body tumors.
Yeah, that is important. Hypoglossal is important.
Yeah, boss.
See, we have to expose this carotid right up to the, the carotid foramen. And then we have to go up beyond that.
Please center, make it center.
Yes.
Okay, thank you.
Bipolar. Hope the picture is good.
Yes.
See these abnormal veins. Now this is hypoglossal, and these are the branches of the carotid.
Yeah, boss.
And one of them, which is ascending high up, now see what it is, non-tooth. This external carotid here rises in the parotid, up in the parotid, This is hypoglossal.
So we can't see ANSA in this case, boss, from hypo.
ANSA was in the sheath, far laterally.
Okay.
I can show lower down. Now, having seen the carotid and the... Can you see this now?
Vegas, boss, right?
Yes. So, 10th, 11th, 12th. Can you see all?
Yes.
Internal and external carotid.
Yeah.
And see, this was the, we have already ligated that. That is occipital. See, such a huge occipital. Hata. See, such a huge occipital.
Yes.
And that was giving supply to the
Which is this branch, boss?
Occipital. Always see a posterior branch at the level of the hypoglossal is occipital.
Occipital is a branch of what? Vertebral artery?
Oh, come on. External carotid.
Okay, boss.
And this is how our aim is to devascularize the tumor.
I think the marks will be cut. You get.
Okay.
Sending for engine.
Good. See this. Now this goes behind to ascend towards the parotid. We know the external carotid artery passes through the deep part of the parotid gland. Can you see this?
Yes.
Okay.
Yeah.
Now, bipolar. Find out. Yes. Make it. Leave it. See, this is external carotid.
Yes.
This is going to be the anterior branches, one by one. See this?
Yes, boss.
Facial, maybe thyroid.
Yes. So leave them, and one branch many a times goes from behind. Let us see if there in the place. See this?
Yes. Could you see the ascending pharyngeal now?
Yes, boss.
It is. See this.
Yes, yes, very clear,
Yes,
boss.
sir.
See now? This
Yes,
is
yes.
arising from this external carotid here. And this is how this vessel supplies the. See this?
Yeah, yeah.
It is a deep branch. I will just coagulate and leave it. I am not cutting it, you know. See this? Just coagulating and leaving it. So the
Intraoperative embolization, boss.
yes. That's why I've come to the tumor first, this neck first, and then tumor. So we have seen all the vessels. We can always take a control of the vessel whenever we want. See this?
Yeah.
Yes, sir.
That is the vagus. Yes. And that is how artery. My internal carotid, when I come to the, tumor removal, my internal carotid should be visible. See this?
Yes, boss.
Going high up towards the carotid foramen. So this part of the, this section is very, very important. Cut.
Satish?
Yes. Cut.
Center the picture.
Pardon?
Narayan, I think I'm going to say a big thank you to you for your wonderful demonstration and take your leave for today. I've got another very early surgery tomorrow.
You came late and you're going early.
Oh.
I was busy with surgeries today and tomorrow also.
Oh, great.
For coming late. Otherwise, I never miss
Great, Narayan.
Satish's
Thank you, man.
Satish, always a pleasure to see you operating. Get to learn too much seeing you and your
Nothing new for you. See the internal carotid.
Yes, sir.
Yes, boss.
High up in the neck. See this?
Thank you, Narayan.
We have seen internal carotid, we have seen external carotid,
Yes.
we have seen the jugular, and we have seen the cranial nerves, the lower cranial nerves.
Yes.
Thank you, Narayan.
Yeah, thank you, Rajiv. Thank you, Paromita.
Thank
Thank
you,
you.
sir.
Thank you, Narayan.
Yeah, thank you. Bye, Appa.
Bye.
Satish, thanks.
Thank you, Narayan. Thank you. Yeah, see the internal carotid.
Yeah.
That's the jugular.
Yeah.
That is the 11th which I have, separated. Okay?
Yes, sir.
Yes.
Oh. Anyway, we are going to ligate it. Okay?
Okay.
So this was all about the neck. Now I can move on to the subtotal petrosectomy part. And we all know section. We have to remove this entire canal. See this?
Yes.
We have to ensure that no skin is left above as we are doing closure. See this canal?
Yes.
What I am removing the canal skin quickly. The thick skin I am removing like this, quick. साफ कर. Now bipolar, pani. See, this is the tumor. तो बड़ा This is all in the exnotory canal. किधर से आ रहा है? See, this is all tumor.
Yes, yes.
I can bipolarize it. तो suggestion दे दो.
Is there any role of coagulation in this case, laryngeal probe?
I've never used coagulation for all this, but maybe useful. But see, here we need something robust.
Yeah. Yeah, especially over the facial nerve area.
Yes.
So your bipolar is at 40 now, boss?
Yes, now increased. Just now increased. Otherwise, I keep at 20.
Yeah.
So around dura, around sinus 20-25.
Yeah. In previous case, it must have been all around 20 or even less than that.
I am so happy about the facial now. These cystic tumors, you never know.
Thermal injury can be avoided with cold water also here in this case.
Pardon?
Thermal injury to the facial nerve can be avoided with cold water.
Yeah, irrigation.
Yeah.
Yeah, thermal injury anyway. We are nowhere close to the facial now.
No, not now, during it.
Now see the lateral area, absolutely good.
Yes, boss.
Yes.
And we have to do a proper subtotal petrojectomy now. Excentrate everything and remove the tumor. See this. See, this is the mastoid tip.
Yes.
Which I am going to completely remove it. In this surgery for that matter. Completely I will remove the existence. Suction kar. Na de. Bullet. Bada retractor. Paramita?
Yes, sir.
You can take questions meantime. Whenever you feel like.
So there's a question about consent, which we've already discussed about this patient.
One doctor, there is a Dr. Benek, what is difficult to pronounce, Benek Sekren Lotfi Bizlai from Algeria.
What is
He's
that?
Very big fan. He is very big fan of you. He is seeing all the webinars. Even now he is on. Are you in all 15 webinars?
From Algeria.
From Algeria? My God. अरे पानी डाल दो यार, तीन जने हो.
Name is very difficult. Ben Hussein Loft by Ziliali.
Wow. इधर रख ये नीचे.
It was not only we need to see your surgeries, even our assistants need to see your surgeries so that they'll learn how to assist.
Very important point.
Hey, muta de. So now I'll be using the robust cutting burr.
Yes, sir.
That is my favorite one.
Yeah.
See this?
Yeah.
This is the best burr.
Just for information, these burrs are much cheaper. The short burrs are cheaper than the long burrs. Okay, they cut very well, and they're much cheaper than the long burrs.
And you have a much better control.
Yeah.
Shorter
Lesser
the burr length.
point out, better the control you have.
Yes, बड़ा section, largest. पानी डाल, जम के पानी डाल.
If you look at the length of the burr out of the handpiece, it's hardly less than half a centimeter. This way you get a better control.
See, with this robust cutting burr, I will be able to do this in less than 10 minutes.
You always use a straight handpiece, I think.
Boss, bar is loose. Yeah.
You prefer to use a straight handpiece in all the cases. I have never seen you using very.
You know, contra angle I use if I have to use in the middle ear somewhere. Sometimes. पानी डालना है यार, बोन दस्त आ रही है. वो वाली देना बड़ी.
हो गया क्या?
बंद है. दूसरा दे. हाँ ये बड़ा रख. ये बड़ी दे. निकल. बिगर वन. निबलर रखना. In all skull-based surgery, whether it is endoscopic, microscopic, the hallmark is exposure, exposure, exposure. Your time, 90% time is, invested in exposure. Whatsoever the skull-based surgery is. Majority of time goes in exposure because all these are deep-seated lesions. And a good exposure is the key for the success, That's the sigmoid. You can see.
Yes, sir.
See the beauty of this burr. This is very, very safe, See the dural plate?
Yeah. Yes, boss.
Dural plate, sinus plate. And see what I was telling. The mastoid is absolutely free.
Yeah.
When was the CT was taken? Latest one?
Pardon?
CT scan was taken latest one or?
CT scan?
The latest one?
Yes, yes. See, this is the sinodural angle.
Yeah.
Ossicles are already destroyed.
What's Jagoma?
So not a very pneumatized mastoid. Small.
Average.
Yeah. The pre-sigmoid dura is not involved as you told on the.
I told you, pre-sigmoid has nothing to do with, disease. You see the entire pre-sigmoid region, you could see on CT scan. Section देना दूसरा. Wash. पानी डाल इधर. See, all these air cells have to go as you have to obliterate. Beauty of this burr is you have the best control. See, one burr point serves the entire purpose of the crude work. That too and faster. That is the tumor coming to the editors. This part you can really go faster. Bipolar.
What about the indication of gamma knife and Glomus?
Pardon?
What are the indications of gamma knife and Glomus jugularis?
Hello, can you speak a bit louder, please?
What are the indications of gamma knife here?
Gamma knife, like same for acoustic. Elderly people, growing tumor, that's it.
See, basic principle is you should give gamma knife for small tumors. Like we said, acoustic neuroma, less than 2 centimeters. Here also, when you doing a glomus for elderly people, you debulk the most of the tumor. If your tumor stuck on the vagus nerve, for example, leave it behind. That can be gamma knife. Do not give a gamma knife for big amount of tumor. Bigger amount of gamma knife can cause malignancy rather than small volume of the tumor. The volume has to be reduced tremendously for gamma knife anywhere.
Okay.
So,
Gamma
young
knife.
patient, it should be operated rather than gamma knife.
Gamma knife is not a cure. Gamma
Even
knife is
elderly
not a
patient.
cure.
No, yeah. Even elderly patient, as I said, you can do a radical job. Leave the tumor unless it's
Can you see the tumor? Can you see the tumor medial to the incus?
Yes, yes, boss, we can see it.
Now, bone nibbler रखना रे. I will take away this. Yeah.
Then what is the fallopian bridge technique?
Fallopian bridge technique is a, facial nerve preservation technique. If your tumor is not invading the carotid arteries so much, what you can do, rather than transposition, you keep a bridge intact. Work from here, deep to facial retrofacial, through the facial recess and through the canal, and go around the tumor to remove it, rather than transposing it. But that is not a good approach for extensive tumors like this.
For limited
C1 tumor, C1 tumor, or
See, once the carotid is involved, it is the exposure of the carotid is very important to prevent the injury, and in case happens to occur, to control the carotid. That cannot be controlled by such narrow approaches,
Okay.
Right. Now, this is the retrosigmoid, area I am exposing. See what a burr point it is. So we have taken the mastoid tip almost. I will completely remove it to remove the existence. See this part I have gone faster.
Because you have already cut the digastric, no?
Just from below.
Yeah, from below.
See, it is here. This is important to give me a good transcondylar access. My jugular foramen is here.
Yes, boss.
To have a full access of the jugular foramen posterior-medially, I will remove the jugular process of the occipital bone. See the complete exposure here.
Yeah, we can see the force of the sigmoid.
Yeah, much better now.
One.
See, what I suggest is the crude work you can do faster.
Yes, sir.
this work doesn't have too much of the bearing on the overall. You know. See the tumor. My God. Tumor is coming there.
Yes.
Facial prospects are not good.
Yeah, that's why I was telling you to show the vertical course. There was no bone under the vertical course of the fallopian canal.
Yes, there was no bone on CT scan.
Yes.
Yeah, bipolar day. फिर diamond day. See, majority of the bone work in this area is done.
Super fast, boss.
Yeah.
No, hold on. See the tumor.
Yes, yes. Totally gone.
I don't think we'll be able to.
Because of the facial.
Just see the situation.
I don't think that facial nerve periosteum will be involved, boss.
Let's see.
Intact.
No, it will be involved.
Yeah, it is not intact.
Yeah, it will be involved.
Diamond.
Satish?
Yes, sir.
The last case with Dr. Jack Benyon and me told you to
Yes.
preserve the facial nerve rather than exercise. How is
Yes.
the patient's facial nerve function?
He had that time before sending had a grade 4 facial.
Yes.
I have called him.
I think next week we'll show all the most of the we'll follow up the cases. Discuss how to follow up the cases. We'll try.
See the sigmoid sinus completely skeletonized. This is sinodural angle. See everywhere?
Yeah.
Do you have any experience about the somatostatin analogs therapeutic?
Yeah, these tumors they are known to contain, somatostatin receptors. A lot of work is going on the medical therapy, Imatinib is one which is also supposed to have an effect. Bevacizumab is another monoclonal antibody supposed to have an effect because of the vascular vascular endothelial growth factor receptor inhibitor.
Actually, these help to reduce the growth.
Yeah. Once these tumor have a receptor, so obviously they are going to suppress. But see, all this is still experimental. I mean, nothing is standard of care of treatment as a first line treatment.
Boss, the tumor is almost, you are at the vertical
Yeah, I
segment.
am right on the tumor.
Yeah.
And I told you the tumor is rising here.
He has to remove the complete tympanic plate anteriorly.
Yes,
He has
sir.
to remove the complete styloid process anteriorly.
Yeah.
He has to take away the posterior canal wall, thin out the anterior canal wall to expose the. As he said, you have to have good exposure. So good exposure involves anterior canal wall drilling, tympanic bone drilling. There should be no bone in between the neck and the temporal bone area. See, the complete bone has to be removed. Styloid process has to be removed.
See, this is all tumor.
Yes.
And this tumor is, here going towards the intraocular meatus,
Yes, boss. We saw it on the CT. Yeah, boss.
Gauge piece. Now, having done this, good. Now I will remove the canal wall. I don't see good prospects for the facial now again.
Yes. Doesn't look like.
See, wherever the tumor is, I am removing, cauterizing.
Yes.
Incus निकालेंगे. See, the field is good.
Yeah, boss. Can you zoom in, boss, here now?
Yes. See my exentration.
Yes.
Yes, yes.
This is the vario microscope which I am addicted to. Addicted to. The cutting medium size.
Is it the same which we have in our place?
Pardon?
Is it the same vario microscope which we have in our place?
Yeah, Agra. Yes, yes, boss, same.
Vario asset, boss, or which one this?
88.
Okay, yeah.
S88.
Yeah, boss. It's a very good microscope. Even I have the same S88.
Yeah, S88 is amazing, boss. Bipolar. देखो सर्जिकल है चल क्यों नहीं रही बोन देख देते हैं
Islam from Bangladesh. He's saying he's conveying his regard to you.
Good morning.
Satish?
Pardon?
Dr. Islam from Bangladesh. He's conveying his regard to you.
Oh, thank you.
So many places.
Yeah, these are very committed people. I have seen them.
Dr. C.S. Tengli is saying that it is fast and furious type of drilling sir is doing right now.
See the facial now. See how swollen it
See the
is.
horizontal segment, boss, right?
See how swollen it is. And see the tumor over it.
I think, is there any bone on the horizontal segment, boss?
I am not confirmed.
It doesn't look like.
I am not confirmed. I will see.
Dr. Satyaprakash Dubey sir has commented on you as super fast express, Satish.
Sir is on right now.
He's also asking about the role of post-op radiotherapy, sir.
Post-op radiotherapy is required when you have a tumor which you have left intentionally and done a subtotal resection and tumor is growing. Secondly, when you have tumor in the inoperable areas, inoperable areas where you cannot remove, like cavernous sinus, involving the intracranial vessels, involving the brain tissue, and then you can follow with the radiation. And sometimes you have removed a part of it, decompressed it, and if the tumor is showing growth, then you can use the radiation. See now? This is the facial now. This is descent. Can you see?
Yes, boss. Yes.
Zoom. Yes, sir.
Yes.
See now the tumor is behaving so well. Absolutely dry.
Yes.
Medium size diamond.
Boss, डर गया आपसे वो.
Hey, Appara, how are you, yeah?
Man, are you sleeping?
No, he is very active. Since the starting, he is very active and he is.
Appa.
I think.
He's glued to the screen.
Appa is one of my best friends,
Even for minutes, he is not out.
He is one of the most respectable person in my life.
No. Everything super fast.
See this? The supra perilabyrinthine cells, all these.
Yes.
The tumor is well under control here. See this. Now, give me cutting. See now, facial now will follow how it goes.
Yes.
We'll remove the canal wall and let's see.
That is Koda. Right?
Yeah.
Koda.
See the facial nerve proper.
Yes, yes.
Now see the facial nerve proper. Give me side circular.
Yes, we can see.
The bipolar देखो.
You can see that.
See, I can see the facial nerve.
Yes, sir.
Vertical segment coming into the picture. Let me.
Zoom zoom.
Huh?
Let the people see the facial nerve properly.
Yes, yes, I will show that, sir. Let me bipolarize it. This is all tumor tissue which is bleeding, you know.
The tumor is going in the eustachian tube.
Now see my facial nerve.
No, in the CT scan, it showed that it is just popping on the eustachian tube. It was not going down the.
Now see the true involvement of the nerve.
Yes, sir.
Yes.
Very clear.
Yes, sir.
Without any doubt, see the nerve is completely encased. See this?
Yes.
No doubt about it.
I will still preserve the nerve.
Pardon?
I will try and preserve the nerve.
No, sir. You have several times you have tried this, and every time I have seen. Ultimately, we have to resect. This I can see.
That should be a last choice to get rid of it.
Sir, it looks theoretically all good, but see, we have seen such now it's completely encased. It's not at one place.
If you leave negligible, you said about 10 minutes back, if there's a negligible amount of tumor in some important area, there's a role of gamma knife. We are not utilizing gamma knife as frequently as we should be, of course. So if you have a tumor hanging on the facial nerve, on the
tumor, if invading the facial nerve, invading the facial nerve in a young patient, there's no question of gamma knife, sir. You ask anybody in the world.
Good night, chalo, all of you. Bye.
See this? Completely encased, sir.
Yes.
There is no question. This is a complete, indication for the resection and anastomosis.
Yes.
No point. See this nerve involved.
Yes, sir.
See how the nerve is swollen. Had there been a slight involvement, I would leave it. But this is not slight, sir. This is complete engulfing the nerve.
It's completely encased.
Yes, completely means completely. See this?
Yes, sir.
Here it is. There is no distinction between nerve and the tumor.
Yes, sir.
I would definitely preserve it. See, the nerve fibers are truly invaded.
Yes, sir. So in the previous case, the previous case, the encasing was not.
So don't tell your patient that if you have a pre-op normal now, that means you always can preserve it.
Yes, sir.
I leave this stump.
Yes, sir.
Okay. Bipolar. There is no point.
For this, I think we need the sural nerve, at least.
Pardon?
So which nerve will you use now?
Yeah, we will anastomose with the nerve.
Sural, I think sural nerve.
Sural nerve is best.
Big segment.
Easy to harvest in no time, with hardly any morbidity. See all this tumor invading the medullary structures, you know.
Yes.
See the cochlea is invaded.
Yes,
what I told you, see the cochlea. Completely, drilled out by tumor.
Yes.
Let me show you the cochlear tuns. See the cochlear tuns itself.
Yes, sir.
See the inside of the cochlear tuns. See this?
Yes.
This is inside of the cochlear tuns.
Yes, sir.
See how dubious. So this is my stump of the facial now. Oh, cochlea is completely destroyed, man.
Yeah, even CT also shows.
Yeah, I could see the tumor reaching the cochlea, eroding a little bit lower part. See this completely, what a tumor it is.
Yes, sir.
But anyway, we will now give me the drill. See how this tumor is going here toward the intra-aortic meatus.
Yeah.
There is no prospect of hearing, no prospect of, and this is a young man.
Oh, 22 years, no, boss? Just?
Yes. So this massive tumor, you know. Here the only goal is to give him a cure. Because he has a huge life expectancy.
Yes, we have to
आगे
take
आगे
care
जल
of-
वो डाल दे सर्विस से वो साफ करना है यार. See, this tumor is invading the labyrinth here again.
Yes, yes.
You have to stay radical in young patient.
Yes.
छोड़ दे. Gauze please रख. Yes. छोड़ दे. अरे छोड़ के मत चल जाया करो यार. साफ कर. See, all this tumor coming from the jugular bulb area.
Bulb area? Okay.
पानी डालो. No, put a gauze please. Yes, no. See, in such areas you can pack like this and move on. Now we have seen it is massive. No chance of anything conservative.
Yes, sir.
पकड़ो इधर. बोन निबलर बंद है, ये ले लो. The rest of the mastoid process.
Yes.
Now I will drill away the tympanic bone. I will see the rest of the course of the facial now. Extra tympanic. काट देना इसका, काट दे.
But it's fine focusing we need.
Yes, yes. Give me the body wali bar. Look, इसको तो. Yes. This is the tympanic bone.
Yes, sir.
Medial to which is the jugular foramen. And this jugular foramen has a tendency to erode this bone to come out. Body देना. Retract. Somebody come with a retractor here.
Then the occipital bone looks also eroded, na? On CT was little bit.
Yes, that's why I will do that. That is part of my every case. To take the exposure of that area of the jugular foramen. See the area where I am drilling, medial to that is jugular foramen.
Yes, sir.
Yes, boss.
Now since the facial nerve is no prospects, so see that is the facial canal.
Yeah, that is stylomastoid.
Now entire tympanic bone is mobilized. Bipolar.
So Dr. Palaniappan from Tiruchirappalli wants to see cochlear aqueduct. Is it possible? No.
Cochlear aqueduct?
In this case.
Yeah.
Here we are not supposed to go to the cochlear aqueduct for any reason. Give me diamond.
So Dr. Palaniappan from Tiruchirappalli has been very active in all the webinars. Even before the session starts, he shares his queries, his discussion.
Found him so committed a person he is. Great boss. Hats off to you.
So is that we can see the periosteum over the facial nerve, right, boss?
Yeah, this is all invaded. See, this is the entire tympanic bone which is mobilized. See this tympanic bone?
Yes,
Yeah.
And medial to that is the jugular foramen. See, this is jugular foramen full of tumor.
Yes, sir.
Bipolar. That is jugular foramen full of tumor. See, this is, I am in the lateral wall of the jugular foramen.
Yes.
Gosh. See, this is how you can control. So this is not going to control so easily. Come under control. See that? Now I'm removing this bone completely to give it full access. Section.
It's a very thick bone.
Yes.
No, it's not.
Boss, had the facial nerve been intact, you would have first dissected the facial nerve.
I would have done the transposition.
This bone.
Yes. See this? I may be exposing the jugular foramen directly by doing this.
Yes, sir.
But still I would. That will result in little bit extra oozing also here. It doesn't matter. You know, this continues down as a styloid process.
Yes, boss.
Yes.
Bone nibbler.
So,
see that? Just come up fast, and this is your facial nerve.
Facial
stump.
you can see the styloid process also now.
Yes. Now see, I will quickly convert. This is styloid process.
Yes.
That's a great landmark. As long as you are lateral to the styloid, you are lateral to the great vessels.
Yeah.
That's an amazing landmark. Now see, this is your facial stump. staying lateral to it. See this?
Yes.
I can see the facial nerve ascending in the parotid.
Yes, yes.
And here I want to see and preserve so that I can do an anastomosis later.
Yes, sir.
Yes. See this facial nerve?
Yeah,
Yes. Yes.
Rising high. पकड़ो पकड़ो देखो. See the facial nerve. No, वो ले. Look at bipolar. See, I will go and dissect beyond the bifurcation. See the facial nerve?
Yes, sir.
See this, brother. See the facial nerve?
Yes.
That's the bifurcation. See this?
Yes, sir.
This is one of the branch.
This is going to the styloid, I think.
इनके गोद की सकते हैं आप कुछ नहीं कर रहे ना. And this is the stylomastoid vessel. So this is the entire course of the facial nerve now. Give me non-tooth and a good scissors. Non-tooth and a good scissors. See now, this facial nerve here. This is involved. See this?
Yes, yes, yes.
Yes.
You have to go distal.
So I will go more and more distal until I find the normal nerve. See this, here it is normal.
Yeah, just.
This is bifurcation.
Yeah.
See this. Oh, terita. Bipolar. Leave it. Now see the course of the facial nerve. And this I will keep here, put a stitch. So that in the end I can identify. Okay?
Yes, sir.
Yes, yes.
And anastomose with the proximal stump. So that this will not come in our way of tumor removal because we will do a lot of retraction here. पटक सूचर करते हैं. यस वहाँ ऊपर से हाँ यहाँ टिप से निकल गया. At this part of the facial now I am sacrificing the distal part. Just put a stitch suture. See this black suture?
Yeah.
थोड़ा लंबा काट.
Just for reminder.
Yes, to identify it. Yes, that's it. Okay, now let us communicate the ear and the neck. And then we'll close the sigmoid, close the internal ligate the acoustic patient is doing well, he is conscious, he has a, you can say grade 2 facial palsy right now, paresis.
Okay.
Paresis, that is certainly going to improve. But yeah, extubated. We always extubate at the same time. Yes, section. Now the most important thing, see my landmark what Rajiv had shown. Mentioned. See this styloid?
Yes.
Yeah.
As long as you stay lateral to the styloid, what a landmark, see this?
Yeah.
You are in the safest area.
Yes,
Yes, sir.
See this, Lily? just ले लेना. See this section.
Yes.
See the styloid. See the styloid.
Yes.
And now, see the external carotid ascending up.
Yes, yes, yes.
Just anterior to it.
Yeah, that will leave up. यहाँ लगा रहे.
Going into the parotid gland.
Yes, that will keep aside. See this?
Yeah, boss.
Out of our field. Now see the neck and the.
You can see the muscles attached to the styloid.
Yeah, the neck and the temporal bone has become one space. You know.
Yes.
See this now? Now. Now, monopolar. Now see my, on the lateral surface, what I see, the styloid. These are all muscles here. See this?
Yes.
Posterior to the jugular. See this? All muscles posterior to the jugular. See this?
Yes.
Yes.
The stump of the occipital. Either. Yes. See, I am elevating so that I can do a good transcondylar.
Make it center, Satish.
Yes.
Yeah.
See my jugular.
Boss, you identify the C1 transverse process at this stage?
Yes. If you are not supposed, you have to pocket. See the occipital, continuation of the occipital.
Yes, boss.
So I am leaving these muscles behind. See, I elevated. So now I am in the plane of the styloid. See this? What a landmark. As long as you are lateral to styloid, there is nothing important structure, you know.
Yes.
And now you have to elevate styloid and resect all the muscles along with it. Just stick to the bone, you know. See this? And all the muscles attached to it. See this? I will sacrifice this. That's it. So simple. And now is the time to look at the level of the great vessels. Artery. Okay. Now give me artery. Now see, we have our jugular here.
Yes, boss.
All this tissue lateral to the jugular. This is a thick sheath over here.
Yes.
See this?
Yes, sir.
I am, separating. See the jugular?
Yes.
See the jugular going?
Yes, boss.
And then...
Satish, boss, where is the exact location of the jugulocarotid crest bone?
This is eroded here. It is here in between.
Here, right here, boss.
Here, see the carotid now?
Yeah, we can see, boss.
Now I will remove the things lateral to it. Mop. Section रख दे हटा ना section रख देखो कहाँ खुल गया. Now see how the carotid, as it enters the temporal bone, it turns so medial. Section रखना यार. Yes. Keep it. Honor the bleeding. See how it goes medial.
Yes,
Yes.
boss.
See, I'm exposing more and more carotid. Hope you are oriented.
Yes, sir.
See, this is the jugular bulb region. अरे देखने देना यार. जब मर्जी. See now, this is my carotid. See this?
Yes, sir.
It is entering the petrous bone. Cut. Yeah.
Boss,
Yeah.
can you show the location of the vagus here now?
अभी दिखाता हूँ. Deeper, deeper, deeper. All the nerves are now deeper.
Okay.
Suction करना है.
The medial side of the carotid.
No, I don't see that. पता है क्या? I will show you. See this. This is carotid.
Yes, boss.
See my vagus.
Yeah, right.
Yes, sir.
Deeper.
Yes.
Don't bother.
Yes.
All important nerves are deeper. See, I am removing all this to show my carotid very, very clear. See this?
Yes, sir.
Now this is becoming the petrous carotid, you know. Sort of. Got it. Got it. पकड़ ना. See, one assistant job is to just keep pouring water all the time. See just. See the thick carotid sheath. See this?
Yes, sir.
Now it is entering the petrous bone.
Petrous temporal bone, yeah.
See this? That was a thick sheath over it. Oh my God. And this is the part of the. So now, see, above is the temporal bone here, and this is the neck, and it has become one compartment. अरे रुक रही है. Gentle, no?
दो नंबर दे सकते हैं.
Dr. Pankaj Gupta sir is saying you just can't sleep without extubating the patient and seeing the post-operative status.
Yes, ideally it should be like that. Unless there is some major issue.
Yeah.
See, different practice parameters, you know.
Dr. Suresh Babu from Riyadh writes to you that, dear Satish, I was from PGI Chandigarh and now the director of lateral skull base surgery at King Faisal Specialist Hospital at Riyadh.
Oh,
I really enjoyed all your surgeries and watched all your webinars, and I made all my residents watch your videos. Thank you for your good work.
पकड़ना. Thank you. See, you have to be fast, quick. Yes. Can you see the course further?
Yes, boss. Is
That is the carotid. See this.
yeah.
And
Is it
here,
the tumor over the sheath now?
I am not sure. See, here is the tumor. See where? I am anterior to the carotid here. See this?
Yes.
This is all tumor here. And carotid is there. Where? See, all the way behind. Anterior. See what I am trying to say. Artery. See, this is the carotid going all the way.
Yes, boss. Yes.
See deep to this, where my artery is.
Yes, yes, boss.
And see the tumor is all behind it.
All posterior to it, you mean to say?
Yes, that's what we saw on CT scan.
Yes, yes, boss. Yeah.
And I open this entire sheath. Now see, the tumor is, separated. The carotid, lateral part of the carotid is absolutely free. See this?
Yes, sir.
Now this posterior part of the carotid, here it is attached with the tumor,
Yes.
Posterior.
Posterior to carotid. See this entire thing?
Yes, boss.
This is the tumor, which you have to separate from carotid, Scissors, See this? Okay.
Oh.
Oi.
See this?
You're going.
See this? See the vessel left anteriorly.
Yes, yes, yes.
See this? Entire tumor is behind. That was a very close move.
Yeah, boss. Right. Our heart started beating faster when you were doing
And
that.
see, and this is the area where sharp dissection is safest. Yeah. See this carotid? Now it is absolutely anterior. See this is going anterior.
Still attached posteriorly, boss.
This is the bone, the not bone nibbler or something. See the carotid is going in this bone. This bone. See this? See the further normal periosteum over the carotid. See this?
Yes, yes.
And see this bone, this is affected. This bone is affected. See that? So now my carotid is very safe, quite anteriorly. And what we need to do is remove this tumor from behind. So my final part is tumor removal and quickly, and then we'll be free. So what I'll do first, I will do a, this extraluminal closure of the sigmoid sinus. Okay?
Yes, boss.
There. Diamond.
So Dr. Krishna Kishore from Vishakhapatnam is asking, have you encountered a carotid spasm anytime in this kind of dissection?
Yeah, sometimes.
Tried to identify intraop and manage.
Yeah, you can see at that same time the patient having bradycardia, and you can see visibly the carotid going into spasm. And in that situation we use a topical, piperacin, xylocan, anesthetics, give some medicines, If you are alert, you can certainly avoid the problem. See, now I am making the window.
Boss, have you ever used stents in these cases where the carotid is extensively involved?
Stent never used. We have done bypass once.
Okay.
We use neuroradiologist services very often. Coiling, all that, but not that classical carotid stent which Mario Sana uses.
Yeah, those nitinol stents.
Yeah, Nitin, that is good.
Yeah.
See, I am making the window to extraluminally compress this sigmoid sinus. Fibrillar है? Fibrillar है क्या? Fibrillar.
फिब्रिलर नहीं है, वो लंबा है.
So, boss, how large window you make? I mean, approximate dimensions of the window you make for
one by 1 centimeter. Periosteum. See, less than the width of the sinus,
Yes.
So you can tuck your, material underneath the edges all around to keep it stabilized. If you make a wider window, it will not be stable.
Yes, boss.
Yes.
It's simple physics. See this? See, subperiosteally.
Yes. So have you encountered of any cases of multiple paraganglioma?
Yes, many a time.
Okay.
We have done combination surgeries together many a time. This.
So what you have? So what is to be done, sir?
Glomus jugular and the carotid body tumor same stage.
Yes, sir.
Glomus jugular and the vagal paraganglioma same stage.
Okay.
Bilateral carotid body we have done, but not at the same stage.
Okay.
Staging at a 1 week gap.
Okay.
Boss, in last week I did a mastoid in which I encountered a petrosquamous sinus. I sent you a
Yes,
picture.
I sent you immediately.
Yeah, that this is petrosquamous sinus.
Petrosquamous sinus is an anomaly I have seen couple of times.
Yeah.
So that is an abnormal vein connecting the, transverse sinus to the anterior veins.
Yes, boss.
And it runs in the, in the roof of the petrous bone. So when you are doing atic work or mastoid, you may find a huge bleeding.
The same case, Rajiv, discussed on that day.
The same case I showed.
See, so, I am pushing it all around beyond the window. Beyond the window. Otherwise, you can, make incision, decompress on both sides, make the incision on the dura, a small one, and take a suture.
Take the sinus, yeah.
But why to do all that once you can do the same thing? See our final, we are reaching to the final stage of tumor removal. So far, the entire, time and energy was given to the exposure. One thing for all skull-based ENT surgeons, the carotid artery. Everywhere you are doing endoscopic, you are doing, neck surgery, you are doing oral cavity surgery, oropharynx, neck, ear, everywhere.
You will put one more piece, boss?
No, a small one so that I can give a pressure with the bone wax.
Okay.
I want little out to keep a constant pressure. Now see, this is pure extraluminal. No question of giving any complication.
Yeah.
Now see, little high up. Give me bone wax. And now we'll put a complete seal over it to immobilize it, you know. Fine. This will never open up. Okay?
Yes.
Amazing, bro.
Now, coming to the neck. Quick. Yeah. Non-tooth. See now, a retractor laga aage. Retractor. Yes. See here, the accessory.
Yes.
Yes, sir.
You have to get this now. Like this.
Okay. So ligate here, right?
So now the accessory is left medial to it.
Yes, boss.
See, all these nerves go medial to the medial wall.
Yes.
इसको बांध दे इसको. This lower end is important to prevent air embolism. चल जल्दी कर बातें.
One more.
जल्दी कर. कोई राखी बांध रहे क्या? चल. See this end?
Yes, boss.
Yes, for twice.
I will just simple coagulate it. See the coagulation of the internal jugular. Now, this is all tumor. Now, before giving access, start removing the tumor. Now we have all things set to remove the tumors. Number one, the carotid is dissected anteriorly.
Yes.
Jugular valve is closed.
Boss, will you put a temporary clip on the external carotid here now?
Not needed, boss. See, don't get, frightened with the bleeding. Little bit you have to get used to.
Okay.
See this tumor going towards the intra-aortic meatus. Give me centralize. See this?
Yes, boss.
Bipolar. See, invading the bone here. Invading the bone here of the Peter's bone.
Yes, sir.
Skull-based surgeries are long-hour surgeries, lot of morbidity, mortality, teamwork, unpredictable results, so many things. I'm cutting there. That's why a lot of people are not opting it. Now what I was saying, बढ़ा दे. इससे बढ़िया. दे. See now I am removing this jugular process of the occipital bone. See my jugular foramen is here.
Yes, sir.
To get the posterior medial exposure here of the complete foramen, I need to remove this bone. See this? My vertebral artery is 1 centimeter, see, from this lower edge of the mastoid bone. 1 centimeter below and 1 centimeter deep is the safe area. Below that, if you go, see, this is the transfer process, cervical process,
Yes, boss.
1 centimeter below and 1 centimeter deep, you are safe. That is your safe limit. Beyond that, you are not. See the jugular foramen from behind.
Yes, sir.
I'm exposing it to make my life easy. See this?
Yes.
From behind.
Also, there have been few papers on this fibrin sealant injection, which is used to reduce the
Yeah, to
venous
reduce the
bleeding.
bleeding. They may work to some extent, lot of publication. We never used it.
Okay.
The, see this tumor in the foramen?
Yeah, going deep, very deep.
See this tumor?
So here, is there any bone between the posterior fossa dura and the tumor there?
Posterior fossa tumor dura and the tumor.
Yeah. Just
That
lateral.
yeah. So far is the bone. Diamond there. ये थोड़ा सा और कर लो.
Yeah, here, boss, here.
There is bone. See, the entire labyrinth is invaded, boss. What to say? See this?
Totally gone.
You cannot see the tumor. See this tumor inside. What to say? Black diamond. And cutting वो दे bipolar जब तक. See this. I am so grateful to our team who has always been, diamond.
100% appreciate your staff, team, everybody.
Dedicated people,
Always. See this? Bipolar. See this tumor?
Yeah.
Oh my God.
Yeah, it's going in the
Gauge piece.
It was going in the vestibule, no, boss?
Yes.
Vestibule interacoustic meters.
See, I will go to the medial wall of the jugular foramen. I will remove everywhere around the tumor. This tumor can go to the intracranial space, posterior fossa dura, intraartery meatus, everywhere, and you should be able to track and remove it. Yeah, हटा उसको, बहुत को हटा दो. हटा उसको.
But Satish was nowhere in the classification is internal auditory meatus mentioned.
Yeah, that area is CP angle. That is considered, intracranial.
So this is VE extradural.
See, this is where the sigmoid sinus is opening in the jugular bulb. And medially, there was a vessel here behind. That is the condylar vein. See this?
Yes, sir.
Shoulder. Yes. See my intraartery meatus dura?
Yes.
See, this was going up to the dura.
Yes, sir.
Not going inside the meatus.
The tumor has already made the superior and inferior trough, boss.
And this is important, condylar vein.
Yeah, for the collateral circulation, no, boss?
Yes, that's important. Which now we have blocked. बहुत रख दो, बस थोड़ा बड़ा रखो, बहुत रख दो, इधर भी रखेगा. Now we'll start, mobilizing the tumor.
Congestion of Kurdi cell must be in kilos at your place, I think. Must be buying in kilo, 2 kg, 5
I can
kg.
see 5 hands working there, boss.
So many surgery cells been used so far. And
Yes.
1, 2, 3, 4, yes,
Tooth,
4 hands.
tooth for
5 hands. There were 5 hands working
forceps.
at the time.
7 is holding
Full section
section.
लगाओ.
Yeah.
The 4 instruments we can see, and the 5th one is putting saline.
See, this is the tumor. This is the interior of the jugular bulb.
Yes, sir.
Which I'm now opening up. See this artery.
Can you, boss, orient again about the internal carotid here?
See this anteriorly. See this anteriorly. That's yes. See anteriorly. What a plane. That is for the superior anterior inferior petrosal sinus. अरे देना यार. पढ़ा दे यार. क्या देता है? No, ऐसे नहीं. देख के रुको. What? क्या पूछ रहा था?
Internal carotid artery.
Yeah, I will show. That is immediately anterior to it. Now see what I saw. ये retractor लगा. Leave it. See the carotid artery anteriorly?
Yes.
And see here what I did. I lifted the tumor from the anterior aspect. What is there below? The superior petrosal sinus openings. Inferior petrosal sinus opening. Show the. And that is expected here. Okay? Now I will start separating the tumor from all around. See this venous bleeding. See this huge venous bleeding. The bipolar. See this venous bleeding?
Yes, boss. And it is all from inferior petrosal.
Yeah. We'll control this. See the medial bone. Periosteum. Give me periosteum. Hata.
So now can we call this as near total petrosectomy?
See this. I am elevating this entire thing on the plane below. Can you see the dura below?
Yes.
Already involved, I think. Looks like involved.
Can you see the dura and the openings below?
Yes.
Yeah, I can see that, boss.
See very clear?
Very clear, yeah.
And this is the sinus opening which I can now even bipolarize. See the small openings. Yes, small surgery cell, because these are very close to the. See the medial wall intact. This is important to ensure that we are not damaging the lower cranial nerves. What's my point?
Yes, sir.
See, here we can't afford to push more and more.
But if we can see the dura, then how we can say that the medial wall is preserved?
This is medial wall. That is the medial wall of the bulb. No, sorry. See this. We'll show you again. See, this is the medial wall of the bulb.
Yeah, we can see now, boss. Right.
Now, once the medial wall is intact, see this? Beyond this, अरे क्यों दबा यूं? इधर की साइड यार यूं.
Medial
गधा
wall
है
or
क्या?
it is
यूं.
dura?
See
medial
this?
sinus wall.
Yeah, this is the medial wall. Medial to which is the posterior cranial fossa.
Has multiple openings.
So, when the medial wall is intact, your nerves are automatically preserved. See this? And see, this tumor is out.
Yes, sir.
See, out as one piece. Now this venous bleeding from the inferior petrosal sinus, God लगा दे सब जगह एक. God लगा दे गुरु. जो तुम कर लिया कर. ये God ले. जो ज़्यादा मत दबाना बस. Gentle, gentle, gentle. See this? I will show you the nerves later. One surgical here. Condylar vein behind. छोटे. See the condylar vein behind. Yes. छोड़ हटा. Not that much pressure. हटा छोड़ दे. Remove everything. Yes. If you press too hard here, we may end up damaging the glossopharyngeal also, which runs very close to the inferior petrosal sinus. Now, boss.
With pressure.
See now, this is the tumor. Hello.
Yes, sir.
Yes.
Yes, boss.
Out.
Very good.
Beautiful.
Now all cranial nerves are there, deep to that.
They were medial to this.
Yes. No. So
Dr.
This is-
Satish Dubes is asking, is there an
Oh,
issue of
he's
post-op?
still awake.
Yeah. He's asking,
Sir?
is there an issue of post-op vertigo? If yes, how to manage it?
Yeah,
I think Dr.
you see-
Ashim Kumar Banerjee is also asking the same question.
See, post-op vertigo can happen once you drill away the vestibule, but you see the kind of vestibular involvement must have given him already a good compensation. Otherwise, it improves on its own with time. See now,
So
my
any-
tumor removal is complete.
Yes, sir. Beautiful.
I will assess if there is some bone involvement, I will drill. See how deep I am again.
Yes, sir.
And what a massive tumor.
Yes.
Still very deep.
So today's both cases are extensive ones.
Yes.
ये साफ कर.
Sir, this patient had any lower cranial nerve deficit preoperative?
No, that is the worst part for the surgeon.
Yes, they have to.
Yeah, for the surgeon.
So Dr. Shripati is saying, can we now call this as near total petrosectomy?
Subtotal and near total. This is not a subtotal petrosectomy now or anything, because now diamond. Because now you have removed a part of the inner ear. See now this bone here, thoroughly,
Yes, sir.
until you get the normal bone. This is one of the major cause of so-called recurrence.
Yes.
Okay.
Infiltration of this bone. Like in JNA, infiltration of the pterygoid.
Pterygoid, yes.
See this complete clearance. Good cut off. Bipolar. See your carotid artery is here. Hello?
Yes, sir.
Yes, yes.
Your carotid is there. See there?
Yes, yes.
तो उधर सो रहा है. See this. My carotid is, let me show you again. See the course of the carotid all the way.
Yes.
And we are working medial to the carotid now.
Yeah.
See that? And this bone C should be absolutely perfect.
Okay.
So we had discussed last time about the radiotherapy. Now, today Dr. Naresh Jinder is asking about radiotherapy. Can you just tell us in short about
Medium
it?
side diamond. Radiotherapy only for, either primarily for the elderly patient, if the tumor is growing, they are under observation and the tumor starts growing. Or in the post-operative situation, if there is a planned subtotal resection, or patient has a tumor extending to the inoperable areas. Now see, this is petrous apex, I am drilling. This is medial to the carotid, See the bone?
Yes.
I told you until you get the normal bone. See now everywhere.
Yes.
Absolutely fantastic. See, no involvement. Agreed?
Yes, sir. No involvement.
Satish, orient with the eastern tube.
Yeah, boss. Can we see the cochlear area, boss?
Pardon?
Gone.
Cochlear area.
Cochlear drilled away.
Gone.
What do you mean to ask? I didn't get. Cochlea I have drilled away.
Okay, boss.
Eastern tube opening, Satish?
Eustachian tube opening is here far lateral, boss.
Okay.
Medial to Eustachian tube is the carotid here. See this.
Yeah.
And I am a centimeter and more than medial to it. See here.
Yeah.
See how deep I am.
Yeah.
Yes, sir. Very deep.
So now, see this only bleeding. Satish Jain.
Sal tumor.
See now.
Yeah.
These are inferior petrosal sinus openings,
Yes, sir.
See this? Best to see my medial wall here. Absolutely fine. See multiple openings there. See multiple holes.
Yes,
Yeah.
sir.
Typical of.
Look at this. Chota. और दे यस जेंटल अरे यार एक ही जगह पर दिए छोड़ना साफ कर छोड़ जल्दी मत हटा क्या करता है यार अब डालिया see this now just छोड़ दे बड़ा गोल दे leave it. See now this surgery cell I will keep. And we'll leave this gauge, press with this gauge for 5 minutes and this will stop. See this is about the jugular foramen clearance.
Yes.
This is all. See now, you can see the entire anatomy. This is the condylar vein. Yes. Now, okay. Just leave it for 5 minutes. It will stop. Surgical will take care. Now see the entire area. Right from the neck, bifurcation of the carotid till the tegmen. Can you see everywhere?
Yes, sir.
Yes, yes.
Absolutely dry. But just now, meantime, what we have to do is we have to obliterate and we have to do something to the facial. Hata. Hata. छोटा देना पेरियोस्ट वो नहीं elevator.
Sir, how do you prevent surgeons' neck pain and low back pain after such marathon surgical run? A very interesting question by Dr. Ashwin Banerjee.
Keep working. Not once in a while. See, this is my stump of the facial now.
Yes, sir.
Diamond, patli diamond. Patli, patli. So I will just clear this area around.
Sir, थोड़ा fine focus अगर हो सकता है.
Fine focus. Okay. So I'm just improving this stump. You know?
Yeah.
छोटा team elevator. Patla de. So now I will improve this stump of the facial now here. We'll harvest the sural now, harvest the graft. Graft is already harvested by a team here.
Sural na graft, na?
Thigh.
Okay, thigh.
See the facial now?
Yes, sir.
Little better now.
What is that, sir? Small one?
See this? Now this now is better beyond.
Yeah.
Yes, sir.
There's a knife there now. Give 11 number la naya. New 11 blade.
Sir, was it a branch?
Hello?
Was it a branch?
Yeah, looks like GSPN.
Yes.
GSPN.
Not sure. Bipolar. Pandal. No? See the area below.
Yes, sir.
Completely nowhere is the tumor. See this?
Yes.
11 number. See this? And what I am doing here, see this now was not looking good to me.
Stem will be too less small.
Yeah, see this?
Yes.
This is good now. Healthy now, I would say. This is at the level of the genu below. See, below is the genu.
Yes, sir.
And now it will give us a good nerve for anastomosis.
Is
Other
the
end we have in the parotid.
stump length good enough, boss, here?
Yeah, I will acquire the sural now, no?
Okay.
See, now till this level below here, I will create the bed with the तो glue भी बना लेना.
So with what fascia?
Pardon?
So with bed with
Fat.
fascia, fat. Okay.
Oh, चलो.
राइट में होती है कि लेफ्ट में सुरल
क्या?
राइट में होती है कि लेफ्ट में
वो
सुरल
दोनों सब ले लो, कहीं सब ले. लो, इधर गॉच पीस रखो.
Is it tumor? Is it?
Pardon?
What is this tissue?
Huh?
Is it tumor or something else?
Boss, I can't hear you. Two voices. What?
He's asking, is that a tumor?
No tumor at all. See? That was dural surface. See now, only surgicel, nothing else. See?
Yes.
Centralized, please.
Now give me a good gauge piece so I can place over here. What a mud. Yeah. See this? All set?
Yes.
We'll cover the cavity with the fat and then put a sural nerve guard and it will work very well. It will give us a good HB3. So let's go to sural now, quick. Change, लगाए नहीं क्या local? Prepare तो करो यार. Oh, यार, shit. सो रहा है क्या? अरे हटे यार. इधर. छोड़. इधर कर ले. यो कर ले. Yes. लो बेटाडीन लगा. या. Hello.
Yes, sir.
Yes.
The location for the sural now I had shown you in the cadaver. Between the lateral, malleolus and the tendon Achilles. इसको करवट दिला. No, ऐसे नहीं होगा. नहीं करवट दिला. Tilt कर दो टेबल में. करवट दिला. So this is going to be between the lateral malleolus and the tendon Achilles at the midpoint, just behind the saphenous vein. Short saphenous vein will find, and it is quite superficial. We can harvest any length we want, and we'll use fibrin glue for the anastomosis in the proximal part, and we'll put 1 or 2 stitches in the parotid part. Okay?
Okay, boss.
So I think how much? 6 centimeter roughly.
Pardon?
5 to 6 centimeter length.
More than that. We'll take generous segment because it should not fall short. And we have ample of space to lay down the nerve, even if it is longer. We can cut down, we can put a long segment, whatever. Microscope. इसको हटाओ. वो वाली चेयर ले गया. Yes. So let me show you. दूसरा वाला दो.
ग्लव देना, सर को ग्लव देना भैया.
So anybody, any questions, any suggestions about the Glomus, if they are doing anything different? Paramita, you have seen at Gruppo so many.
Sir. Sir, it's perfect.
See, this is the tendon Achilles.
Yes, yes.
This is lateral malleolus.
Yes,
Yes.
पूरा करवट दिलाना चाहिए था. The position should be, you know, this is exactly in the
midpoint.
अरे यार, बिना कहीं नहीं करना होता ना बेटा.
One little posterior.
Bipolar. Pedal. Pedal for the bipolar. So last part is this placing this nerve. Glue. Ready? And then a fat. See this?
Yeah.
देना यार. रुक. See, can you see the vein?
Yes, sir.
Yes.
This is the saphenous vein, you know.
Yeah.
Yes, sir.
Can you see the nerve?
Beautiful.
Can you see the nerve?
Yeah, very good.
Yes.
See, such a simple thing. And you can harvest as long as you want. Such people harvest endoscopically with a tendon stripper. Tendon stripper you can take from your orthopedic friends.
What is that, boss?
That is an instrument with a hollow inside. You just hold the tendon and pull it out. Something like that.
Okay.
See, such a superficial nerve. The dimension is also befitting. See this? And you can take as long as you want.
Same. Control.
See the full length of the nerve. If you want to go up, you can make step ladder incision and go as much as you want. Okay? But this is good enough for me. Give me non-tooth. This looks good enough for me. Here. इधर का retract पहले इधर का नरेश. This one. Retractor लगा. See this lower portion?
Yes.
Yeah.
This is one of the branch यार मेरे को शार्प सीजर चाहिए।
ये लो सीजर देने यार, कहाँ गया वो?
अरे रिट्रैक्टर मीन्स रिट्रैक्टर।
छोटा सीजर देना यार। ये
रिट्रैक्टर।
नरेश रिट्रैक्टर लगा यार। नरेश यहाँ लगा ना, रिट्रैक्टर कहाँ लगा रहा है?
यस।
ऐसे लगा, उठा के रखिए।
See this, I am just harboring extra length
Yes, sir.
by means of undermining the non-tooth. नहीं काट रही है। नहीं काट रही है, मान जाए करना।
नरेश रिट्रैक्टर ऊपर लिया यार।
गधा है वो तो। See this now?
Yes, yes.
So this Sunday, what all cases will you keep?
Pardon?
This Sunday, which cases will be there?
This?
Long list.
Sunday.
This Sunday are a lot of cases. We have variety of cases like you asked last time to keep a exteriorization, a classic example of exteriorization. Then we have seen carotid body and glomus and the JNS. So next time we'll keep a vagal paraganglioma to add on to variety.
Okay.
Then some more cases like, some variety of situation for the stapes.
DCR, just try to get DCR also.
Yeah, maybe some variety of situation for stapes.
Okay.
Some situations like I may keep a glomus tympanicum also because we have not kept yet. And some
Got any laryngeal papilloma? No.
Yes, I will keep the laryngeal papilloma also and some, a good parotid.
Okay.
I can keep a craniofacial resection, but these are all open. I am doing every day. I don't want to keep those are not the cases for mass demonstration. Okay, come fast, guys. चलो, एक उल्टा करके दे. Fast, चलो. Knife, give me a sharp knife. लो. भाई, fat ready? नरेश. हाँ? Good.
So will you cut the nerve obliquely?
Not really.
Okay.
Glue ready? Say this. Oh, fat here, tattoo. कहाँ गया? पकड़ना है. See this one end of the nerve?
Yes.
I will cut it sharp, And this is the other end. Hold it. And this is what length of the nerve is. Now we want. First, I will keep some fat in the bed of this. See, this is Surgicel.
Yes, sir.
Scissors. See, now I can minimize this. Scissors. See, I am minimizing this.
Very fine focus.
See, minimal Surgicel in the region of the condylar vein and
Boss, can we put bone wax in the region of condylar vein?
not really.
Okay.
See, venous bleeding is best controlled with a Surgicel.
Condylar vein is in what, boss? It's in a emissary vein or what?
See, in the jugular bulb,
Yeah, boss.
there are many openings which diverts the, the jugular flow coming through the sigmoid sinus. It passes through these veins to other sinuses like anterior and posterior condylar vein.
Yeah, boss.
That diverts the blood to the vertebral plexus.
Right, boss.
बोलो ये कहाँ है वो fat? So, like when you ligate the internal jugular in the neck, there is hardly any effect because the blood is diverted in majority by these condylar veins to the vertebral plexus and it doesn't affect the intracranial pressure there. यार.
No, boss, we have ligated the internal jugular blow. We have sigmoid sinus. We have obliterated. So where the blood will come to the emissary vein? From where the blood will come?
Where the blood will come to?
From where will the blood come to the condylar vein?
So if you are now.
Yeah,
Now there is no flow. That is retrograde flow. What you are seeing is a retrograde flow. What you are seeing.
Okay, boss.
Was a retrograde flow.
Okay.
Now see what I am doing. Making the area receptive for the grafting, Okay?
Yes.
रुक जा. इसको रिलीज कर. Give me sharpest scissor. Release this, the other stump of the facial. See, this is the other stump of the facial which we have marked.
Yes, boss.
See this. And see, I have already told, I will take this region only. See that?
Yes, boss.
Yes, sir.
And see this part of the facial now, this part of the facial now. Suture. Okay. Non-tooth. Non-tooth. कोई बात नहीं. This one end of the facial now will approximate this. See this? Other end will, will be suture to this. Can you see?
Yes, sir.
Yes.
Here. Like this. So I will put my, this thing, fibrin glue on the other side later. First I will make a stay suture to this nerve. You can see epineurium to epineurium. Can you see?
Yes, boss. Here.
This is 8-0.
Boss, you are using microvascular needle holder?
Yes. This is ophthalmic.
Okay.
इसको दादो को यहीं से काट दे और बीरबल दादा यहीं काट दे.
Yes.
बीरबल
Take this. काट दूंगा. Take this. Okay. क्या करता है?
काटना पड़ेगा सर, लंबा है वो, दिख नहीं रहा मुझे, ऊपर नहीं दिख रहा.
चल.
आपका हाथ थोड़ा अंदर.
Yeah. रुक जा.
खींचे जरा.
Keep the other end.
This is what 80 was or
80.
80. Yeah.
Give me. Cut.
Dr. Krishna is asking, can we drill a new fallopian canal for the nerve graft to sit nicely?
Can we drill a?
New fallopian canal for the nerve graft to sit nicely?
Not here. It's not, practical. Since we have a huge cavity, we can do it. Not today now. See, this side we will suture. Hello?
Yes.
Yes, sir.
Cut. Give me. One more. I will put at least 2 sutures, Hello?
Yes, sir.
So again, epineurium to epineurium.
Will you also put a fascia and then apply glue?
Okay, first suture on this side, then other side will approximate and put a glue.
You will use a fascia to wrap around it or no?
No, nothing.
Okay.
Satish, which glue you use? Baxter one or?
Yeah, the Baxter.
Baxter is still best.
Yeah, Baxter is best. Yeah. It solidifies very fast.
You can make both instant and,
Yeah. It has very good time. And what are the chances of recovery? Means how much you expect after 6 months or 1 year in this case? Satish?
Yeah, pardon?
How much you expect recovery in this case after 6 months?
How much
recovery means how much facial nerve recovery you expect?
It will take time because it is almost from here, 30 centimeters to the end plates. So it will take not less than
1 year.
9 to 10 months.
Till then, he has to carry on the physical exercise, physiotherapy also.
Yeah, but this will give a good spontaneous smile, boss.
Yes, sir.
This is the best result than any reanimation or anything.
What is the suture material, boss?
80 protein.
80 ethylone.
Ethylone.
Okay. 80 ethylone. Okay. So Dr. Satyaprakash Dubey is asking
this now. No, it's good one.
What is asking?
Dr. Satyaprakash Dubey sir is asking how much time will this take to heal? Like how much time will it take?
1 year.
1 year.
1 year. See now this is good.
Yes, sir.
Yeah.
The boss is watching till end, Because Dubey boss is still there.
I'm amazed to see this crazy man. I have very high respect for him. He's a wonderful human being. He's a wonderful, surgeon. He has been, see this end?
Yes, sir.
Now this is our bed for the other end. Like this. And then we'll put some more fat. Okay?
Okay.
So here now, give me the glue. That is the final part, and then we'll close it. Okay?
No more suturing here?
On this end?
Yeah, only glue? Only glue?
Glue. The results are same.
Yeah.
You have to keep the ends in approximation. See this?
Yeah.
Even single stitch will be more stable.
Sir, then fascia also wrapping around it, can that be more stable? Give that more
Yeah,
stable?
you can, but some people are against that. Some are doing. Because it may affect the time it acquires vascularity.
Okay.
Like Ashim was saying that day.
Okay.
Will a single stitch will help a lot?
Pardon?
Putting a single stitch.
No, it won't affect the, outcome.
But sometimes it will get displaced.
No, it cannot. Believe me. See this?
Yes.
Approximation?
Yes.
You see under magnification?
Yes, very good.
See that?
Yeah.
Yes, sir.
Good. Is the picture good?
Yes, sir. Very good.
And see the natural approximation of the facial nerve and the size and everything with the sural.
Yes, yes.
See now, this is completely fixed. I will put some additional glue here. See that?
Yeah.
And then I will put some glue at the other areas to fix the course of the facial nerve. See that?
Yes, sir.
That's it. Chode. Now we will leave it and put some glue, put some remaining fat in the cavity, and that's
Yes,
it.
sir.
Okay?
Yes, sir. Excellent demonstration.
Wonderful.
Thank you. Thank you. And finally, we can take questions if you have any or any suggestions.
In this case, like we didn't separately obliterated the eustachian tube. Only with the fat.
Yeah, that was drilled. I drilled that and pushed the fat.
Okay.
I drilled that area, if you remember.
Yeah.
If you want, I can keep in the coming webinars. See, these two cases you have seen. Both are little different, but majority of the steps are same. And both, I couldn't show the transposition very good because of the involvement of the nerve. Unfortunately, both had pre-op good function and both had nerve involved.
Yeah.
So, next in coming times, in 2-3 weeks time, I can keep a case with extensive intracranial. Or more than 2 centimeter, and we can do still one stage. In the posterior fossa, all cranial nerves already paralyzed. 9th, 10th, 11th, 7th, everything. Tumor involving the horizontal petrous carotid artery, going in the posterior cranial fossa. All possible extensions are there.
Okay.
So what, boss, it is more than 2 centimeter. It is difficult.
Yeah, I know difficult, but what we have now started doing is putting a good muscle patch to suture all around. See the concern was the CSF leak.
Yes.
And if you can overcome that problem, you can do it. There is no contraindication otherwise.
Okay.
The issue is the CSF leak.
Yeah.
You can certainly avoid one extra stage of surgery.
So excellent demonstration, sir.
Thank you, boss. It's
Wonderful,
always
wonderful.
Thank you so
wonderful
much,
treat
sir.
to
Thank
see
you.
you operate.
I think you've answered all the questions. There has been no much questions
Ultimate,
left
ultimate.
unanswered.
Thank
Thank
you.
you, Dr.
Thank
Parab,
you,
sir.
man.
You always give us the courage to at least do all these difficult cases,
Yes,
attempt these
yes.
difficult cases that we would have never thought otherwise
Thought
doing.
of, yes.
We can do
Satish,
it. We have
we
to
And
be,
really,
after these, we have to understand science a little bit. We can do it. And for this, I have no words to express my thanks to Pachori boss and Paramita.
yes,
It
sir.
is because
Thankful
of them I am here. Thank
Yeah,
you.
yeah.
to
Nothing
Pachori,
like that.
sir.
Nothing like that.
Thankful to Sun Pharma for
Thanks to, big thanks to
cooperating.
Sun Pharma.
Yeah,
Big thanks to Dinesh.
Yes.
And Appa, what a day.
yeah,
yeah,
Thank
you
you,
are.
man. Thank you.
thrilling one, thrilling one.
Thank you. Thank you. I am really thankful to Pankaj boss, Achal boss, and
Yeah, they
Dr.
was.
Panikar,
Yes.
who were so good.
Yes.
Morvani sir, Narayan, everyone, Amit Kesri,
Sandeep
Kapil.
was there.
Kapila, you feel free to come anytime. Your inputs are so valuable.
He has given multiple visas. He can come and multiple entry visas.
Thank you, boss. Thank you so much.
Okay. Let's
Thank you,
go
sir.
Okay.
and take rest.
Thank you. See
Take
you on
rest, sir.
Sunday.
See you
Okay, see
on
you.
Sunday, sir. The timings we will let some doctors are asking about the timing, so I think we will let
I
you
think
all
we'll
know.
announce tomorrow.
Yeah, yeah,
Somewhere.
yeah,
As
Tomorrow we'll
boss,
decide.
whatever
yeah,
boss
yeah,
thinks.
yeah, yeah.
Okay.
Okay.
Good
Okay.
night.
Thank you. Good night.
Bye.
Good
Thank you.
night.
Good night.
Rajiv,
Good night,
Rajiv, Paramita, thank you.
boss. Good night.
Thank you. Thank you
Thank
so
you,
much.
Appa.
Thank you, Appa, sir.
Rajiv, thank you.
Bye.
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 Bye bye.
Parva sir, good night.
Good night.
Good night, Sandeep.
Good night.
Good night.
Good night.